Good morning, everyone. Welcome to the 2022 Toronto Cardiac Tumor Conference. This is our 7th conference in this Toronto Cardiac Tumor Conference. So it's been 7 years since we started, and every year we've done something different. Every year is on the website, so you can go back and look at previous talks. This year's conference is on the diagnostic and treatment strategies for Toronto for primary cardiac tumors. As mentioned, it's the 7th conference on the cardiac tumors. It's an ongoing free online resource for previous meetings with full lectures by world leaders. It has been webcast for the past few years. You can look live on YouTube or Facebook, welcome on both platforms, and online questions are possible. All you have to do is ask questions on the chat line, and we'll be able to get them and answer the questions as you wish. First, I must thank some people. The Peter Munk Cardiac Center is my home hospital, and they've given me great support. We have an endorsement from the Society of Thoracic Surgeons yet again this year. And thank you to all the speakers and to you, the attendees, presently live and those in the future who come to the website to learn more. Finally, and most importantly, to Henry and Barbara Bank. Henry and Barbara Bank are two individuals who've given me the financial support in order to make this possible. They wanted to thank me, and using their money, I've allowed a dream of mine to become reality, and have helped countless people around the world by the interaction we've had with them and by the information brought forth and the friendships and collaborations brought forth by this meeting. So thank you most of all to Henry and Barbara Bank.
Hi, Dr. Cusmano. We can't currently see your slides. Would you just be able to share them?
Oh, no. I don't know how to share it.
Yeah, if you just hit the green button at the bottom of Zoom.
No, I don't see any green button. Oh, I do now.
Okay.
Should I start again?
No, you can continue where you left off.
Share screen. Sorry, everybody. Can you see that?
Not yet. Okay, we can see them if you can just make them full screen, and then you are good to go.
Yeah. Sorry about that. There we go. So this is the Toronto Cardiac Tumor Conference, the Diagnostic and Treatment Strategies for Primary Cardiac Tumors. As I said, it's the 7th conference on cardiac tumors. It's an ongoing free online resource for previous meetings with full lectures by world leaders. So you can go to those free online resources. You can go to the Toronto Cardiac Tumor site, and you can find those resources and use them to your advantage whenever you have a patient who has a problem with one of these tumors. It's webcast live, and I think the webcast is online for a year, but even if you miss that, you can go onto the website and see previous lectures from previous years, including this one. You are able to ask online questions by going onto the chat at the bottom of the image. And again, I'd like to thank Peter Munk Cardiac Center, the Society of Thoracic Surgeons, for their endorsement, all the speakers that have graciously donated their time, and to all of you attendees who make this also possible. The most important person, I think, is Henry and Barbara Bank, who gave me financial support in order to start this 7 years ago and continue to give me the support in order to continue this endeavor. So the problem in general is that tumors of the heart are very, very rare indeed. Some surgeons never see a malignant tumor in their whole career. So the question is, where do physicians go when they have a patient? Where do surgeons go when they have a patient? And finally, where does a patient turn when diagnosed? It's amazing how many people find the Toronto Cardiac Tumor website and email me from all parts of the world and ask questions, where can they go, et cetera, et cetera. So this is a big problem in the world. The vision of the Toronto Cardiac Tumor Conference is to improve the care of people with cardiac tumors. The mission of the conference is to develop a subspecialty of cardiac tumor care and to develop a global network of centers of excellence in the diagnosis, treatment, and care of patients with cardiac tumors. You'll see later on in the conference, we're going to discuss this primarily, and we've started an initiative, and you'll learn more about it again this year. We've spoken about it for 2 years in the past, and we'll learn a little bit more about where we are. That initiative is called the Interact project. It stands for International Registry to Assess Cardiac Tumours. This is going to be a global network of individuals, right from primary care all the way up to the super specialist hospitals, so that we can get information from around the world, gather information around the world, and learn even more than we know now. We're also going to have, as a second part in the afternoon, a number of cardiac tumor cases. These are real-life cases. They're meant to illustrate the difficulties in the diagnosis, planning, and the treatment of patients with cardiac tumors with these very complicated, sometimes very complicated cases. We have an international panel to illustrate that a collaborative approach is possible and to demonstrate the advantage of an international collaboration in cardiac tumors. And finally, it demonstrates the reasoning behind the Interact project. You will be able to see that by having people from around the world discuss cases, we can come to a realization that maybe there's one way that may be a little bit better, and there are things that we're lacking so that we can help ourselves to explore through the Interact project new endeavors in the future. The objectives this year are to describe the difficulties in organizing an international registry, describe the challenges in unifying continents in the development of such a registry, list the steps in the diagnosis and treatment of complex cardiac tumors, as well as simple ones, but complex ones are harder to get the steps for. And finally, to describe the treatment options for patients with complex cardiac tumors. You'll see that in the case presentations. The goals this year, therefore, are to improve knowledge about an international cardiac tumor registry and to learn about the workup of a patient with a complex cardiac tumor. We have, as I said, an international faculty this year. After my first lecture, we're going to meet from Bridget Ann Kerwin from Switzerland. She's a very, very interesting person. I'm sure you'll agree with me after you listen to her talk. Dr. Oussama Hamza is from Egypt. He's heading the African spearhead for the Interact trial. Chiara Lastuzzi is from Italy. She's a cardiologist, very interested in radiotherapy and treatment from cardiac tumors. She's the cardiology lead for Europe for the Interact trial. Federico Navaria is from Italy. He's a radiation oncologist, and he's going to speak to us about a complex, very interesting case. Dr. Robin Jones is the oncology lead for Europe. He's from the United Kingdom. Michael Reardon is from the United States. He's the co-principal for the Interact trial. Juan Umama is a cardiac surgeon from Colombia, South America, and he's the South American lead for the Interact trial. Andrew Newcomb, another cardiac surgeon from Australia, is the lead for the Australia portion of the Interact trial. And Albiruni Razak is an oncologist here, and he's the co-chair of the conference. So without much ado, we're going to continue with the Cardiac Tumor Conference. Please feel free to ask any questions through the chat line. Thanks for telling me that the slides weren't on. That was a little bit of a mishap. Hopefully it will be better from now on. So I'm going to start with the first talk. And I may go a little bit over time, so I'm happy to start a little bit sooner than I would otherwise have. I'm going to talk to you today about cardiac tumors and what's known and what's unknown in the world of cardiac tumors. Now you have to hold on to your seats, because this is going to be an overall lecture, right from benign tumors all the way to malignant tumors, what's new and what's unknown. And hopefully after listening to this, you'll realize that although we thought we knew something about some tumors, we actually know a little bit less than what we thought. And I'll show you why a international database is really important. The objectives of this lecture are to understand the current knowledge regarding benign and malignant tumors, describe the potential reasons for recurrence after myxoma operations, because they do recur, list the most common cardiac tumors in the pediatric age group. We'll have a lengthy discussion about that, and describe the shortcomings of malignant cardiac tumor treatments. And finally, as I said, understand the reasoning behind the INTERACT project. If you go back to all the lectures from the previous years, you'll realize that although we have world experts, there are some unanswered questions, and hopefully the INTERACT project will bring some of these questions a little bit closer to a reality. We will explore during this talk of myxomas, fibroelastomas, pediatric tumors, and malignant tumors, and we'll touch on whether minimally invasive approaches are important or recommended for cardiac tumors. First, let's start off with myxoma. Myxomas are the most commonly resected cardiac masses. You can see here how much more commonly myxomas are resected than any of the other tumors. Quite a lot more. It really is outstanding in terms of the number of operations performed for myxomas. For the malignant lesions, there are malignant lesions, and the most common malignant lesion to be resected is a sarcoma. This is a typical paper from China of 212 patients over a 16-year period. You can see there they resected 180 myxomas, and you can see it's by far and away the most common tumor they resected. With respect to the location, the left atrium, as expected, is the most common, with the right atrium and then ventricular chambers much less so common. Myxomas occur in all age groups, and you can see here 10 to 19-year-olds, there are myxomas. As a matter of fact, they start at less than 10 years of age, and they vary throughout the life of an individual. The female gender is more commonly afflicted by this lesion, and this is for an unknown reason. But they are tumors that span the whole life of an individual. Once resected, however, the lifespan of an individual equals that of a normal population. So just because you have a myxoma does not mean that your life is shortened. This is another paper spanning 56 years and 194 patients that were collected in those 56 years of myxomas. Some myxomas present as emboli, most commonly cerebral emboli. So neurologic events are sometimes the initial presentation of a myxoma, and it happens between 20 and 30%. This group, again from China, examined 162 myxomas over a 16-year period, and they found that 20% of their patients presented with an embolus. They tried to get some information as to what was it about these myxomas that made them different from the rest. And they tried a multivariate analysis of the retrospective data that they used. So you can see there are problems here. There are small numbers and the retrospective data. And they found 4 different values that they felt was representative of those patients who presented with embolization. They had a high platelet count, a greater mean platelet volume, an irregular shape to the tumor, and an abnormal location. So these are the risk factors. Now, a platelet count greater than 300 is reasonable. A mean platelet count, they didn't give numbers or anything like that, but remember they had small numbers. So they tried to, but again, with small numbers, make a diagnosis, and make a treatment strategy for those people. Let's talk a little about minimally invasive operation and recurrence. Are they related? There are many papers of minimally invasive approaches for left atrial myxoma, for benign lesions, but they're all small papers. And they all talk about benign disease, and they all talk about myxomas. I'm going to talk about one of these just to choose one out of very, very many. And these people looked at 30 patients over a span of 11 years, and they used shave of the myocardium or the base of the stalk. Now, I don't quite know what that means. Shave myocardium, I can understand it. And this is either at the base of the stalk where they took a scissors and cut the stalk off and left the base of the stalk attached, or they took a piece of myocardium along with the mass. It's hard to determine from these papers what exactly people do. They had 1 out of their 30 patients who had a recurrence at 24 months. This is obviously not the optimal outcome of a person, and you might blame the video assisted in the minimally invasive part, and they couldn't see very much. Perhaps they cut the base of the stalk and left the tumor there, so they didn't completely resect it. They may not have done a cancer operation. Open surgery must be better, you'd think. Here's a paper from the Mayo Clinic group. They found 194 patients in the 56 years, and these are their locations. The left atrium, as mentioned, was the most common. They found a few more in the right atrium and some in the ventricles. So whether the numbers are bigger or smaller, the ratio always is more or less the same, most in the left atrium and then in the right atrium. Their average tumor size was 4 by 3 by 2 centimeters in size. And you can see some of the reasonings for operation on these individuals. Now, in their paper, they mentioned that they cut the base of the stalk or they used an endocardial button. And when the tumor came from the intraatrial septum, they took a portion of the intraatrial septum as well. Unfortunately, it's a little bit hard to understand exactly how they took the tumors and when they did. But you have to remember, this is over a 56-year period. Coronary bypass has changed over a 56-year period. I think probably most operations in the world, including hernia operations, bowel resections, breast operations, have changed quite a lot in the last 56 years. So it's not surprising that cardiac procedures have changed as well. But you have to take this into consideration when you think about recurrence risk. So what was their recurrence risk? Well, they had 13 out of the 194 people that recurred. Interestingly, 9 out of those 13 recurred in the same location. And you can see the time. Now, they had a recurrence in a 12-year-old after only 1.2 years. And they had a recurrence in a 45-year-old after 26.6 years. So it's quite a long variation in terms of the recurrence risk. And there may be a difference in terms of the ages. This goes in an ascending order for ages. So they had 13 of theirs recurred, but when they recurred, they were in exactly the same location. If you remove the Carney's complex, now Carney's complex is a genetically predisposing condition to Mixomas. When you remove those, because you expect them perhaps to have a recurrence, they found that 9 out of their 11 non-Carney's patients recurred in exactly the same location. Interestingly, if you look at the recurrence risk, you would have expected that a Carney's patient would recur fairly quickly, but in this particular case, one of them took 8.8 years. Interestingly, the 12-year-old at the very top had a small tumor to start, and within 1 year, it had grown to 5.6 by 2.6 centimeters, quite a lot larger than actually the initial one. So they didn't tell us, because it probably was very hard to find, whether these were shaved or cut at the stalk, but it begs the question of whether or not there's a margin problem. When they looked at their univariate model predicting freedom from recurrence, and they couldn't do a multivariate because they didn't have enough patients at 194 patients, again, over 56 years, they found that young people recurred more often. When they had a tumor in the ventricle, it recurred more often. The smaller tumors, believe it or not, recurred more often. And for some reason, men recurred more often, but resection with the endocardial button was also a risk factor. So again, I could not understand from reading their paper. Perhaps if somebody reads it, they'll be able to understand better than I. But this begs to the question of whether or not it is a margin issue that caused the problem, especially when you look at something like the ventricle, where it has 7 times the hazard ratio, and the endocardial button has 4.9. The other ones you may say are pretty close to 1. It may be an error in terms of small numbers, but the other two clearly are quite interesting. Some people, and you'll see this in some papers, especially with the minimally invasive portions, minimally invasive operations, ablate the base of the tumor margin, the base of the tumor bed. And they do this to try to prevent recurrence. And in this particular case, the authors have used cryoablation. So when authors are talking about cryoablating the tumor bed without much in terms of examination or discussion about why it's happening, you have to wonder whether they've just plucked the tumor off of the heart and left the tumor bed there with viable tumor on its base. So when you're talking about that sort of things, you have to wonder whether or not they're doing the proper tumor operation. So recurrence happens at 0 to 6%, and it may be very late, but it's often in the same location. And we have to wonder whether it's related to resection margin more than the method of operation. I don't necessarily think that the minimally invasive portion is perhaps worse than the open operation, as long as they do the proper tumor operation. Now, you've noticed that the large series are only 200 or even less than 200, and this may take many, many years. And multivariate analysis is difficult because the multivariate predictors are hard to determine due to the small numbers. So it's hard to make a multivariate analysis when you only have 150 or 160 or even 200 patients. You need many, many more than that to make a diagnosis. Those are some concepts, but one of the other things that we have to concern ourselves with, oh, it's not working, that's unfortunate, is what is the actual tumor that you're going after. I don't know why this is not working, but it's not. But this would have shown you one sort of solid kind of tumor, and this one has some openings inside of the tumor itself. And when you're going to do a minimally invasive operation, you have to try to determine whether or not this is a malignancy. And remember, the cardiac tumor resections for minimally invasive all mention either myxoma or they mention benign disease. The problem sometimes is trying to figure out whether this is a benign or malignant lesion. These particular ones, the top one happens to be in the right chamber. So it's an unusual tumor. And one of my edicts is always a myxoma in an abnormal location may not be a myxoma. So you have to be careful. And the question is whether you do this minimally invasively or not. So you really have to have a diagnosis. Here's a patient. What kind of tumor is this? They've decided to do this minimally invasively, and they found this particular kind of tumor. Now, I don't see a resection margin unless this happens to be the resection margin here. It's hard to determine because they haven't shown the whole thing, but they've shown the fact that the tumor is quite large compared to the opening. And my question is, what should be done sometimes is not what can be done. What should be done versus what can be done sometimes turns into what can be done, not what should be done. And that's where we have to be a little bit careful, because once you've made the resection, you've made the resection. And if you get the diagnosis wrong, the person suffers because they had a minimally invasive operation. Even if you get the diagnosis correct, you may predispose the person to recurrence. Remember, most of them recur in the same spot because the tumor portion of the operation doesn't meet the tumor resection requirements, and that is of an adequate margin. Unfortunately, for myxomas, we don't know what the adequate margin is, whether it's 0.5 millimeter, 2 millimeters, 3 millimeters, we really don't know. I suspect it's very small. So let's move on now to fibroelastoma. I hope this works this time, and it doesn't. It doesn't. This was the same paper, and it showed two different lesions, and the both were fibroelastomas, even though they look like myxomas or perhaps something more solid. This will not play either. I'm sorry about that. I don't know why. This shows a fibroelastoma on the aortic valve, but you can see on this aortic valve in a 3D reconstruction, there are lesions in all three cusps. Now, this particular person I've been following for over 10 years, and this particular individual has refused to have an operation because he or she feels well and wonders whether they will have benefit from this. They also are afraid of losing their valve and don't want a biological valve. Those were our only two slides that had video, so hopefully it's going to be fine from now on. Now, there are a few large series. This particular series is a series of 725 cases. It is the biggest series in the world. However, it's a meta-analysis of multiple smaller papers. 209 patients were diagnosed at autopsy. So this is a combination of clinical and autopsy-related patients. Only 9 patients were found at cardiac surgery. 120 patients had a stroke, and 77 patients presented with angina or a myocardial infarction, for a total of 11% of the overall group. So therefore, there was potentially a 27% embolization risk compared to about 20 or 30% risk for a myxoma. So they're about the same risk of embolization as a myxoma as a presenting feature. In 517 patients, the sex was unknown, not known. As you can see here, fibroelastomas occur in all age groups. Here's less than 10 years of age. And as expected, as a person gets older, they are more common. The most common valves are the aortic valve, the mitral valve, tricuspid valve, and the pulmonary valve. In other words, the valves of the heart. But a percentage of them, and a good percentage of them, are non-valvular, usually found in the ventricles or the atria. This is another paper looking at fibroelastomas. They found the valves were in 77%, with the most common being the aortic, followed by the mitral valve. And on the aortic valve, 2 or more cusps, just like in my patient that I've been following for so many years, have 2 or more cusps involved. So the most common thing is not to have a single fibroelastoma, but multiple fibroelastomas. The cardiac chambers in this particular paper were affected in 30 patients. This was a surgical series, not an echocardiographic series. The most common chamber that they resected was inside the ventricle on the left side. So when should an operation be offered for these individuals? When should you operate on a person who has a fibroelastoma? This was discussed in a paper from the Mayo Clinic. Over a 15-year period, they amassed 511 patients. How did they find the patients? They went through 575,000 echoes to find 511 patients for a rate of less than 0.1%. I can imagine the person looking through 575,000 echoes, and hopefully they had some AI helping them with respect to getting the diagnosis. Anyway, they broke it up into 2 groups. The first group had an operation, 185 of them had an operation, and this is, as far as I could see, the biggest series of operated fibroelastomas in the literature. And the second group were people who didn't have an operation. Now, it was a poorly defined group in the paper, but for one reason or another, they did not have an operation, but they were able to find out what they did and were able to follow them in the long term. Back in group 1, those people who had an operation, there were 2 types of operations that were performed. One was where the fibroelastoma was the primary indication for the operation. That was about half of the group. And the second one was the fibroelastoma was removed at another cardiac operation. So in other words, it was an incidental finding. The patient had an operation for another procedure, and while they were in there, they removed the fibroelastoma. Again, about half of them. If you remember before, in the first series I showed you, the group of individuals that had found it operation, that was the 725 patients, was only 9 out of the 725 patients. So this group, again, it's a surgical group, not an overall group, including pathology specimens, showed quite a bigger number of patients who had a fibroelastoma that resected at the time of another cardiac procedure. They found that there were different reasons for operating on them. Nobody had a risk factor for stroke, but neurologic events were overwhelmingly the number, about half of them in the first group. In other words, the group that had as a primary indication the fibroelastoma. They had less people who were symptomatic and less people had chest pain, as you'd expect. Now, the chest pain may be coronary disease, but the group 1A, those 94 patients, did not have any coronary bypass. The only thing that they had was the fibroelastoma in their heart. If they had another reason for going in, they were in group 1B. In other words, those people that they had the fibroelastoma resected as a secondary, not as a primary reason for having the operation. So perhaps this chest pain was intermittent occlusion of the coronary ostium. Perhaps it was microemboli into the coronary arteries. It's hard to determine, but the primary reason for the person in group 1A to have an operation was neurologic events. Systemic emboli occur occasionally, but not very often, and syncope is equal in both groups. Were the size of the tumors different for those people who had a stroke or a neurologic event, not necessarily a stroke, for those people who had a neurologic event compared to those who didn't? Well, the answer is no. Whether you were in group 1, in other words, you had an operation, or whether you were in group 2, the size of the tumors was the same whether they had a neurologic event or not. So the size of the the size of the tumor did not predict neurological events either preoperatively in those people who had an operation or subsequently in those people who were found to have a fibroelastoma. This shows the size of the fibroelastoma in their operated patients. The aortic and mitral, you saw smaller tumors than the tricuspid, pulmonary, and the right side. However, the non-valvular left-sided tumors were bigger than the aortic and mitral lesions. So we find that the left-sided lesions had operations on smaller tumors. Remember, these are patients that were selected for an operation. However, it did not select these, and they did not in the paper determine whether or not the tumors in those who had a primary reason for resection were any different in size than those who had an operation for another reason. In this particular group of these 511 operated patients, and 59% were on the aortic. Again, these are in groups 1 and 2 combined. Mitral was 13, tricuspid was 4, pulmonic was 4, and the myocardium was 22%. 23% of the overall group had valve problems, but only 1 was related to the papillary fibroelastoma. So papillary fibroelastoma does not cause valvular disease. If it does, it's very rare. You can see the size of the non-valvular right tumors was 22 millimeters compared to 8 millimeters in the aortic valves. And even on the pulmonic valve is twice as large. Once you have a papillary fibroelastoma diagnosed, you have recurrent neurologic events later on. Well, there's an interesting answer to this. It depends on what your comorbid conditions are. If you were in group 1A, the 5-year follow-up and 1-year follow-up was equal to the expected numbers. So the answer is if you have a fibroelastoma resected as the primary reason for having your operations, the subsequent stroke risk is very, very low. And really it was equal to the expected stroke risk for a general population. However, if you had a cardiac operation, in other words, another comorbid cardiac indication for an operation, then your stroke risk was higher than the expected. The observed was 8 strokes and the expected was 2.4, giving a statistically increased risk of stroke in those patients who had an operation for some other reason and a myxoma was removed at the same time. Now, it doesn't say what the cause of the stroke was, but presumably the people would have had higher risk factors for stroke in their group themselves. The group 2 patients, the ones who were observed, and again, we don't know why they were observed, they also had a higher than expected. They expected 8.4 and they found to have 29. So if you have comorbid conditions, chances are you're going to have an increased risk of stroke. But if the only reason for having your procedure is the fibroelastoma, then you've reduced the risk of stroke perhaps, because remember, half of those had strokes and half did not, but you've probably reduced the risk of stroke in the future in those patients. They looked at their 5-year neurologic event rate in those people who had warfarin, aspirin, or nothing, and they found that there was absolutely no difference in the number of future strokes related to anticoagulation. And in other words, the warfarin and the aspirin did nothing in terms of preventing stroke compared to no treatment at all. So it seems as though there's no effect by anticoagulation, although people are very commonly anticoagulated. So the fibroelastoma category, the male group suggests that an operation be performed for all left-sided lesions, regardless of size, due to the excellent surgical results. Again, especially if it's a primary indication for the procedure. If it's a secondary indication procedure, as with every secondary indication for a cardiac surgery, if it's there, you should remove it. But as a primary cause, you should remove it because there are excellent surgical results. A very low valve replacement risk. I didn't talk about it, but they recommend to shave it off unless there are too many to shave off, in which case the valve should be changed. And there's a lower long-term stroke risk. They think presumably because you've removed the stroke. Remember, half of those people presented with a stroke, and theoretically, half of them would have a stroke in the future. No randomized trial has been performed. I don't know whether one would. Anticoagulation did not prevent neurological events. And the question is when to intervene on the right-sided lesions. Remember, we saw a 2-centimeter lesion on the right side. If you see a 1 centimeter, do you watch it, let it grow? What it is, what to do. I suspect it's related to the comorbid condition of the patients and how small or how obstructive it is. Remember, fibroblastomas rarely cause abnormalities of the valves. Let's talk about the pediatric age group. Not too many people know about pediatric cardiac tumors. Here's a paper, again out of China, showing a number of patients. This was presented in 2017, 166 pediatric tumors, a very large paper. And they found that the most common tumors were rhabdomyoma, fibroma, and there's our friend Mixoma, or perhaps enemy. They did find a scattering of malignant tumors, either primary or metastatic. But I wanted to point out that the age of these individuals vary based on what the pathology is. Rhabdomyomas occur at the median age of 4 months. Fibromas, median age of 9 months, in other words, infants. And myxomas are higher level. They're 10 years of age was the median age. Mortality did occur in the infants, mostly in the did occur in pediatric age group, mostly in the infants, usually related to congestive heart failure or recurrent arrhythmias. The mortality that occurred in the primary malignancy group was obviously late, but the postoperative mortality was there for the early group, and once they passed the perioperative period, the mortality rate was very low. Sometimes these tumors prevent flow through the valve. They perform echoes in these people, and many times for these infants, they find it in a prenatal echo or ultrasound. And the age at the postnatal diagnosis for those patients in whom an obstruction to cardiac flow is present is only 4 days. And it makes sense because if a child has a large tumor in the heart that's obstructing the outflow tract, they're going to present it very, very early, compared to those who do not have an outflow tract, where the presentation was at 75 days. So it's either at 1 week or 2 or 3 months if there's a tumor in infancy. As I mentioned before, most of these patients had rhabdomyomas, and rhabdomyomas are associated a little bit more often with obstruction, but even the non-obstructive type is very frequent. There's documented diagnosis of tubular sclerosis. Tuberous sclerosis is a genetic defect predisposing to multiple tumors throughout the body. So many of these babies and children are diagnosed with tubular sclerosis, either in themselves or a family history. That's pretty prevalent when you talk about pediatric tumors and review the literature on them. The gradient, again, is dependent on where the tumor is. Those people who have a high gradient tend to have tumors that affect the chambers themselves, either one side or both sides. If the low gradient is there, you can be pretty sure that the tumor involves the interventricular septum. So the interventricular septum lesions tend not to have a gradient, and the free wall tumors or the interchamber tumors that are not affecting the interventricular septum tend to be associated with a high gradient. What's the strategy for long-term outcome? Well, operations are undertaken for symptoms, obstruction, or arrhythmias. This is from a paper over a period of 37 years and discussed only 47 patients. So a little bit more than 1 patient per year, but through this, they were able to make these recommendations. Operations are undertaken for symptoms, obstruction, and arrhythmias. Arrhythmias are most commonly related to fibromas. Mixomas in the infants or children are equally on the left and right side. Remember from the early slides in Mixoma, the Mixomas in the adults are overwhelmingly found in the left side. In the pediatric age group, they're equal on both left and right sides. Deaths occurred in the infants, usually from severe left ventricular failure or recurrent ventricular arrhythmias. And when it does occur, it occurs in the perioperative period. Interestingly, unlike the adult or the malignant tumors, there was no progression of the partly resected tumors. So if you go in for a tumor of a child and you can only resect some of the fibroma, is it worthwhile? Well, the answer is yes, because there was no progression of the partly resected tumors. And in fact, regression of rhabdomyomas occurred over a 4-year period. And so there is some regression of some of these tumors, specifically the rhabdomyomas. Now, I don't know whether it's a regression of the tumor or whether or not the tumor stays the same size, but the heart grows, so it apparently looks as though it's regressed. But certainly the rhabdomyomas are a group of individuals that if they don't cause obstruction, they may be watched. Again, I have to comment the fact that it took a long time and the numbers are really quite small. This is a large group of 28 studies. This is a meta-analysis again, it's 745 pediatric tumors, and it shows what we were just talking about. Rhabdomyomas and fibromas and perhaps teratomas occur in the very young, and very young means a fetal or less than a year of age. And as you get older, it's hard to call a 10-year-old old, but they get more of the adult tumors, the mixomas and the malignant tumors. The risk of tumor recurrence is very low in the benign tumors. Remember, I said that the rhabdomyomas, although they can recur, they sometimes regress. Fibromas can recur, but very infrequently. Teratomas and mixomas. There's that number there, 4.9% mixoma recurrence, roughly equal or not out of keeping with those in the adults. Malignant tumors, as expected, do recur, but not nearly as often as they do in adults. The malignant tumors, let's look at that a little bit. The malignant tumor in a child has a better outcome than the malignant tumor in the adult. Green is the adults and blue is in the children. And the question is, why is that? Well, when you look at the type of tumors, they're dealing with some sarcomas, a rhabdomyosarcoma. They deal with teratoma, Wilms tumors, and pleuropulmonary blastoma in this particular series. So the tumors they have are a little bit different. In the adults, it's mostly a sarcoma, you'll see later on. But in the children, they have different tumors. So perhaps you would expect a different behavior and a different long-term outcome of those tumors. That's a good segue into the malignant cardiac tumor group. Malignant primary cardiac sarcoma is a bad animal. This is a paper looking at 26,000 individuals who had a sarcoma, soft tissue sarcoma or non-cardiac sarcoma, compared to patients who had a primary cardiac sarcoma, isolated primary cardiac sarcoma. They found 210 patients with a primary cardiac sarcoma, and they compared them to 24,000 non-cardiac sarcomas. And they found the median survival of the surgical group was only 6 months, and the median survival for all comers of the non-cardiac sarcomas was 93 months. So non-cardiac sarcoma is bad, but cardiac sarcoma is horrific. If we operate on these individuals, we can improve their survival from 1 month for no operation, the person who gets no operation, a median survival of 1 month with a non-surgically treated cardiac sarcoma is 1 month versus 12 months if they operate. So even with an operation, the outcome is not good, but can you make it better? Well, when you talk about cancer surgery, if there are any cancer surgeons, you can correct me if I'm wrong, but we talk about residual tumor. Residual tumor is either R0, R1, or R2. R0 means there's no microscopic tumor left behind. In other words, it's completely gone. R1 means that your resection margin was positive, but in a non-visual way. It was microscopically positive. R2 means you left gross visible tumor behind. And this particular series, again, not very big, 29 patients in a long time period, showed if you had an R1 or an R2 resection, in other words, microscopic or gross tumor left behind, the outcome was much, much worse than if you had an R0 resection. In other words, I quote, got it all out with no microscopic disease. So there's a big difference between the outcome of leaving even microscopic disease versus removing it all. Here's a perfect example of a malignant tumor. This patient presented to us, previous osteosarcoma many, many years before, presented with hypotension. and had a large obstructing tumor of the right ventricle. This person had to go to the operation. We did a debulking operation. I'll talk about that. That debulking means leave residual tumor. This patient underwent an R2 resection, perhaps an R1 resection, but at least an R1 resection, because there's no way in the world you're going to get microscopic clearance on a tumor of this sort at an emergency operation. So this patient had an operation. Once the person recovered, we did a pre-discharge MRI prior to chemotherapy, and we found this: 16 days, less, a little bit more than 2 weeks after the operation, the patient had at least half of the right ventricle full of tumor once again. 16 days. So left to themselves, without any adjuvant therapy, without any subsequent chemotherapy, a person who you leave residual tumor behind will die before the sternum is healed. That's a powerful statement, but unfortunately it's a true statement. And I'd read about it, and I never realized how true that is until I had this patient that I operated on. Now, I knew this person had residual tumor left behind. You can see my scissors in the bottom picture with tumor on the scissors. So there was residual tumor left behind. That's an R2 resection. But within the short time period, the tumor had almost completely recovered to where it was before we actually started. This is a paper of 551 individuals over a 40-year period, a little bit more than 40 years actually. And this is from the SEER database. There's no chemotherapy information apparently in the SEER database, I found out. There may not be any radiotherapy information on the SEER database as well. The SEER database is a registry of malignancies in the United States. They had 7.4 million total cancer cases recorded from 1973 to 2011 on this database. They found 551 cardiac tumors. Remember I said at the beginning, the problem with cardiac tumors is that they're very rare, and this shows how rare they are. They found, as we already said in some of the people, that cardiac tumors, malignant cardiac tumors, occur in all age groups. Here it shows they even have less than 4. So it shows in all age groups. Sure, it's more common in the more advanced ages. Advanced ages means 20, I'm sorry to say, for all the residents that are watching, but it affects everybody in all age groups. What are the most common types of tumors that they found? Well, the 3 most common are sarcoma, lymphoma, and mesothelioma. Mesothelioma are less common. I've been dealing with cardiac tumors for many, many years, and I've actually never seen a mesothelioma of the heart. There are sides. Tumors do take sides. If you look at the angiosarcoma group, the vast majority are in the right heart, often in the right atrium. The intimal sarcomas are left-sided tumors, and the undifferentiated sarcomas are somewhere in between. They're undifferentiated because they're advanced in their course, or we don't quite understand how to classify them. A little bit more about that later. But they do take sides. Right-sided are often angiosarcoma, and the left-sided are often either undifferentiated or intimal sarcomas. This is a paper from the French sarcoma group. They were early presenters of their data. This was from 2014. There's another large series by them. And they took a group of patients from 1977 to 2010. So again, a very long time period. In that very long time period, they found 124 patients. So that's roughly 4 patients a year into that group in all of France. Obviously underreported because there has to be more than 4 people who come with a cardiac tumor every year in a country as large as France, but this is what we have to work with. They found the sides. The tumors did take sides. Here, the angiosarcomas represented 80% of the right-sided tumors, or sorry, 80% of the angiosarcomas were on the right side. The leiomyosarcomas, or the poorly differentiated sarcomas, and other sarcomas were on the left side primarily. 20% of the people presented to them with already metastatic disease, and metastatic disease affected the lungs in 37%, the liver in 29%, and the bone in 29%, as well as a smaller portion, but a significant portion found in the brain. When you're working somebody up with a sarcoma of the heart, you think it's a sarcoma of the heart, always look at the brain. because it affects the brain more commonly than people think that it does. Even if it's not supposed to go to the brain because it's a right-sided tumor, why should it go to the brain? Always check the brain when you're working a person up. Of those 80% who presented as isolated cardiac tumors, eventual metastatic disease occurred in the lungs most often and in the brain second. So the brain is a player, unfortunately, in sarcomas of the heart or malignant cardiac tumors of the heart. When it did recur, when it didn't metastasize, it happened in an average of about 11 months later in those other lesions, in those other areas. And if it was a local recurrence, again, it happened roughly at the same time at 10 months. This is a busy slide, but I'll go through it. There were those patients who had non-metastatic disease at the time of diagnosis, 100 of them, and 24 of them had metastatic disease. R0 resection, in other words, they were able to get the whole thing out without microscopic disease left behind, is only 10 of the 100 patients, so 10%. And they had an unknown number in 14%, but most of them had either an R1 microscopic resection positive or R2 gross tumor left behind. Interestingly, in their series, they had 5 patients who had transplantation, and I found quite interesting that they transplanted somebody who had already metastatic disease at the time of the diagnosis. Most people had combination chemotherapy, but if you had metastatic disease, it was more likely that you had monotherapy for your chemotherapy as well. Surgery and chemotherapy or chemotherapy alone were the most common treatments. And if you had metastatic disease, a multimodality therapy, including surgery and radiotherapy, chemotherapy and radiotherapy, or surgery, and the 3 were not performed in that group of individuals. Let's stop back and look at those transplants. They had 5 people. This is another group of individuals who looked at a bigger number of people. They reported their series, again, out of China in 2016, and they looked at their survival of the patients that they transplanted. In total, they had 30 people who survived, and they had a good series of people they did transplants on. Now, they looked at the chemotherapy effect, and the chemotherapy effect showed if they had neoadjuvant chemotherapy, there was no effect in terms of the survival. This is not the number of people. This is the average survival. There's the number there, 18 and 11, 34 and 27. But the average number of people that survived, the average lifespan, whether they had neoadjuvant chemotherapy or adjuvant chemotherapy, in other words, had the chemotherapy and then had their transplant, or had their transplant and then had chemotherapy, there was no difference in the outcome of those individuals compared to those who did not have chemotherapy. So there was no chemotherapy effect. When you look at angiosarcoma, those right-sided tumors, whether you had a transplant or whether you had no transplant, there was absolutely no difference in survival for a person who had a transplant compared to those who did not have a transplant if your diagnosis was angiosarcoma. If you had a non-angiosarcoma diagnosis, the survival was better than those angiosarcomas, but much worse than the standard transplant survival. So transplant for angiosarcoma, it will not work at all. Transplant for a non-angiosarcoma may have an effect, but not nearly as good of an effect as if the person didn't have a cancer. This is a paper where they looked at 442 patients, again, over 42 years using the SEER database. So about 10 patients per year in this database. And they broke it up into an early time and a late time to see whether or not from 1973 to 2005, whether the outcome for treatment for sarcoma changed. And the answer is no, it didn't change at all. There was no difference, no advances in the surgery or treatment for angiosarcoma between these 2 time periods occurred. They looked at the group, that was overall, they looked at the group to see whether or not operations made a difference for this, and in fact, they did make a difference. Remember, the overall survival was no difference in the early and late time period. However, if you broke it down as to whether the patients received an operation or not, there was a benefit that probably went away by 2 or 3 years. If you added some form of treatment, in this particular case, chemotherapy, again, this doesn't tell us whether or not the chemotherapy happened before or afterwards, and chemotherapy apparently in the SEERS database is poorly represented or poorly followed. But if you added some chemotherapy to this individual, you do improve their early but not late survival. Again, the benefit happens to stop at around 2 years. Another paper looking at 617 patients in a 14-year period presented to this year, or not this year, 2021, showed that if you had any therapy, chemotherapy, radiotherapy, the combination of etc., it again added to your early survival over the first 2 years, but then it equaled after that. So it has an early signal, but no late signal. The first slide on the left shows the very poor outcome if there's no treatment and if there's non-surgical treatment. In other words, isolated radiotherapy or isolated chemotherapy has a benefit over nothing, but the best long-term outcome is with an operation, and even better than that is an operation associated with one form of therapy. Still a very poor outcome. Still, there's a long-term equalization of all patients, whether they've had adjunct therapy or even any therapy. So can we improve upon these outcomes? What can we do to get these outcomes better? Because certainly they're not very good. Well, if you find a tumor by accident that's less than 3 centimeters, you're lucky because the outcome is better. Again, not very good, but it's better. So if you could turn back the clock and regress the tumor, then we can get a better outcome. Perhaps if you give chemotherapy or radiotherapy before and get the tumor smaller, you may have a better outcome. But clearly, the inflection point seems to be around 3 centimeters. A lot of these articles talk about different clinical factors that affect survival. And in this particular paper of the 442 patients, incidentally, they included 27 patients less than 20 years of age. They found that surgery or chemotherapy, or possibly the combination of the two, improved survival. They also found, as we spoke about earlier, that younger age is a better outcome. They did find this in people operated less than 45 years of age versus greater than 45 years of age. And it may be related to comorbid conditions of the individual, but it may also be reflected in that this particular paper, for instance, had a number of people who are less than 20 years of age, and the diagnoses in those younger people may be different, and they may have a different behavior. But let's look at surgery and chemotherapy as well. Dr. Reardon, he's part of this seminar or conference. He and his group have been instrumental in pushing the field of cardiac tumor treatments throughout the world. They're a very, very strong group. I think they're the #1 group in the world for cardiac tumor treatment and diagnosis. They early on in 2009 reported on a series of 27 patients, and they noticed one thing. They noticed 2 things. One, 2 out of 8 left-sided tumors, they looked at tumors whether they're the right and the left-sided. 2 out of the 8 had an R0, sorry, there should be R0. 2 out of the 8 had an R0 resection, but 13 of 19 right-sided tumors had an R0. And they found that R0 patients live longer. So what they found is it's more common to get an R0, or in other words, complete resection on the right side than it is on the left side. And they also found that the R0 patients live longer. That was in 2009, and that was 27 patients. And this is when they used the combination of surgery and chemotherapy and radiotherapy, all the things that they had available to them. They found the right-sided tumors were more likely to have an R0 resection. The French sarcoma group found the same sort of thing. The median survival for an R0 patient was 38 months, but for an R1 or an R2 was 18 months. Remember, the R1 and the R2 may be exactly the same. There aren't too many articles in the paper that we can find that show there's a difference between R1 and R2 survival. Transplanted patients in their French sarcoma group had a median survival of 27 months. Very little was discussed about the transplanted patients and diagnosis, et cetera, but they seem to have an intermediate survival. Dr. Reardon's group, again, examined some patients. Subsequently, in 2017, they reported on 44 patients of right-sided sarcomas treated by neoadjuvant chemotherapy in 32 patients and non-neoadjuvant therapy in the remaining 12 patients. And what they were able to find is the neoadjuvant versus no therapy had a slight improvement in survival. Survival for those who did not have neoadjuvant chemotherapy was 9.5 months versus those who had the neoadjuvant therapy was 20 months. But what they found as well is they confirmed that the R0 resection, as all the studies have shown, is a great thing. They found that they had an improved median survival from 9 months without with an R1 or an R2, and they found a survival of 53 months for those who had an R0. This was significantly positive. They found when a person had neoadjuvant chemotherapy, R0 was achieved in 47% versus only 33% when no adjuvant chemotherapy was given. And that led them to suggest that we should give neoadjuvant therapy to all patients who come with a cardiac sarcoma. And I think this paper is a landmark paper in moving treatment towards that. So what's the rationale for neoadjuvant therapy? Perhaps it gives more R0 resections. Now, it may be a little bit false to say that. Dr. Reardon, if he's listening, I'm happy to hear your comments about this. But this may not necessarily be that neoadjuvant chemotherapy is allowing more R0 resections. It may be center or surgical experience or aggressiveness. In other words, those centers that go to the trouble of getting a preoperative diagnosis, giving the person neoadjuvant chemotherapy, they probably are a more experienced center and they have more aggressive surgeons who are able to do this more often and therefore have a bigger experience. That may be one reason, but it may also pre-select those with aggressive disease. In other words, you have a person, you take a biopsy of their cardiac tumor, you give them neoadjuvant therapy, but during the neoadjuvant therapy, they develop metastatic disease, or the primary tumor grows, or the metastatic tumor grows, something grows, and they never come to surgery. So the outcome is better, not because it caused more R0 resections, because it eliminated those people who should never come to an operation. So it's hard to say whether neoadjuvant chemotherapy is useful or not. Unfortunately, they're small numbers. Remember, Dr. Reardon's paper, and whom we used to recommend neoadjuvant therapy, only had 44 patients over a number of years. Well, let's look at something else. Let's look at the diagnosis. This is a paper examining the diagnosis and what we use for diagnosis. The most common thing you'll get when you get a biopsy is histology. We send a piece off to the pathologist and we wait for the pathologic response. Yes, this is a sarcoma. Well, this particular case shows 4 different intimal sarcomas. They're left-sided tumors, 4 different intimal sarcomas. Are these the same? 3 of them sort of look the same. The one on the left lower, the very bright red one, to me looks totally different than the other ones. Will they behave equally, these 4 different patients? And is the survival different amongst these 4 patients, or is it similar? I find it hard to believe that they will behave the same. And I find it hard to believe that the survival will be similar in these 4 patients, but an intimal sarcoma is an intimal sarcoma, right? Perhaps they will. Well, let's look at it a little bit more deeply. When you use immunohistochemistry, and what they use when they use immunohistochemistry is they use an antibody specific to a certain antigen on the surface of the cell or a protein inside the cell. So this is MDM2, which is one of the proteins that they look for. And the one on the left is strongly staining for that protein. And the one on the right is weakly staining for it. So these 2 tumors, even though they're both intimal sarcomas, may react differently. And that's where immunohistochemistry helps us along. This is something called FISH. FISH is fluorescence in situ hybridization. And what they do is they look for specific DNA sequences on chromosome using a DNA probe that has a fluorescent stain on it. And this again is an MDM2 gene organized in small clusters, as it says underneath there. So now we're getting not only at proteins, we're getting at the DNA structures. And so this is a great way of perhaps moving the whole field forward. Now what we can do is we can get a histological stain, yes, but we will get more than the histological stain. We'll get the immunohistochemical determination of what this tumor is. And you can see if you look across the top board, it's not a 0 or 1, although some of them are 100%, but small numbers. But it's sort of a yeah, this is sort of more common in this is sort of more common in this, and they will give us a immunohistochemistry profile of this tumor. When you look more deeply, you'll see that tumors are very variant in terms of what genes they may or may not express. So what we're getting now is we're getting a histological as well as a different kind of a diagnosis. This would be what a pathology specimen looks like today. This group of individuals examined a number of cardiac tumors in 2014, and they looked at the histologic type of primary cardiac sarcoma when they had no stain, nothing other than histological stain, and after they used more advanced techniques. And they found that there was a big difference. Intimal sarcoma initially was 6 patients, and after they looked at it, they reclassified a lot of those tumors as an intimal sarcoma. And you can look down the list and see how the reclassification changed after they had a little bit more information about what they were dealing with. So now that we're able to better classify the tumors, we can figure out a little bit better what we're dealing with and compare apples to apples. We find from malignant disease that it's very, very lethal, especially cardiac, primary cardiac sarcomas are much more lethal than all the other tumors outside the heart. Therapy, any therapy added to surgery provides better early results. And it's unknown whether neoadjuvant therapy is beneficial, even though we do it. It's a standard of care now. R0 is always the goal of the resection, and better quantification may help for a more appropriate classification. So for instance, when we're testing a specific chemotherapeutic agent on an intimal sarcoma, are they really intimal sarcomas, or are there other kinds of sarcomas thrown in there? We saw the undifferentiated sarcomas. Well, now that we know that we're only dealing with intimal sarcomas, based on the more immunohistochemical studies or any of the advanced methods of diagnosis, maybe we'll have a better understanding of these tumors and better able to compare different types of chemotherapeutic agents. Now that we're able to stain for these things and able to target even at the DNA level, we have new targets for future treatments. I think this is very, very exciting and fit for study. Unfortunately, all of these tumor numbers reported in the literature by these different varying authors all have small numbers that have been amassed over a great number of years, and that's the biggest problem. But it's a big inroads in terms of quantification and targets for future treatments. So what is known and unknown? Well, more is unknown than is known. Where are the centers of excellence? If you have a child who has a cardiac tumor, as long as they're not in extremis, where do you send that child? The numbers, even for benign disease, truly are small. It would be very beneficial to have international collaboration. So instead of having 200 tumors over 40 years one place, 120 tumors over 20 years in another place, we'll have multiple hundreds or even thousands in 1 year. Individual countries don't even provide enough patients. We need the whole world together. And so therefore it won't take somebody's whole career to understudy a group of tumors, because even though we're studying them, we're really understudying them because the numbers are so limited. And it would allow for more specialized care if we had a large number of tumors being taken care of in the whole world at once. We could develop a specialty of cardiac tumors. To that end, I'm going to talk a little bit more about the International Registry to Assess Cardiac Tumours. Is going to be spoken about by subsequent speakers. But this is the steering committee for the International Registry to Assess Cardiac Tumours, or the INTERACT project. And you can see it's a global initiative. We have people involved in Canada, the United States, South America, Africa, Europe, Asia, and Australia. It really is a global initiative to try to answer some of these questions and get the whole world together to advance the knowledge and understanding of cardiac tumors. And that's the end of my talk. Matt, could we have the are there any questions by anybody?
Dr. Cusmano, do you have the chat open on your screen? There's a couple of questions.
Yes, I do.
Okay, perfect.
interestingly, I spoke about the minimally invasive Mixoma paper, and we actually had the author, Dr. Bianchi, is online in the Tumor. I'm very, very happy to hear that you're on the Tumor. Could we please have your comment and your question? He wanted to expand on that, and it's very, very nice to actually have the author talk about that. Are you still online?
Yeah, I'm online. Can you hear me?
Yes, it's very, very nice to meet you online. I'm very, very happy to see this.
It's a real pleasure to attend this tremendous meeting. I'd like to stress the point about the minimally invasive surgery, and I'm glad you cited our paper. I have to say that maybe for the sake of brevity, the methods of resection was not the same that we reported in the paper. We did not shave. We reported that to take out the tumor along with a layer of endocardium, and in some patients we had to resect the interatrial septum too and patch it. Minimally invasive actually is not a limit for which is the common surgery for myxomas. Even in case you have to resect also the interatrial septum and then patch it afterwards. And the only patient that we had a recurrent was 24 months later. The median follow-up time was 59 months in the whole case series. And also, after you cited the paper about from the Mayo Clinic group, and also in their experience, they report there is no association about recurrency if they resected only the tumor stalk or also the endocardial resection. This is another clarification I'd like to make.
Yeah, I think that's really important. The problem is that we don't know how much margin to take. And what I'm trying to say is I don't think it's necessarily the method of the operation. I'm not trying to say that the method of minimally invasive operation is wrong. I'm saying that we don't know whether or not minimally invasive or even open, how much tumor resection to take, and we don't understand why people recur. And it points out the fact that it might be a resection portion. I mean, when you talk about shaving, what you're talking about is shaving. It means remove some of the endocardium, so you have an R0 resection of your myxomas. And I think that's what we all have to get. When people talk about ablating the bed, you can be pretty sure that they're not taking any endocardium along with the tumor. So I'm saying that it matters that you do a proper tumor operation, not necessarily how you get into the heart to do that tumor operation. One of the problems, and I'd like to ask you, one of the problems is trying to determine beforehand what the pathology is. For instance, I'm really happy that you're online because you're a minimally invasive surgeon, a surgical group there, is how you determine what the pathology is beforehand. Is by echo, by location, I can understand that. And would you resect something that you are concerned that it may not necessarily be a benign tumor by minimally invasive methods?
Thank you for the question, because we also had experience of an unexpected finding. First of all, for the myxoma, we do transesophageal echocardiography. If the patient does not present in emergency, just like a tumor plop with obstruction symptoms, we have time to perform MRI that usually characterize very well these kind of masses. And one time happened that we went through this minimally invasive operation for obstructive symptoms from a right atrial mass that when we get into and then we resected, it was not like a myxoma. We raised the concern immediately after. And then at histology, and we also published that and is cited in the same paper, it came out that it was a colonic cancer metastasis to the right interatrial septum. So this patient underwent an R1 resection, but eventually 3 months later, he had recurrent symptoms, and also the PET scan revealed captation on the atrium. It was not complete resection. So if we are very sure that is a myxoma, we'll go for minimally invasive. Otherwise, we agree that sternotomy approach can also control for unexpected findings in the operating theater, or if we are unsure of the extension to the surrounding structures that can potentially can be resected or not, or have complications.
Yeah, I think it shows a very mature group of individuals doing that in your center. You're a very mature center, and I congratulate you on your results. It's a very, very nice and coincidental that I chose all the papers about minimally invasive. I chose yours, and you're here today. So thank you very much for your comments.
Very good.
We have some other questions. Dr. Rogala is one of our interventional radiologists. He's one of the world leaders in getting percutaneous biopsies of the heart. One of the problems, as you saw, is that there are very few R0 resections for left-sided tumors, and that may be because there's very few preoperative diagnoses. And Dr. Rogala, with his efforts of doing percutaneous biopsies, has moved the needle forward to try to get more and more biopsies where previously we weren't able to get biopsies. So it's great. He's asked, have you seen differences between biopsy post-resection pathology, given the potential heterogeneity of the tumors? In general, when we get the biopsies, your biopsies are very, very good. And we're usually pretty good. The most commonly misdiagnosed tumor is the myxoma. And the myxoma are most likely on the left side. If you were to speak to Dr. Reardon in the group down in Texas, who get people sent from all over the country for their sarcomas, and they see more than I do, a good number of their sarcomas are myxomas that were misdiagnosed. And we don't usually get a biopsy of a myxoma because they're left-sided. People see them on the intraatrial septum, it's a myxoma and they go in. But whenever they get a biopsy, it's very unusual to have a different diagnosis at the final pathology than it is at your biopsy. Somebody, Dr. Lestuzzi from Rome, she's also a member of the Interact group. She's asking, do you think that right-sided fibroelastomas, there may be room for transvenous interventions? You know, that's a very important question to ask, because I've gone and I've done some minimally invasive, not as many as the group that just spoke, Dr. Bianchi's group, but for a fibroelastoma, if you're pretty certain it's a fibroelastoma, you know, they have no uptake on the imaging. Dr. Rogala can talk perhaps about the difference between a fibroelastoma and a solid tumor. Fibroelastomas are hard to see on MRI or CT scan because they're so mobile. But I have had reports of fibroelastomas with minimal uptake of contrast, and it can be misleading sometimes. But you know, there are ways to remove things, say with a snare or something like that, if you see a good stock. And we have yet to see those published in the literature, but it is a possibility of happening. It doesn't really matter if the biopsy comes back as something else, as long as they can grab onto it and it doesn't metastasize. A transvenous, say, stalk or snare removal, as they would for colon cancer and colon adenomas, would be, I think personally, quite appropriate for the heart, because it's a biopsy, it's a transvenous biopsy. In this particular case, if it comes back as a fibroelastoma, you can watch the lesion, you've prevented an operation. If it comes back as a malignancy, it's your biopsy. If it comes back as a myxoma, you can consider going back in and removing the stalk, or even watching it. If it's on the right side, it doesn't matter as much. It's not as much of a problem in the right side of tumors as long as they're not malignant, because the downstream location of the metastases is going to be into the lungs. And if it's a benign metastasis into the lung, it doesn't matter so much. There are two questions about, and please, anybody has any comments, please pipe in as well. There are two comments about transplantation. Some people say, do you have any experience with auto transplant? And two different people asked that question. And yes, we do have some experience with auto transplant at Toronto, and it was really pioneered by Dr. Michael Reardon. Again, every time you here an important paper. Michael Reardon is behind it, and it shows you what a giant he is in the world of cardiac tumor in the world. We do have some experience with auto transplantation. It's for places. Auto transplantation, again, is just an incision. For those surgeons out there, you know what I'm talking about. How do you incise the heart to get at a specific tumor? An auto transplant is a method of cutting into the heart in order to gain a window into where the tumor is. So if the tumor is in a very difficult to remove location, for instance, at the base of the heart, at the posterior wall or the anterior wall of the left atrium, by dividing the superior vena cava, pulmonary artery, and aorta. Now, we usually leave the inferior vena cava alone. There's technical reasons for that. We've just gotten accepted a paper about auto transplantation in Journal of Thoracic and Cardiovascular Surgery Techniques, I think it was. But you'll be able to see that. We discussed the pros and cons of the auto transplant versus a full transplant of the heart. It's probably better to leave the inferior vena cava alone because you don't need to divide the inferior vena cava, less time doing that, less problems with reorientation of the heart. But it's really a method to get at places that are quite hard to do if you don't cut those places, don't cut those vessels. So there's nothing really too special about it. It's just to have the experience and the skill and the courage to cut across the superior vena cava, aorta, and the pulmonary artery. I think that if you're going to get into the world of cardiac tumor surgery, you have to have a lot of transplant experience. I think it's a really, really good basis for cardiac tumor surgery. So we have had experience with that. Okay, any more questions? No questions? Okay, in that case, we'll move on to the next talk. Dr. Bridget Ann Kerwin is a member of an organization called SOCOR out of Switzerland. Her group is instrumental in organization and carrying out of multiple international trials. And we've brought her under the wing, or asked her help really, in order to help us with the Interact project. And I've never done an international registry before. So when we looked for people, Dr. Michael Farku of our hospital, who's our epidemiologist and cardiologist in terms of international trials, recommended Dr. Kerwin as the most foremost international expert in this. And she's going to help us to understand what the challenges in the development of organization of an international registry are. On a personal note, she lives in Switzerland and has a strong constitution. She goes swimming every day, summer or winter, as long as the water is not frozen. So she's a very, very interesting person over and above the epidemiology that she's going to talk to us about. So Dr. Kerwin, go ahead.
I'm talking to myself. Thank you very much for that really great introduction. In fact, I'm blushing. Yes, maybe I just add, in fact, I will get my pickaxe out to break the ice in the water if it is frozen. It hasn't happened yet in Lake Geneva. It's now at what is it, about 5 degrees, I think. So it's still doable in its current state. So I've been asked to present to you the challenges in the development and organization of an international registry. And as Dr. Kushner said, that I'm involved with the Interact team, part of the steering committee, to get this great registry underway. Now, I've got 30 minutes to go through the issue about the challenges. So I'll really be the tip of the iceberg. And as we're going to be, then we'll have time for questions at the end of 15 minutes. So I don't have any conflicts of interest to declare. And this is what I plan to focus on. So cancer registry, of course, the purpose of registry is how to go about setting up a registry. The potential challenges, with the good news is that the majority of these can be overcome and or mitigated. And then at the end, we've got time for some questions and answers. So let's go to the definition of what actually is a patient registry. And this is just one of the definitions. So patient registries have been defined as an organized system that uses observational study methods to collect uniform data, that be clinical or other, to evaluate specific outcomes for a population defined by a particular disease, condition, or exposure, and that serves as a predetermined scientific, clinical, or policy purpose. However, there's no consistent term as such of the term patient registry, and it's often used synonymously with clinical registry, clinical data registry, disease registry, outcome registry, and so on, to mention just a few. In setting up registries, they can be done at either a local, regional, national, or international level. But what is important that irrespective of how it's done, standardized data should be collected. And we'll come back to the importance of data collection later on. So why take the endeavor to do an international registry? Well, international registries do provide a really great opportunity to investigate the geographic variations which there are in disease etiology and the disease progression, in addition to treatment patterns and clinical effectiveness in the different populations, which otherwise you would not have access to if your registry is to be done at either local, regional, or national level. In addition, the international registries give access to a wider and larger pool of participants. And that, of course, will enable you perhaps to identify, detect adverse events not previously reported, and also to better understand rare conditions. So in other words, we're looking at real-world evidence, which, for example, you can also include in registries patients who otherwise would not be included in the randomized clinical trials, because as we know, randomized clinical trials are certainly the golden standard to assess, evaluate new therapies, but often the sicker patients are excluded from these trials because of the stringent exclusion criteria. So the registries give a chance to evaluate these patients and to get information which otherwise would not be available for them or you would not have access to. However, there are unique challenges, if one could say that, because of variations in terms of the interpretation of the data, because of the variations in treatment patterns across the different geographical regions, the patient populations, the cultural differences that exist, and last but not least, the regulatory and ethical environments. So in order to successfully conduct an international registry, they need to be planned, they need to be designed in a very well manner and conducted taking into consideration the challenges mentioned under item 1. Now, when it comes to setting up a registry, I'll just briefly allude to 2 different models, one being the central registry and the other the registry network model. So in the central registry model, this is where the data is stored in one central database managed by one data coordinating center. And there's one protocol that governs the process. The same case report form, which is the document used to collect the data, will be used across all participating sites, with perhaps potential of local variations depending on what is required or requested locally by regulatory to have or not have in the case report form. The registry network model is more individual registries, which may be done at either regional, national level, where there may be multiple protocols, there may be different CRFs, and the only thing that's unique to this type of model is that the same data dictionary is used. So what we are planning for the Interact registry will be the central registry, where the data will be stored in one central database managed by one data coordinating center. Just irrespective of the type of model that is used for registry, you have to think about also in setting up your data management to make sure that at the end that we have data that's accurate that's complete, and it's interpretable. So there's quite a number of activities that you will need to contemplate on getting into place in order to make sure that you end up with your data that is completely, I say, accurate, clean, and complete. We'll come back to the data collection aspect in the following slide. So in terms of then setting up a registry, what do you need to take into consideration, and what are your potential challenges? Well, first and foremost, it's important to define what is the purpose of your registry. And then, that being the case, then what registry model are you going to use? Which patient population, disease to be included and will be evaluated in your registry? This is important because you need to ensure that you're going to have the same population that's included throughout the different regions, because you want to end up with a homogeneous population, not with a very heterogeneous population. So before deciding on that, you need to do your literature research to be able to understand on a global basis if the population that you want to include is that will be in the other perhaps geographical regions where you intend to go to. And how are you going to ensure that these patients are included? Well, then you need to define and set up a protocol which is going to be commonly used throughout the different geographical regions where your registry is going to be done. Another issue that's very important is that you have to be able to ascertain how easy it will be to identify patients, because one big challenge in any registry, it goes the same for clinical trials, is the selection, identification and inclusion of patients. So to overcome this challenge, you really need to make sure that, first of all, the patient population that you want to include does exist. You want to be able to identify the prevalence in the different countries where you intend to go to. And to do this, you need to really have good contacts with the key opinion leaders in these respective countries in order to be able to provide the information, to make sure that the information that you're provided with is sufficiently accurate. Again, you'll have to ascertain how many patients you want to include in your registry to be able to have publications and data that's interpretable and meaningful. So again, looking at the feasibility of being able to recruit the number of patients that you will need to determine that. Again, this comes back to doing your homework, so to say, with respect to prevalence in the countries where you do want to go to the disease prevalence. Another thing also is to be able to understand the treatments, what treatments are being used, and is this relatively standardized in the different regions where you plan to do your registry. You will also want to recruit then a certain number of patients over a certain number of time, and to follow these patients up for a certain number of time. So it'll be important to determine how many sites you will need to be included in your registry. What's the feasibility of how many sites can the registry manage? Is there a minimum, a maximum? And how are you going to identify your sites? That's really very, very important, because you want to have researchers involved in your registry who are motivated, who will include the patients within the timeframes that are defined, and also will include the patient population. So the patients with the disease that's under evaluation by the registry. So all of these are really challenges, yes, but if you have got the right people working with you in your registry, you can overcome these challenges. So geographical location is also a very important point, because you, as I've said a few moments ago, you have to be able to ascertain the disease epidemiology, local practices, and access to patients and treatments. So it's something that needs to be taken into consideration defining where you plan to do your international registry. So data collection, again, we have to be cognizant that in clinical trials, for example, there's about 60, perhaps to 65% of data collected that's never used. So in defining what data needs to be collected, it's critical for each data point that you determine what are we going to do with this data. Because collecting data on the site level is a lot of work. You've got to determine how you're going to collect it. Perhaps In some countries, you can extract data from an EHR. Other countries, that's not possible, so sites will have to enter the data manually into an electronic system, the electronic case report form. But whatever the mode is, it's more defining what you will collect and having really a question for yourselves. Why are we collecting this data? What are we going to do with it? And how will this impact on what we want to publish, for example? Will this be of relevance for publication? Data sharing agreements is also something that you'd have to think about, which can be extremely challenging. But again, knowing that this is going to be could be a potential issue, it's important to address this up front. So you may need to go to your hospital before your registry ever gets underway to understand what data sharing agreements are. And also, will it be necessary to obtain informed consent from patients? Can a waiver be obtained for this, etc.? So all of this again is important to do there. Certainly it's a challenge, but knowing that this is an issue that has to be dealt with, it should be something that should be addressed at the time the registry is being thought about and set up. So in essence, it is important not to put the cart before the horse. And what I presented in the previous slide is not necessarily in the order with which things should be done. However, in the planning phase, it really should be done in a stepwise forward manner to ensure that it's everything that is put in place, what should be put in place in order for the next step to be done. So in addition to the data collection, defining what your data collection tools are going to be, data confidentiality is also a very important thing that you need to think about. So in Europe, we have this GDPR regulation that has to be complied with. In the US, it's HIPAA. In the other geographical regions, there are also local regulations that have to be complied with. So this is something in setting up your data collection tools that you ensure that none of these regulations are going to be, there won't be any breaches, and that data confidentiality can be assured at all times. This is really, it can be, it's not even just limited to registries. In clinical trials, this is also an issue. But knowing that this is something that's got to be dealt with, this can be mitigated, and you can put procedures and processes in place to make sure that their data confidentiality can be ensured throughout the life cycle of your registry. Local and regional regulatory ethics issues have to be also taken into consideration, because depending on the country and region, it may be required to get ethics approval, it may be required to get regulatory approval before you can do the registry. In some countries, this may not even be necessary. As I've mentioned previously, it may be necessary to obtain informed consent from patients, whereas in other countries, you may get a waiver for that. So again, it's a potential hurdle, yes, but this can be overcome by evaluating upfront and discussing with the experts in this area as to what exactly would be required to get the registry set up in each respective country. So we come to funding. Funding is also a critical issue because you're not going to start your registry if there's not sufficient funding to collect or to get the registry in place, to be able to collection of the data and then its subsequent reporting. So it is important there's adequate funding to define and to identify your funding source, because it would be unethical as such to start with the registry, start collecting the data, and then ending up that there's not sufficient funding to enable the reporting and the publication of the data. So securing funding, and perhaps depending on the duration of your registry, it's important to make sure that as the registry progresses, perhaps then that new sources of funding could also be identified. So in order to overcome a lot of these challenges, it's really important that you've got core functions within your registry structure, and that being the steering committee, an executive committee, perhaps a publication committee, data coordinating center, and a group that will be responsible for the study oversight and management. And all of this is really important, like in any clinical trial, in fact, to ensure that your registry continues as planned insofar those patients are recruited, the patients that are recruited into your registry comply with the criteria for the patients to be included, the data collection is done in a timely time frame, etc. And that goes then also for data management, that the data cleaning is done on an ongoing basis. It's also important to ensure that your sites that are involved in your registry continue to include patients. So you need to contemplate and consider all the site motivation efforts that you would put in place to ensure that this is done. And there's multiple ways of doing this, increasing the awareness of your registry and perhaps having a website, a blog, where the participating sites can actually have access to. And it's not just also for the site personnel and the sites themselves, but also for patients. Because again, it's thanks to the patients that we will end up with the data. Also, so they also deserve some form of motivation, and it could be maybe setting up a website for patients that are participating in registry, where there's updates, where they can access publications and whatever else. So again, all of these things are important to keep the motivation going for your registry, and to ensure then that the site motivation to keep recruiting the patients and also completing the case report forms is maintained throughout the life cycle of your registry. Last but not least, which is very important, is the publications. I mean, one of the main purposes of doing your registry is to collect data which you can actually publish your data that you're collecting. So having a publication plan, defining and identifying the authors of these publications, etc., is really very, very important. So perhaps, developing a publication plan on a yearly basis, or something to that effect, is also something that's very motivating for sites and also for the researchers that are involved in your registry. So at the end, as we've just gone through, there are quite a number of challenges. However, with teamwork, these challenges, for the most part, can be overcome. So identifying the team members, let it be on a committee level, let it be with the sites and other partnerships, it's really important that this is done at the onset of setting up your registry. Also, some other issues that can help with that is identifying the key opinion leaders from each of the participating countries, because this is really crucial, and defining their role in motivating also the sites on a local level, because that in itself will also have to mitigate the impact of the different medical practice and treatments that may be also in the other countries, because normally registries are also going to occur over a long period of time. And I think it's important to keep in mind that over that time frame, treatment patterns and standards of care may change during the lifespan of the registry. Therefore, you do need to monitor this on a very frequent basis. And perhaps then this could result in changing the protocol, in changing the data to be collected, etc., in the trial. So working with key opinion leaders is really important on a national level to be able to identify this and to ensure that everybody is informed when there are key changes, so that then the protocols, etc., can be adapted and reflects the real world today, so to say, for the treatment patterns for the patient population under investigation. So I think for these challenges, as I've said, is that clinical research and registries are no exception, is never without a roadblock. And what is most important is to plan, to prevent, and to be proactive. These are the 3 Ps, or something I think in setting up an international registry, which is really critical, and always should be in the back of one's mind from the onset, in fact, of designing your registry. So to conclude, so I think we've seen that registries do play a crucial role in the generation of evidence that can eventually drive healthcare. And this is one of the aims of doing registries, is to drive but also improve healthcare. And the challenge is that the setup and running of an internal registry can be overcome on the proviso that a challenge is recognized as being a challenge and therefore action can be taken. There's no point in if an issue comes up, to put it under the carpet and pray or good and hope that it'll go away. It's a question of really taking action, identifying what the issue is, taking action to resolve it and or to mitigate that it occurs again in the future. Important that you have the necessary experts that are involved in your registry to support the design, data collection, analysis, and reporting. I think we've discussed the reasons why this is really crucial. To evaluate upfront ethical and regulatory considerations and requirements. We've also discussed why this is important, because if this is only discovered when we're 3/4 way into the trial that things are being done which are not ethical or regulatory compliant, that of course can end up with a large number of problems. So is to be able to understand and to know what is required to be able to put that in place before the trial gets underway. In order to successfully execute the trial and the data collection, it's important to have the well-designed technology that is defined up front, that the data collection tools in particular are state-of-the-art to ensure that your data collection will be done without any hitches also. Again, just in order to avoid and to mitigate challenges, be careful not to bite off more than you can chew, meaning not to go further afield if that's not necessary, perhaps to start off your registry with a reduced number of sites and geographical locations to make sure that what is planned works, and then to spread your wings a bit wider and to spread the net. So to do things in a step-by-step process. As I've said earlier, is that recruitment, with respect to recruitment, encouragement and gratitude for participation for the sites and the patients should also be thought about. And also important to nurture collaborative relationships with the researchers, because without the researchers, we don't have the patients. Without the patients, we don't have the data. So these groups are also critical for the success of your registry. Important also to establish a motivated and dedicated team, being the steering committee, the country leads, the data management group, the coordination groups, etc. And all of this so that, in fact, it comes down to one great team of multidisciplinary people who are going to lead and bring your registry to a successful end. Throughout the registry also, it's important to think about the partnerships with a broad range of stakeholders. And this is also important for perhaps increasing the awareness of your registry. And perhaps it could also attract additional funding, which is necessary for your registry, etc. Publications, as we said, that's what's really critical for registries, is to have regular and frequent publications. That also is a way of increasing the awareness of of the registry, what's being done. And also, of course, the data that comes out of it may well be very important when it comes to patient care and perhaps improving the quality of care for the patient population under investigation. So the last word I have to say that registries will certainly pave the way for high quality research that will eventually drive the local and national, even international policy to improve patient care. And that's what our research is all about. And as Winston Churchill has said, plans are of little importance, but planning is essential. So thank you very much for your attention, and look forward to replying to any questions that anybody may have.
That was an amazing talk. Thank you very much. I'm going through that, I'm going, okay, good. I'm glad I have Bridget doing this. Okay, I'm glad I have Usama doing that, and friends from around the world doing that. And it's so important to have experts that know way more than you do helping you along. And that's really important in terms of planning, as you've said. I think it's really important. Whenever we have a steering committee, this is a world global initiative, and it's easy for somebody who has to organize one country, but when you have to organize a whole continent with different requirements, as you said, is very, 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 very different stories. So it's something that requires a lot of planning. We already have one group from Italy who wants to join the Interact group, even though we are still in the planning stage, and that's great that the word has gotten out. If you look at the previous tumor conferences for the past 2 years, you'll be able to get an introduction to the concept of the International Tumor Registry, and you'll be able to see that. But through the previous sessions, we've already had people coming forward and asking to join. So that's really good. But as you've said, it's important to plan really, really carefully beforehand. We have a question by Dr. Rogala. He says, brilliant, Bridget. He agrees with me that it's a brilliant lecture. Privacy concerns have become a real challenge, in particular with rare diseases, as patients could potentially be identified based on very limited patient health information. Can you share your experience with this, with rare diseases, and how we get over those sorts of things?
Yeah, that's an excellent question, Dr. Rogala, and thank you very much for addressing that. This comes down to also is how are you going to collect your data? So, if you're using the case report form, which we'll be using, for example, for Interact, we just have to make sure that the amount of data that's collected that could potentially identify a patient is limited. Because as you probably know, in Europe, in Germany, for example, it's not allowed to collect concurrently on the case report form the complete date of birth, let alone that combined with initials. So we'll have to make sure that in the jurisdictions where we're going is that the data is collected that is allowed by that jurisdiction. And that we can, with the case report form, we can limit it that, for example, in the US, it's allowed to collect the complete date of birth, whereas in Europe, it won't be. So we'll just have to make sure that in the different jurisdictions, that the case report form is adapted, that it just collects the data that's allowed in that jurisdiction to prevent the access to any form of PHI, which could divulge the identification of the patient that's included. So it really comes down to defining what data, well, knowing, and again, knowing what is allowed. And then once that is done then, or at least once that is known, then to adapt the case report form accordingly.
I think this is really important. I mean, we're still in the planning stage, the executive stage. We're still pushing the data form around, and we're trying to keep it to a minimum because, as Bridget says, 65% of the information is never used. But for instance, for identification of a patient, they're going to be de-identified, but instead of having date of birth, we're just going to put age at the time of inclusion into the study. Yeah. And try to get around that to be inclusive of every place in the world to do it. That's undermining one of the problems. Dr. Terrial is asking, she said, a fantastic talk. What plans would there be for collecting blood and tissue for a centralized repository within this network? So I can answer that question. We've spoken about this, and some databases, some registries have huge amounts of data in there. Gigantic amounts of data, in as close as putting operative notes onto the registry, so that we can go back and look at the operative notes, individual echoes and the reports, individual X-rays and that sort of data on there. We're not at this time going to do that. We are going to identify those individual locations and patients who have tissue for banking, because not everybody will, and let them store that information at their own site and use the registry to be able to identify at that time when we do studies related to tissue banking, to identify the centers that have the tissue banking, and for instance, those people who do a sub-study about the sort of thing. But the actual repository within the registry is not going to happen. It's going to be a little bit hard to have tissue samples sent to a central repository. But each place that currently does them and in the future will do them, will keep them at their own site, but we will have identification of those individuals on the registry so that we can identify them, and then those people can go and do their subsequent studies. So it's a really important question to have. Tissue banking for cardiac tumors is extremely important, as I showed you on the few slides about histology and subsequent immunohistochemistry and FISH studies and whatever is going to come out in the future. So it's really, really important, but not every hospital collects that sort of information. And so it won't be pertinent to many places, but it's very pertinent in the overall scheme of things and for future studies. So that's what we're going to do at this time. All right, are there any more questions by anybody or any comments by anybody? This was an outstanding talk. All right, if that's the case, we're at the point now we're going to take a little break. It's actually perfect timing. We're 3 minutes already for the break. And then we'll reconvene in a few minutes at looks like 10:30 for the next session. The next sessions we're going to have Dr. Hamza from Africa. He is the lead for all of Africa. He's going to talk to us about the challenges of getting a whole continent together with respect to the registry, what he's sort of done to try to do that. And then we're going to have a very interesting lecture by Dr. Lastucci about radiotherapy for cardiac tumors. The radiotherapy for cardiac, well, we'll talk about it later, but she's going to talk about that. Then we'll have a lunch break after that. Okay, so we'll see you all in a little while.
Go ahead.
Welcome back, everybody. I hope you had a nice break. It might have been a little bit long, but sometimes you have to wait in line to get to the bathroom or have a little bit of work to do. I'm glad that you came back. Just to remind everybody that you can add questions to the chat. We've had some questions. I'm really happy to see that. We have a lot of people from around the world joining us today, and I'm really also very happy to see that as well. This course is accredited for 6 hours of accredited time for all jurisdictions in the world, essentially through the University of Toronto. You'll have to participate in something at the end about that, but if you have some questions, you can ask us about that as well. I was happy to see that the group from China is going to also present a little bit about their experiences in getting the cardiac tumor database, registry going in Europe, in China. And but first, before we do that, we're going to have Dr. Usama Hamza from Egypt talk to us about his efforts to get the whole continent of Africa together in this global project. Dr. Hamza is a professor of cardiac surgery in Egypt, and he's been a very, very good friend of mine for many, many years. And I was very happy to have him speak to us about this today and find the amazing things that he's going to be able to do for us in the whole world, his contribution for the world. So he's the Interact lead for all of Africa, and he's in Mansoura University in Mansoura, Egypt. Thank you very much. And then following that, we'll have the same sort of presentation to see how they're tackling the same problem in China. It's not on the program, but we were asked, and I think we can spend a few minutes to see how they do it as well. So Dr. Hamza, they're always nice to see you. Very nice to see you today. I hope it's warm there in Toronto today. It's minus 22 with a wind chill of about minus 30. So I'm sure it's a little bit warmer there in Egypt.
Yeah, how are you doing? Hi, everybody. Well, in Mansoura now, it's about 5 or 6 degrees, which is chilling here and unusual, but we can manage. I had the opportunity to be with you in Toronto, and I am proud of being there. I am a professor of cardiothoracic surgery, Mansoura University. I am the head of the department, and I have a hard task to bring the whole continent together, Africa continent. It's challenging. To start with, let's have an overview over Africa. It is the world's second largest and most populous continent after Asia, of course. About 54 countries, 1.4 or 1.5 now population. Unfortunately, few African countries have the resources to provide cardiac surgery care in their population. Available data described only 213 heart centers in only half of the countries in Africa. Only 22 cardiac centers are in the sub-Saharan for the number of centers, let's compare to North America, it's 1 cardiac center per 120,000 population. In Africa, it's around 1 center per 30 million population. 860 cardiac procedures are done per million people in North America and Europe. Only 60 per 100 million people in Africa. The number of cardiac surgeons in Africa is almost 1/10 that in the Western world. For sure, cardiac surgery requires relatively sophisticated diagnostic and surgical techniques and high-level infrastructure operated by personnel and advanced training and expertise. The manpower and the infrastructure required is largely unavailable in African context. Apart from South Africa and Egypt, and to a lesser part in North Africa countries, Morocco, Algeria, and Tunisia, the fact remains that the entire continent lacks the appropriate cardiovascular infrastructure. Talking about the challenges, there is a long list of challenges facing developing cardiac centers. We are not talking about database and the interact, but to have centers doing cardiac surgery. There is low quality equipment and maintenance, poor financial sustainability, problems with growth and expansion due to regions, isolated location, poor health and literacy of the patients. It's an overview of different parts of Africa, North, East, South, and West. Poverty is more than 50%. However, there is some hope. Recently, several African countries have already started promising cardiac surgery programs that will benefit the local patients and the economies. Of course, in Africa, there is international volunteer teams helping the people in Africa strongly help to provide long-term educational and commitment and support until the centers reach their full independence. Interact in Africa, cardiac tumors being rare, markedly affected by the poor cardiovascular infrastructure in many African nations. Several aspects, for example, late surgical intervention, lack of reliable medical records, lack of research facilities, lack of internet and database. Our approach to reach that poor continent, I have to say that, is I started to identify the distinguished cardiac centers in the continent, mainly South Africa, around Egypt, and North African centers. By the way, we have in Egypt about 10 cardiac centers out of total about 25 centers, but about 10 potential centers that have their database and they're doing at least 600 to 1,000 cases per year. I started to contact the national and regional cardiology and the cardiac surgery societies. We started to stress on starting a reliable medical records in each center, in each potential center we are contacting. I am full of hope that the Interact will find its way in Africa and make a great change in the concept of data collection and registry in the developing continent. I'm sorry to say that, but it's a difficult task in Africa. But hopefully we will find our way, and even to start with a few nations, a few countries, a few centers, and start to build up from that. Thank you very much.
Thank you very much, Sama, for that lecture. As you said, it's a very, very difficult thing. What we're going to do before we ask for questions about this talk, and I have some questions and comments to make about it myself, is the team from Fuai Hospital in China, who's also an Interact steering committee member, is going to talk about their efforts in China. Now, I was trying to get them before and we were having some trouble communicating, but they've mentioned in the chat today that they're able to speak today with some slides. Are you available to speak from Fuai?
Thanks, Cosmano. I will present my slides.
Perfect. What we'll do is we'll have you present your slides, and then after that we'll have discussion about both centers, both talks at the same time, because this is what I wanted. I wanted, and I do want, people to tell us what's happening in their continents, in their countries, so that we can put our minds together in the international collaboration way that we want to have, and advance the topic. So if you could share your slides, we'll start that lecture as well.
Oh, okay. Okay. Dear Professor Kusmano and colleagues, nice to meet everyone. It's a great honor that Professor Kusmano chose to cooperate with Fubai Hospital and invited Dr. Jiang Pingsong to be the leader of the interactive research in China. As the Chinese New Year is coming, I wish you all a happy New Year's. Next, I will introduce how to develop interactive research in China and discuss with everyone. Fubai Hospital was founded in 1646, which belongs to the Chinese Academy of Medical Science. It's a national AAA first-class hospital specializing in cardiovascular disease. It's also the National Center for Cardiovascular Disease and the National Clinical Research Center for Cardiovascular Disease. It's well known internationally for treatment of all kinds of complex, difficult, and severe cardiovascular disease. And has become one of the world's biggest cardiovascular center, as well as a national center for clinical health care, medical research, disease prevention, and education. At present, Fubai Hospital has established 3 sub-centers, including Central China Fubai Hospital, Shenzhen Fubai Hospital, and Yunnan Fubai Hospital, forming a nationwide cardiovascular disease prevention and treatment network, forming the core basis of domestic leading and international first-class innovative cardiovascular medicine prevention, scientific research, transformation, and personal training. In 2020, since 26, the annual operation volume of Fubai Hospital has reached about 14,000. In 2020, the number of operations decreased slightly due to the impact of the epidemic of COVID-19, but also researched to the 9,660 is the largest cardiovascular disease diagnosis and treatment center in China. The volume of operation at 3 sub-centers is also increasing. In 2020, surgeons at Fubai Yunnan Cardiovascular Hospital performed 1698 cardiovascular surgeons, and 3,963 cases of cardiovascular surgeons was completed at Fubai Central China Hospital, and 1171 cases was performed at Fubai Shenzhen Hospital. These 3 central sub-centers are located across the north and south of China, which lays the foundation for interactive research in China. The cardiac tumor surgeon accounts for about 0.52% of all operations, about 100 per year. The Mixoma is still the main type of cardiac tumor, followed by sarcoma. Taking cardiac sarcoma as an example, introduce the treatment experience of Fubai Hospital. Sarcomas are the main cardiac tumors, of which angiosarcoma is common and mostly investigate the right heart and the blood vessel. And other types of sarcomas, such as pheochromocytomas, are mostly invade the left heart. Surgeons significantly improve the prognosis of patients with cardiac malignancy, especially for those who have undergone orthotopic heart transplantation. In order to better carry out intact research in China, in addition to the leadership of White Hospital, we also need to unite with large heart centers in other provinces, such as Xi'an, Xijing Yuan, Wuhan, Xijing Hospital, Wuhan Union Hospital, Chengdu West China Hospital, Beijing Anzhen Hospital, and Shanghai Xinhua Hospital, Guangdong General Hospital. We will establish cooperate network to promote the diagnosis and the treatment of cardiac tumors and improve the overall treatment level of heart tumors in China. On the basis, we will establish a national database of patients with the cardiac tumor, follow up the long-term prognosis of the patients, promote the knowledge related to cardiac tumors, and improve the public's understanding of cardiac tumor. On the basis of establishing cardiac tumor operation, on the basis of establishing cardiac tumor cooperation centers, giving play to the expertise of each hospital, develop a patient-centered, multidisciplinary team diagnosis and treatment, including cardiac surgeon team, cooperative circulation team, imaging team, pathology team, and intensive care team. Exclude clinical research, we will also perform some basic research, such as single-cell RNA sequencing for the sarcoma, to identify the cell complex in the tumors. Next, I will introduce two special cases next. A 21-year-old present with a 1-year history intermittent hypertension, palpitation, and axial sweating. Plasma and urinary catecholamine and methamphetamine levels were significantly elevated, suggest pheochromocytoma. But the abdominal CT showed normal adrenal glands bilaterally. The whole body somatostatin receptor CRgraphy and CT imaging identified abdominal focal uptake adjacent to the right heart. Under the cardiac MRI was performed and showed an overall well-defined mass in the right anteroventricular groove. It's the 3.5 plus 3.8 plus 4.8 centimeters in size. The mass comprises the right atrium, the tricuspid annulus, and the right ventricular inflow tract. For the first pass perfusion documented a rapid uptake of the contrast shortly after its administration, indicated abundant vascularity. The multimodality imaging plays an important role in the diagnosis of cardiac paraganglioma. Cardiac coronarography demonstrates many small branches from the right coronary arteries feeding the cardiac mass. After the adequate pre-operation preparation, the mass was successfully resected. Histological and examination confirmed the diagnosis of cardiac paraganglioma. This indicates surgical resection is a primary and effective treatment modality for the cardiac paraganglioma patient. Next case is 9 years old, was admitted to the hospital because of expressional dyspnea, intermittent fever, fatigue, and inaptitude for 3 months. But she didn't have chills on night sweat and had not lost weight. Chest X-ray showed the posterior and anterior view showed the cardio-thoracic ratio was increased. A high density was not behind heart. The left lateral view showed an enlarged left atrium and abnormal high density at the region of lower left pulmonary artery. And the ECG showed a sinus rhythm, but indict left atrium enlargement with biphase P wave with more than 14 milliseconds. And the ECG, the echo showed a large mass with a clear boundary in the left atrial chamber. It protruded into the left ventricular cavity through the mitral annulus during the diastole. This mass obstructed mitral inflow, and there was a small amount of cardiac infusion. The atypical full chamber view showed that a mass in the left atrium that was connected with the mass in the dilated left lower pulmonary vein. The MRI showed the mass was smooth and lobulated, but with one part located in the left atrium and connected to another part in the left lung via the left lower pulmonary vein. After the surgery, we found the large part of the tumor with a size of 3.5 plus 2.5 was in the left atrium, and the smaller part with a size of 1 plus 1 plus 0.5 centimeter was in the lung. And the tumor section was homogeneously solid, grayish white and hard. After the operation, patient was in a good condition. UCG examination at 1 year follow-up was normal. During the years, with a summary the surgical experience in Y hospital. For about heart tumors, especially malignancies, complete surgical resection is preferred. But heart transplantation is also a bad choice for malignant tumors that can't be resected or the heart structure cannot be reconstructed. For ventricular intramural tumors, it's still difficult to operate. For benign tumors without symptoms and without affect the cardiac function, observation and follow-up it will be suggested. If the tumor is malignant, heart transplantation is recommended due to the poor survival after excision. Chemotherapy is not recommended for heart tumors except lymphoma. Radiotherapy can be considered, but the effect is not so good. For metastatic tumors, even if the primary tumor can't be resected, the removal of cardiac tumors may benefit for patient if the patient can tolerate. That's all. Thanks, everyone.
All right, well, that's great. Thank you very much for 2 lectures from 2 different places that are huge populations. So Africa has 1.4 billion people. China has 1.5 billion people. And they both have the same issue as we have here and everybody in the world has, is how to get a person into the system when there are issues with respect to resources, but also issues with respect to getting people identified early. And this is part of the mandate of the Interact project, is to find those areas of excellence, and Fuai Hospital is definitely an area of expertise around the world. It's also to have the global interaction of specialists who are all interested in the same topic. And it's also an opportunity for us around the world to help each other with respect to problems that they're having in their various parts of the world. Are there any questions for either one of these two individuals, how they're going about doing it? You may think that Dr. Usama Hamza in Egypt has a more difficult problem than the Fuai group in China, but in effect, they're essentially the same. Now Africa has much more of a problem with money, but sometimes when a person has a project like this, it stimulates people to develop their own institutions more than they would otherwise do so. The Interact database form, and it's not completely finalized yet, you'll find those people that are going to join it are going to be very easy to fill out. It's not going to take very long. We've kept the database to a very, very short form, but it'll be very easy to implement. You won't have to have a lot of money to do it. You'll have to have a lot of money to subsequently treat them, but the concept of finding areas of excellence and silos of experience will be beneficial to everybody, not just for those individuals who have cardiac tumors. So I think both areas are really good, and it gives an idea of what we're trying to do with the Interact. Dr. Lestussi's online. She's the cardiologist in charge of Europe. Now she has some help. She's not the only person in Europe. We have a surgeon out of Germany, an oncologist out of the United Kingdom. He's on the talk today, and we have Dr. Bridget Kerwin, who's going to coordinate the whole world for us. Does anybody have any comments or questions about what they saw with these two lectures? I think it's interesting, the comments from the Fuai Hospital about the chemotherapy and the intracardiac tumors. So even a very, 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 very highly specialized area can have interaction with other people, and we can have interaction around the world about this, about trying to answer those very questions. An institution that does 16,000 cardiac procedures per year, 16,000 cardiac procedures per year, they've seen very few cardiac tumors. And I think it's quite interesting, and I don't think it's because the cardiac tumors are not out there. I think it's because in the preparatory stages to the referral to the cardiac surgical service, there may be some problems with getting the people forward. I said in my introductory slide, what does the physician do when he or she sees a patient with a cardiac tumor? Right now, the Fuai Hospital people are the surgeons. What do the surgeons do when they see a person with a cardiac tumor? And you've seen the recommendations by the Fuai group there. They may not be the same around the world, and that's what we want to try to figure out. What's the best treatment for these people? I'm not saying it's right or wrong. I'm just saying it needs to have investigation. But what we're talking about is the physician who has a patient who comes, where do they turn? And this is an important problem. And China has just as much of a problem, I think, in Africa, of getting a person through that level of patient going to doctor, going to a specialist, going to surgeon, going to operation. Is not necessarily the fact that there's lack of funds, although that is obviously a gigantic issue, but it's a lack of knowing where to send these people. And that's the concept of the Interact project. Does anybody have any questions?
If I may, can I make a comment?
Yes.
I think that you are right. I think that what is important is to raise the awareness about the cardiac tumors. Many cardiac tumors are undiagnosed, misdiagnosed maybe, and left without any treatment because they are thought to be a dreadful disease. That is actually true if you don't cure it, but if you try to cure it, some possibility there is. So I think that the big problem is to raise the awareness of the cardiologists and to recognize the tumors when they see the patients and to send them on time in the proper hospital to be diagnosed and sent to the surgeon. Also to avoid the many misdiagnoses of cardiac myxoma instead of what is a sarcoma actually. And so I think that the interactor would be useful also for this goal, to achieve this goal. So to raise attention about this problem. And I will show you our experience. And I think that in our experience, we see more and more tumor patients, cardiac tumors, because since we started to cope with them, and first casually, and then when the people know that we are treating cardiac tumors, they ask our suggestions. And so this a global net that is helpful for the patients.
You know, the awareness is an extremely important thing. That's one of the reasons I wanted to start the Toronto Cardiac Tumor Conference. It's a conference, and that's why I've kept it free for people to attend and watch. And that's why I've insisted that previous lectures be on the website, so that if a person in another part of the world sees a neuroendocrine tumor, we had a whole year on neuroendocrine tumors, they can go onto the website and learn about it. And patients are calling me or emailing me regarding this problem. And it's an awareness issue that's an extremely important issue. So awareness about cardiac tumors is one thing, but for instance, in Africa, where they have a huge areas of underservice, it's a very important issue to get going. And even just the association with a center such as Dr. Hamza Center, an area of expertise, will be beneficial to a cardiac surgical center in other parts of Africa. And in China, to be able to be associated with a university as a hospital as prestigious as the Fuai Hospital will advance cardiac services in all of China. And so these sort of interactions, these sort of unifications of countries and continents and essentially the world will benefit everybody. Right now, as everybody knows, obviously, we're in a worldwide pandemic. And I think if each individual country were trying to fight COVID by themselves, it'd be a totally different story than the whole world coming together. Even just the reporting of, I can go online and see my friends in Italy because I'm Italian origin, to see how COVID's affecting my comrades in Italy and in India, when you hear terrible things happening in India and all the different parts of the world. Just the knowledge that you can go one place and see how your friends are doing around the world, I think it's an important thing. Sub-Saharan Africa is a big challenge. I've just starting to work with Dominique Vervoet. He's a fellow in our research fellow in our university, and he has a gigantic interest in third world or global, not third world, global efforts in surgery. And this is a part of that global effort in surgery. This is really a global effort in medicine to try to get this together. But he and I are going to try to work together to try to bring people in sub-Saharan Africa together, the cardiac surgical services. And Dr. Hamza, through his efforts, will do a great amount of service to all the citizens of Africa by taking this on and forming relationships with different people. As Dr. Kerwin said, Bridget Ann Kerwin said this morning, it's okay to start with a smaller group, and once we get going with this project, to get bigger and bigger and bigger and bigger. But I've thrown the gauntlet out to people, and they have a difficult situation ahead of them. Same thing is happening in South America, and the same thing's going to happen in the U.S. and U.S. and Canada. And if you think it's hard to get in Africa, imagine the different hospitals in the U.S. and Canada who want to keep on to their own data and are so scared to let a person be identified because of this or because of that. So every place has its own challenges, and every place that is going to do this is going to have different strategies to handle those challenges. And I thought it would be good today to show a little bit about what people are doing to handle those challenges. So unless I don't see any comments on the lecture, I enjoyed both of those lectures very, very much, and look forward to the interaction with all of us together on a global scale. Maybe in a couple of years, we'll have a whole session of the Toronto Cardiac Tumor Conference together, talking about the challenges we had and how we overcame them. It'll help us to help each other, but it'll also help people who have other ideas to get those underway as well. So thank you both of you very much for really great lectures. I really enjoyed both of them. The next lecture we're going to have is going to be by Dr. Lestusi. It's a little bit incorrect on the agenda. I'm sorry, I've spoken to my secretary. We're going to get the agenda fixed by the end of the conference, or at least in the next little while. So when you do go back, you'll be able to see it. Dr. Lestusi has become a friend of mine. We met through a tumor board that we are both part of from Houston, Texas. And this is a little bit of what we're doing with respect to the International Cardiac Registry. And part of that registry is going to entail, in terms of when we were talking earlier this morning, we're going to have, as part of the registry, every so often have a mini conference about different tumor types, and perhaps have a tumor board that's an international tumor board, perhaps along with the Houston group. We haven't quite sorted all of this out, but there will be lectures, opportunity to ask the experts, and an opportunity to identify different places of excellence. Dr. Lestusi is in an area of excellence. She really is a real expert, and I always enjoy listening to her and her expertise whenever we have our monthly tumor board meetings through the Houston group. And she's been very nice enough to be allowed to be a part of the Interact group, and she has a real interest in radiotherapy, which I found very interesting, because I use radiotherapy to mop up R1 disease or R2 disease, but she has used it primarily, and I don't want to take much of your talk, but I've really been very, very impressed by her, and I've asked her to give a lecture. She's going to talk to us about cardiac radiation. Thank you very much in advance.
Oh. Okay. Okay. So thank you to Dr. Cusimano for organizing this really wonderful conference, and for inviting me to share out my experience in cardiac tumors. I worked for many years in an oncologic hospital without cardiac surgery, but with a strong team of oncologists. It's a referral center for sarcomas, and a center with a renewed center for radiotherapy. So the background for radiotherapy is that complete F0 resection of cardiac tumors is difficult, as all the cardiac surgeons know, obviously. is most difficult in large masses and is sometimes impossible. And most of the malignant cardiac tumors are sarcomas. We know that radiotherapy is currently used for soft tissue sarcoma in other sites, both in the palliative setting, in the adjuvant setting, and also in the neoadjuvant setting. So there is a rationale to employ radiotherapy for some cardiac tumors, so at least for those who are radiosensitive. However, the experience is limited so far. In a review, in a historical retrospective analysis of the Cleveland Clinic about 42 primary sarcomas, some of them were treated with radiotherapy associated to surgery and chemotherapy, to surgery, to chemotherapy, and one patient had only radiotherapy. Those with a triple treatment had an expected median survival much longer than the others. So there is some advantage in adding radiotherapy and chemotherapy to surgery. In the French sarcoma group retrospective study, who Dr. Cusimano has shown this morning, they analyzed the effectiveness of different treatments. In radiotherapy, increased both the overall survival and the progression-free survival. So there is a possibility to improve the results of surgery. In this more recent analysis of a very large group of patients with cardiac sarcomas, radiotherapy was used both associated to surgery, to chemotherapy and surgery, or also alone or with chemotherapy in non-surgical patients. And as this is a slide as Dr. Cusimano has already shown this morning, you see that adding any therapy, chemo or radiotherapy, to surgery improve the survival significantly, or at least for the first 2 years. In this study, however, there was no differentiation between the role of chemotherapy or of radiotherapy. The problem why the radiotherapy is scarcely used, is rarely used in cardiac tumors, is that the fear of risk of radiation-induced heart disease. Radiations induced immediately within minutes and hours and the first days activate the clotting cascade and stimulate an acute inflammation. And this effect of inflammation continues over weeks, months, and years through chronic inflammation, fibroblast accumulation. So in the short term, we can have pericarditis, arrhythmias, thrombosis, and also myocardial dysfunctions, mostly if anthracycline chemotherapy is associated. And we have also the long-term effects. They are mostly myocardial dysfunction. Also in this case, is higher risk with anthracycline chemotherapy of coronary artery disease, valvular disease, and arrhythmias. What we know about the risk, cardiac risk by radiation, is mostly derived from the studies on the long-term survival of patients treated with for Hodgkin's disease or other intrathoracic tumors. And we see that the risk of heart failure may be very relevant if the radiation burst is high and if anthracyclines are associated. However, you can see that the risk starts to increase after 5 years. and becomes significant after 10 to 15 years. Also, for the other cardiac problems, we see that any cardiac diagnosis is increased on the long-term follow-up. You can have coronary artery disease, arrhythmias, or other cardiac diseases. But also in this case, the risk is very low in the first 5 years, and increase thereafter, and increase sharply after 10, 15 years. Also in our experience, the median interval between radiation therapy and significant heart disease, radiation-induced heart disease, is 15 years. That is beyond the median survival of cardiac tumors, cardiac sarcomas. So we have to accept that we can think to accept a higher risk on the short term and think to the long-term risk only later on. The challenge, the challenge of radiotherapy of cardiac tumors is to deliver a curative dose sparing the neighboring structures and to have a moving target. This is the only organ that is always moving. It's not possible to stop it. So we have to use a radiotherapy technique which is able to concentrate the maximum radiation on the target, that is a tumor, and the less radiation on the surrounding structures. Proton beam therapy and carbon ion therapy are very precise in their target, so are ideally the best treatments. However, they are available in only a few centers. In Italy, we have one center only able to do this. More widely available are stereotactic radiotherapy, which has actually been used for cardiac tumors with a total dose of 15-25 grays given in 3 to 5 sections, or intensity modulated radiotherapy, which we illustrated later this afternoon by Dr. Navaria. This is our radiotherapist, used at a total dose of 30-60 gray, divided in 15 to 30 fractions. We have few data on cardiac radiotherapy safety. In fact, we have a lot of single case reports that are not comparable. We have some larger series, but all are focused on the oncologic results. And they usually didn't do a systematic assessment of the adverse effects and a systematic cardiologic follow-up. So in the series of Takenaka, the sarcoma metastasis, they showed that the median survival with radiotherapy was increased by 7 months, but they don't say anything about the adverse effects. In the French sarcoma group, only on cardiac sarcomas, also the adverse effects on the heart are not reported. In this series of NAWA on primary cardiac sarcomas, 15 cases out of 42 primary cardiac sarcomas treated by radiotherapy, but there is no mention about the adverse effects. There is a paper on 10 cases of cardiac metastasis by sarcomas, carcinomas, and lymphoma. But they just say they were limited adverse effects. And also in the series of Anderson, this is the largest one, there are no mention to the adverse effect on the heart. Besides the tumors, radiotherapy may be used in a particular field of cardiology, that is the ventricular arrhythmias generated from in cardiomyopathy or ischemic heart disease, which are usually treated with interventional cardiology, but in some cases where it is impossible to do an ablation with radiofrequency ablation, there are some cases treated with stereotactic radiotherapy, giving, of note, 25 gray in a single fraction. So a very high dose in a single fraction. And these patients may have an arrhythmic storm shortly after the treatment. So the ventricular arrhythmias increase in quantity, in numbers, because there is the acute inflammation, which exacerbates the arrhythmic focus. And then, however, then this lasts some days, and then it works against the arrhythmias. We will report our clinical experience made at the CRO, the National Cancer Institute of Aviano in Italy, where in 20 years we have treated and followed 42 malignant cardiac tumors. 31 were primary, 11 metastatic, 7 of the metastatic were sarcomas, and 4 were lung carcinoma, neuroendocrine tumor, colon cancer, urothelial cancer. 25 of those were treated also with radiotherapy. 12 had an adjuvant radiotherapy after airborne surgery. 3 had a neoadjuvant radiotherapy, in 2 cases followed by radical surgery, performed 1 and 3 months after radiotherapy respectively, and 1 after radiotherapy was deemed still inoperable. And 10 palliative or curative treatment for metastatic tumors or unresectable tumors, or in patients refusing radiosurgery or chemotherapy. And of the 25, 19 had been also treated with anthracyclines before or after the radiotherapy. Our routine cardiologic surveillance included, before radiotherapy, an echocardiogram, a careful echocardiogram to assess the cardiac function, including the careful study of the valvular and venous and arterial flows, assess the tumor burden, and assess the excursion of the tumor and of the cardiac structures through the cardiac cycle. And we then integrated the CT and echo images of the target and the neighboring structures to evaluate the radiation burden. So the radiotherapists work with a still image, MRI or CT scan, and we show them how much the structures are moving. Then we have the patient have a weekly ECG and echocardiogram during radiotherapy to see the cardiac function, obviously, early changes in hemodynamics and tumor size or echogenicity, because this can give an early indication of the effect of radiotherapy, because usually the necrotic tumors change in echogenicity, and also to see the side effects. After radiotherapy, the patient has a ECG, electrocardiogram and echocardiograms every 3 months for the first 2 years, every 6 months for following 3 years, and after 5 years, yearly. We treated the we had additional therapies as non-steroidal anti-inflammatory for pericarditis, amiodarone beta blockers if there were hyperkinetic arrhythmias, anticoagulation if needed, and additional imaging as needed. The oncologic outcome after radiotherapy was rather good. The local outcome was a complete remission in 16 patients. One of them had a local relapse after 18 months. A partial regression in 7
We may have lost Dr. Lustucci.
patients in the therapy. I will show you some cases. This was the very first patient who had treated the Trojan faculties made just a palliative intent. We tried a palliation. He underwent therapy, and the mass was still large. He underwent also radiotherapy. To our surprise, the palliative intent was transformed in a radical cure. In fact, after this is the follow-up after 9 years, and the patient was still free of disease. He died 4 years later of stroke. And so he remained free of disease and was actually cured. This is a case of constrictive pericarditis in a patient with metastatic lung carcinoma with metastasis also to the kidney and many other metastases. And she had a constrictive pericarditis due to a tumor encasement of the heart, and pericardial space was occupied by a solid mass encasing the heart. And you can see here that during inspiration, there was a shift of the interventricular septum to the left. And so she underwent palliative radiotherapy, 25 gray in 5 sections. After 10 days, the signs of constriction were already reduced. The patient was asymptomatic. And 1 month later, it was possible to see that all the intrapericardial tumor for the patients with systemic disease. This was a patient
It's too bad that it came off, but hopefully she'll get back online. It's a very interesting talk, and I'm curious to see it to its end. I think we'll give, oh, here she is.
Do you see my slides or not? Because
Not yet, not yet. You dropped off. You were showing the echo on the patient who had the tumor causing constrictive pericarditis, but we don't see your slides yet.
Okay, I've sent them if you want to.
Yep, I can share them from my end. Just give me one second.
Okay, from the 16, slide 16. Okay, this one. Okay, next. Okay, this is a tumor encasement after this is a patient. Did you see this one before?
Oh, the previous one. No, we didn't. Just tell us what the outcome was. You gave radiotherapy and 3 months without cardiac symptoms. So this made her heart much better. You can see the wall motion abnormality in the apex and that wall there, how huge difference there is. So it wasn't really constrictive pericarditis, it was tumor encasement of the heart.
Yes, and after 2 months, all the tumor encasement was gone, so the pericardium is normal. So it was cured. Locally, it was cured. That the patient had metastasis on the kidney, so he finally died. But she achieved 3 months free of cardiac symptoms. That is not much, not a little thing, I think.
So remarkable recovery.
If you can show the next slide. So this was a patient with synovial sarcoma, relapsed after surgery, several lines of chemotherapy, and who had a horseshoe mass encasing the heart, compressing mostly the atrium. The mass was had a thickness up to 8 centimeters. He was very symptomatic, had also a superior vena cava thrombosis, and he received obviously heparin, but also radiotherapy. And after 2 months, the maximal diameters were halved, and the ejection fraction was improved, and the patient unfortunately was still not operable. So this neoadjuvant therapy was shifted to palliative therapy, but the patient felt very well for 10 months and died 1 year later. But achieving 10 months of free of symptoms. So the next slide. This was a cardiac angiosarcoma with this is a transesophageal echo, the bicaval section. And on the right, you see the superior vena cava with venous line. This was a diagnosis. The mass was infiltrating the interatrial septum, the atrial roof, and right atrial roof, and also the right atrial free wall up to the tricuspid valve. And after chemo and neoadjuvant radiotherapy of the right heart, he achieved a good reduction of the mass, and he was operated on later after 1 month, and achieving a complete resection of the tumor. The next slide. So the acute cardiac toxicity we observed was really not very frequent. We had 2 cases of atrial fibrillation, which was reverted with amiodarone within a few days. 1 case of acute pericarditis, which recovered after 1 week in non-steroidal anti-inflammatory drugs. And the most severe case of acute toxicity was a ventricular arrhythmia storm in 1 patient who had been described, if you want to see in JACC Cardio Oncology last year, the complete description of this patient who had ventricular arrhythmias originating from right ventricle metastasis of angiosarcoma. And he had been well controlled by amiodarone and by chemotherapy with pazopanib for 2 years. But once the metastasis started to grow again, the arrhythmias increased in spite of increasing dose of amiodarone. And also the couplets and complex arrhythmias were increasing, and he was not responding anymore to pazopanib after 7 lines of chemotherapy. So there was no other choice to treat him, who had also distant metastasis, so was not suitable for cardiac transplantation or cardiac surgery. So he was treated with radiotherapy, stereotactic radiotherapy for 5 days, and she had actually an arrhythmic storm with a sharp increase of ventricular arrhythmias. But he was treated with steroids, infusion, high dose amiodarone infusion, magnesium, and after a few days, the arrhythmias decreased in number, and the amiodarone was also decreased, and he remained stable for 3 more months, with the arrhythmias well controlled by a standard dose of amiodarone. Next slide. What is more important is the analysis of the left ventricular function on the long term. In this slide, I report the ejection fraction before the blue columns, at the end of radiotherapy, light green columns, and the last follow-up, red columns. The follow-up was from 2 months to 131 months. So many patients had a rather long follow-up, about 4 years of follow-up. And these are the patients treated with radiotherapy limited to the left side of the heart. And all but the first one didn't have any reduction at the last follow-up in left ventricular function. This was the very first one I showed you, who had a long follow-up, who received the high-dose anthracyclines, radiotherapy, including the left ventricle. And anyway, he still had the ejection fraction above 50% at the last follow-up. The other had all ejection fraction around 60% or more. On the right side, there are the same evaluations of the left ventricular function for the, and in addition, in dark green, the right ventricular function as measured as shortening fraction, percentage for shortening fraction of the right ventricle at the last follow-up. Also, in this case, we have some very short follow-up, but also some follow-ups over the 4 years. And also in this case, we had at the last follow-up, the left ventricular and right ventricular function were within the normal limits. So we didn't have any significant ventricular dysfunction at the long-term, medium and long-term follow-up. And we didn't have any problem with the valves, even with a patient treated with radiotherapy involving the mitral or tricuspid annulus. So this is a good, I think it is, we are more convinced now that radiotherapy may be done and is also safe, at least on the medium term. The next slides. So in conclusion, I think that radiotherapy may be used to treat cardiac tumors in the palliative setting, obviously, because we don't care in the palliative setting about the long-term adverse effects, and may be very useful in large unresectable tumors and tumors with hemodynamic impairment or responsive to chemotherapy. It may be used in an adjuvant setting, even if we have, after Air1 resection, we have used it on the personal basis. So we use it, for instance, after Air1 resection with a small basis of the original tumor to reduce the need of high doses of chemotherapy in an adjuvant setting. Usually we made, in most of cases, the radiotherapy was used after some cycle of chemotherapy, adjuvant chemotherapy. And in the neoadjuvant setting, it also can be used. We used it very rarely because we were afraid of the problems that the surgeon might have encountered on an irradiated heart. But in the 2 cases we have sent to the cardiac surgery, the surgeon didn't have any additional problem. And may be used also with curative intent together with chemotherapy in some selected cases. Proton therapy is theoretically the safest approach, or carbonium therapy, but it's not so available in a center. Intensity modulated radiotherapy planned with the help of echocardiography and with strict follow-up is also feasible and safe at the medium and long-term follow-up. And the radiotherapy included in a multimodality approach to cardiac sarcomas may help in achieving a complete remission and prolong the overall progression-free survival by several months, possibly 1 year, even more. Next slides. And last slides. And maybe 1 year of life, 1 more year of life or 2 may seem a little thing, but 1 more year may maybe an important thing. If you are a parent of small children, if you have a family to take care of, if you have to plan the life after your death. So I think that it's not a little thing to let our patient gain one more year. And if you can cure them, and this is possible in some cases, even in unpredictable cases, is even better. Thank you for your attention.
Well, even though we had some problems at the from an internet point of view, I think that was a great lecture. I loved it. You know, radiotherapy, we're always scared to do radiotherapy as surgeons because we know the surgeons who have had the missed opportunity or bad opportunity to operate in somebody who's had radiotherapy in the past. It doesn't do very well, but I must admit, I've never done it in a neoadjuvant therapy. I perform only cardiac surgery, even though I'm a cardiothoracic and vascular surgical trained. So I know that they use it in thoracic surgery, but they don't have it many years afterwards. They do, as you have it shortly after the procedure. So finish your therapy as we would for chemotherapy, and just after they've had an opportunity to physically recover from that, then go and perform an operation. You have people all the way out to 10 years and 126 months, I thought I saw. So that's a great long-term outcome. Were those people the R1, in other words, peripheral cardiac irradiation, or are they total cardiac irradiation? In other words, you do a lot of radiotherapy for residual disease. And when you do that, is it residual atrial disease, residual ventricular disease, both, or what's the outcome of the person, or what's your, not outcome, but what's the experience when you do total cardiac irradiation? Are you scared to do that? Have you seen echocardiographic changes, etc.?
No, actually, most of our patients, just a few patients had radiation limited to the atrial roof. So this is obviously safer. But most of our patients had radiotherapy, including the mitral annulus or the tricuspid annulus. And actually, the mitral tumors, including the radiation therapy, including the mitral annulus, are scary because it's at the left ventricle. But the problem with the tricuspid annulus is the excursion, because when I told to my radiotherapist that the excursion was 2 centimeters, he said, "Oh, so much." I said, "It's just normal." Actually, it's just normal. And we had also radiotherapy on the left ventricle and on the right ventricle. And we were surprised because we have 3 patients who had the radiotherapy, adjuvant radiotherapy, 2 on the basis of the left ventricular wall, free wall, and 1 on the interventricular septum for a sarcoma resected on the right part of the interventricular septum. And we saw a hypokinesis in the first echoes after radiotherapy, a hypokinesis of the left ventricular wall for the 2 patients with left ventricular radiation therapy. And they recovered later. So they know now on the long-term follow-up, one is 126 months, and so and they recovered later on. And what was still more impressive was a patient who had surgery on the left ventricular septum, the right side, because the surgeon, as soon as he recognized the tumor, which was supposed to be a myxoma, and he was not a myxoma, was a malignant tumor, cut deeply the septum. So we saw a minus images of the interventricular septum, and this disappeared on the long-term follow-up. So there was a remodeling. There may be a remodeling also on irradiated heart, and we will publish this, I think. I hope that we will be able to show this more in detail. But this was really impressive. So the heart can recover. And I think that the problem was the radiation burden in the single administration. In fact, the only patient who had so much problem with arrhythmia was the patient treated with stereotactic therapy with high-grade dose for a few days, as was in the patient treated for ventricular arrhythmias of other origin. And if you give a low dose, hyperfractionated dose, you will ask, you can discuss later with Dr. Navaria, who will show you how the plan are done, and also two more cases. I think that if you are able to reduce the single dose and to give a little dose to neighboring structures, radiotherapy may be safe. This is important in the adjuvant setting, obviously, because in the palliative setting, it's not so important. You say, okay, we tried to do something. Our first patient was, this is the possibility. There are no other possibilities. So the patient is dead. Otherwise, the patient is dead. But in the adjuvant setting, this is important. But we feel more comfortable in planning radiotherapy.
When you saw the change in the cardiac function, which, as you said, was temporary, how long after the radiotherapy started or completed did you notice it, and how long did it take for it to get better?
Yes, we saw, so the radiotherapy, usually the standard radiotherapy is lasting 1 month, it's 4 weeks, and we have we saw a reduction of immediately after radiotherapy, and it recovered after 1 year, I think. So it was was a remodeling, I think.
And how bad did the heart get? Like heart failure type of decrease in ventricular function?
No. The only patient who had some problems of heart failure was the first one, who actually had a very high dose of anthracyclines. He was treated 20 years ago. And he developed also a renal insufficiency, and because he had also ifosfamide, so probably there was a role of ifosfamide, and he had a lot of other problems, and he was also elderly, because when he developed the dysfunction, he had a slight dysfunction shortly after the radiotherapy, which actually included also the mitral annulus, so in the base of the left ventricle, and was done 20 years ago with a technique that is not as good as IMRT to limit it was an older technique, not more in use. And but he recovered. He had just not really heart failure. He had dysfunction and was treated as usual. And then later on, he underwent. He had more kidney problems than cardiac problems.
You haven't noticed any valvular abnormalities after acute?
No.
That's good.
No, not yet. We tried to avoid that, but maybe we will do a radiotherapy a patient who now is making a chemotherapy and has a tumor very close to an artificial valve. But anyway, we didn't have any problem with the valves.
And when you do chemotherapy and radiotherapy as a trimodality therapy, surgery, chemo, and radiotherapy, do you stagger the chemotherapy first, then do radiotherapy? Do you do concurrently? How do you do that? You know what I mean?
Yeah, we did the chemotherapy first, and then it depends from the we did only radiotherapy in some cases of L1 resection of intermediate grade sarcoma with a limited area to be irradiated, or in patients who refused chemotherapy, because there are also patients who refuse chemotherapy. And usually we have the chemotherapy first and accurate analysis of the cardiac function after chemotherapy and radiotherapy later, or a short-term chemotherapy and radiotherapy. But anyway, chemotherapy first. Usually.
It's interesting in China, their comment on their slide was chemotherapy and cardiac tumors don't mix together. You remember who said that? And here we're saying we only give radiotherapy when the person refuses chemotherapy. So it shows you the difference around the world. And that's why it's something like, I always bring everything back to the Interact because it's so important to have international collaboration to get everybody in the same thing. Perhaps one day we'll have a randomized trial, perhaps through the Interact, if we get enough patients that we can get this together, randomized trial of chemotherapy versus radiotherapy versus surgery. That would be a very interesting thing to do. Because I think there would be equipoise, I suspect, I don't know.
Yes, another problem of radiotherapy might be if you, we have a patient, for instance, who had a left atrial on a cardiac sarcoma arising from the left atrial roof, who was misdiagnosed by the pathologist as a benign tumor after resection, who had a relapse 8 months later, was operated on with a large mass, and was considered to be a radical surgery, but actually the tumor involved at the right superior vein. It was on the roof of the right atrium, involving also the right superior pulmonary vein. So he had a relapse, an early relapse or a residual, which was seen only at the MRI. And in that case, we irradiated also the vein. And I've seen him 2 weeks ago after 7 years. And the flow in the pulmonary vein is very good, it's normal. And this was also something that I was worrying me, because I said, okay, you irradiated a pulmonary vein, what will happen? And actually, it's in complete remission, and this is the reason why we study not only the cardiac function, but everything, also the valves and the flows. And the weekly, I think that the weekly echocardiograms, the weekly check of how things are going is also useful.
Have you seen some early change in function? So you've been doing weekly echoes for a lot of patients for a long time. Maybe not too many patients, but enough. Have you noticed a drop off early on? Or in other words, you think you're doing too many, or still continue?
No, we make the weekly echo is just in the month of radiotherapy. Then we have the patient anyway have an echo every 3 months. So 4 echoes a year for 2 years, and 2 echoes a year for 3 additional years. So for the first 5 years, they are followed really, really strictly. Also because it's the time, the risk of relapse, so we try to check it. And we didn't see significant dysfunctions.
Did all of your patients get complete radiotherapy course, or did you have to stop?
No, they were those who had the whole heart. You see, was just one was the tumor encasement. There were patients with the tumor encasement that is. So they had a limited survival linked to the general conditions. We have another patient, but he was treated not by us, so he underwent carbon ion therapy in another center. And he also had a good local control of disease without any significant dysfunction. And we have 5 years of follow-up, but unfortunately he had systemic metastasis. So I think that radiotherapy may be good if you have a small tumor. Radiotherapy alone can be useful if you have a small tumor resected with only microscopical infiltration. And the 2 tumors we treated just with radiotherapy were going into the pericardial space, not into the ventricle. Otherwise, chemotherapy is necessary because if you look not at the local response, but at the general response, the risk of metastasis is so high that chemotherapy may be used because you don't know if a tumor growing inside the heart cavities has already given some micrometastasis, we don't know where. So I think that the 2 things should go together, but in selected cases, we had 2 cases of sarcomas arising from the external part of the left ventricle with a small point of attachment. And we were able to give a radiotherapy only on the surgical bed and avoid systemic chemotherapy. This is otherwise, I think that the 3 things should be together and depend also. Angiosarcoma needs chemotherapy. It's no way. Angiosarcoma has the worst prognosis. It depends also from the grade of the tumor. So a high-grade tumor or a low-grade or intermediate-grade sarcoma is much different.
So it's your opinion right now that the surgeon is still important in cardiac tumors? Would you ever not treat a patient with operation? In other words, would you ever go primary radiotherapy followed by chemotherapy or vice versa?
No.
Would you include surgery if it's
no,
small?
I think that surgery is very important. The problem is to find a surgeon who has a mentality of oncologic surgery.
Right.
And this is more difficult. Initially, we have 2 different careers. There is cardiac surgery and thoracic surgery. We have not we have very few cardiothoracic surgeons. So the cardiac surgeons has in mind to avoid the larger sections because he tried to spare as much as he can. He has no idea of the risk of microscopic infiltration. It's not in his mind. We had a very good experience with some cardiac surgeons where we talk, whom we talk before, and we explained the problems. If a cardiac surgeon has the idea that a malignant tumor is not a malignant tumor, and that radical surgery is important, and to have a free margin is very important. This is essential. But I think that we try to find a surgeon. I think surgery is the mainstay in all the sarcomas.
And this comes in terms of one of the goals is to find areas of excellence around the world. In Europe, I sent you a patient, you may not know who it is. I don't know if they contacted you from Eastern Europe, and they had a tumor and they contacted me, so I sent them to you. So the point is we need to have friends around the world that we can contact in areas around the world that we know are areas where we have people who aren't afraid, or trust me, when I do an auto transplant, I'm scared, but who have the courage to take on big tumors. And we need to do that, decentralize, or not, we need to centralize care for cardiac tumors, whether it's radiotherapy, chemotherapy, cardiology, surgery, all treatments. We need to centralize it into areas, silos of excellence, and that's exactly what this is all about. Nobody's asked any questions. That's why I've been monopolizing your time, Dr. Lesusi. Thank you very, very much. I could ask you questions for a lot longer, but we're cutting into the lunchtime, and perhaps for the conference that Dr. Navadia is going to speak, I'll ask some of my questions there. I'm particularly interested in terms of the complete versus partial response, how much of a complete response you get. The echo you showed was very, very remarkable, that there truly was complete response. And the partial response, I'm curious to know about that, but perhaps we'll leave that for afterwards and you can discuss that as well. Okay. I loved your chat. It's unfortunate we had a little bit of a break in between, but it's just really for one set of slides, and that's great. Okay, everybody, we're going to go for a lunch break now. We're going to meet back at 12:45, and we've had the lectures in the morning. These are the didactic things, and I find them all very, very interesting and very, very educational. You see, I like to ask questions to learn things, and feel free to ask questions on the chat line, and I'll relay them on to the speakers, and we'll do that. This afternoon is going to be a little bit of a different thing. We've sort of done this 1 year, I think, where we had tumor cases that we're going to present. And I've asked people from around the world to give us a tumor that will help to identify a specific problem. And we'll use it as an opportunity to see how the experts deal with them. Dr. Patrick Ogala has been very patient to stay with us, and I'm hope he learned as much as I did in the morning. But we're going to stress him as well as a panelist, as well as you, Dr. Lestusi, and all the other people, to give the world, really, because there are people here from around the world, an opportunity to see how we deal with these tumors and see if there's any differences in the way we do it. So this afternoon, we're going to have a few cases, 1, 2, 3, 4 cases, I think, and perhaps 5 or 6, if we have some time, to see how people would handle these things from around the world. So everybody have a nice break. I know some place it's in the evening. You can have a dinner break. Here it's a lunch break. China is signed off there. We're in the middle of the morning there, and later in the afternoon in Toronto, but very, very early in the morning in Australia. Dr. Newcomb will join us at 5 o'clock in the morning in Australia. So have a good short break, and we'll see you back here in about a half an hour or so. Okay.
About half an hour. Okay.
for it to show up. Here we go. Hello, welcome back everybody to the conference. I'm glad you had a bit of a break and you were productive answering phone calls, doing whatever you were doing. We're going to start the case as part of the program now. And this is meant to be an example. They're all real cases. This is meant to be an example or a way to have a framework for types of cases you may be handling or presented in the future and get an idea of how it should be handled. Now, what we're going to do here is I've asked different participants to bring up a case of theirs to help illustrate what I think is an important topic. And I've asked some people to be on a panelist. And the panelists are the speakers themselves. They can present their own cases, but then when the other people present, there'll be a panelist on that case, on those cases as well. And I'm going to rack their brains in terms of trying to figure out how they do things, what we should do, et cetera, et cetera. So our panelists are Dr. Usama Hamza. You met him already. He's from Egypt. He's a cardiac surgeon, professor of cardiac surgery. Dr. Robin Jones. He's an oncologist. He's in the UK. He's an outstanding oncologist, very, very smart man. All the oncologists I met are smart, but he's particularly smart and a very, very nice person too. So you can ask him as many questions as you want. And please do ask questions. Dr. Chiara Lestuzzi, we just finished with her. I racked her brain earlier in the session about radiation therapy. I thought that was very interesting. We'll have more comments to make about that. Federico Navaria is an oncologist, radiation oncologist in Italy. He's going to be there as well. Dr. Albi Razak, Dr. Mike Reardon, if you can make it. Patrick Rogala, you see him online there. He's one of our interventional radiologists. He's the chief of radiology here. And he's a fantastic, I can't keep on saying how happy I am and how lucky we are here to have him and staff with him as well. We have Dr. Juan Umana. He's an outstanding professor of surgery from Colombia, Bogota, Colombia in South America. And then Andrew Newcomb is a cardiac surgeon who has an interest, one of the foremost ones in Australia for cardiac surgery care. Now in Australia right now, it is probably 3 or 4 o'clock in the morning. So he may not join us early on, but he's going to join us for the latter part because I've given him a case to present. There's a little bit of a misprint in the agenda. As I said, I've asked my secretary to contact the university to make that right. Some of the biographies are missing, and I'm so sorry for the people who presented for us that they're not there. That was a mishap at the university, but we'll get that all sorted out. Please send me a photograph of yourself if you haven't, so we can put that on there so people can remember what you look like. Again, this is an accredited course for 6 hours of accreditation for all levels of boards, licensing boards, educational boards, and things like that. And finally, you can watch this online for a year. You just have to go to the website and go onto the YouTube channel or the Facebook channel, and you can scroll through it. It's a raw footage. And then finally, at the end, Matt Proctor, he's here at the University Health Network. He's also an outstanding guy. We're really lucky here at the University Health Network to have people like him who's going to put it all together, put it on the website as past presentations. I do encourage you to go back to the past presentations. For instance, Dr. Rogala gave a fantastic lecture last year about percutaneous biopsy. If your centers are thinking about getting into percutaneous biopsies, that's a great place to start. You can watch his lecture. And if you bother him a lot, I'm sure he'll collaborate with you and teach you the technique, because it's really been fantastic. It's avoided operations, and it's really helped people to get neoadjuvant therapy when they otherwise would, or avoid operation when they otherwise would need one for one reason or another. Okay, we'll start with the first case. Are you there, Usama? You want to take over the screen and do it? I'm going to stop you from time to time at the screen to intervene and ask questions, okay? We're going to run this like it's a tumor board, like you have a patient, and we're all trying to sort out what to do, what the next steps are. Well, you gave us the
Hi,
answer.
RJ again.
You gave the answer. You're not supposed to give the answer. Okay.
Okay. Are you getting my voice? Because I think the internet connection. Okay.
Yes.
Today I'm talking about a biatrial cardiac myxoma. Of course, myxoma is the most common cardiac tumor. But biatrial myxoma, I have seen it once 20 years ago. And this is the second case I have seen about 2 years ago. So myxoma is the most common primary cardiac tumor with an estimated incidence of 0.001 among the general population. The left atrium is the most common site of origin of cardiac myxoma, followed by the right atrium. Myxoma represent 5% of all cardiac myxoma, estimated about 2.5. Actually, to the available literature, only a few cases of biatrial myxoma have been reported so far. And they are generally described as a single tumor reaching both atria. We present a rare case of two independently growing atrial myxoma who underwent surgery on thoracic and vascular surgery center at Egypt. A 54-year-old female presented to our department with NEHA class 3 for the past 6 months. She denied any past history of cardiac illness. Her pulse rate was about 120. Cardiac auscultation revealed a mid-diastolic rumble across the mitral valve, followed by a tumor blob. Patient's electrocardiogram showed normal sinus rhythm, right axial deviation, and some T inversion in the 3V1 to V4. Patient was further analyzed initially by transthoracic echo, followed immediately by transesophageal echo. It revealed large left atrial mass attached to the interatrial septum. It was 6.6 by 6.5 or 5.5 centimeter, encroaching on the mitral valve. Of significance, another mass was also evident in the right atrium, almost same size, 6 by 5. Notably, the right atrial mass also was attached to the interatrial septum.
I'm going to stop you there. Can you go back to your last slide?
Yeah.
I'm going to ask Dr. Rogala. No, back slide.
Yeah.
First, I'll ask Dr. Lestucci. We'll ask her from an echo point of view. Have you seen anything like this? And Patrick, I'm going to ask you the same question.
No, I never seen something like this. Beatrial, no.
Patrick?
Well, I have seen one case, and that was in a publication from, I believe it was 2012, out of China, but I have never seen a case here in my practice. And
we don't have motion on this, but
unfortunately, no. It's 2 years ago, and I just collected the available data.
I'm not saying in a bad way. I'm saying we don't have motion like this. I'm glad you have that picture because the picture is worth 1,000 words. I mean, that's a gigantic tumor. I had an opportunity to go teach in Ethiopia, and I saw the biggest mixomas or cardiac tumors that I've ever seen in my whole life, and they were something like this.
Actually, patient was symptomatic 6 months ago, so yeah, it's maybe neglected.
When you see mixomas like this in Egypt, Osama, are they usually big like this? Not biatrial, but are usually big tumors or smaller tumors?
Well, we see smaller tumors, 1.5 centimeters and 6 or 7 centimeters as well. But all in the left atrium or right atrium. Yeah.
May I ask, where was the point of attachment? Was a sessile or was a small point of attachment in the lower part of the interatrial septum?
Well, the right one was pedicled going to the fossa ovalis, and the left atrial mass had more attachment to the septum, broader septum, about 2 centimeters.
The difference between a malignant and a benign tumor of the atrial septum, it can be very deceiving.
That's right.
How certain were you that this was a myxoma?
What is that, sorry?
I said that the difference between a benign and a malignant tumor can be very misleading. Can be very deceiving in terms of a difference between a benign and a malignant tumor.
For sure. You mean intraoperatively or echocardiographically?
Was it obvious on the electrocardiogram that this was a myxoma?
Yeah, the echocardiographer suggested myxoma.
Yeah, they often do when they see something on the tumor. But did you see the echo? Are you used to seeing the echoes there? Did you see the echo?
Yeah, for sure.
And did it look like a myxoma to you? Did it move like a myxoma?
Yes, it was, and going through the mitral valves like the classic myxoma. Yeah.
If I may comment, it is the only thing that is against the malignancy is that the interatrial septum seems free from the tumor, so there are 2 distinct tumors. But on the other hand, when an echocardiographer say it's a myxoma, it's just because they think that the more likely diagnosis is myxoma, because they usually you see myxoma, but you cannot distinguish by the echo a myxoma or a myxoma or a sarcoma, myxoid sarcoma. It's impossible. This is why some myxomas, some sarcomas are misdiagnosed as myxomas.
The left side is pedunculated through the through the mitral valve. Was the right side just as mobile as the left side, or is it less mobile?
Yeah. Both of them were reaching to the valve, but the left one was more going to obstruct the mitral valve.
Juan, do you have any comments from South America?
No, RJ, I haven't seen one of these before. We do see occasionally very large myxomas, mostly on the left side, and ones that can prolapse into the left ventricle, obstructing the LV inflow, of course. And as Dr. Destucci said, there's really no way of knowing whether you're dealing with a sarcoma or a myxoma until you go in and remove them. So I'll be very interested to hear what the approach to this massive tumor was.
Yes, Dr. Wogala said that one of the things they could do is an MRI with gadolinium enhancement. And how would that differ with myxoma versus sarcoma or other malignancy, a secondary tumor or something?
You mean from the diagnostic late gadolinium point of view?
Yes. So
the late gadolinium sort of shows you a chronic fibrotic tissue in a mass. So there is a caveat here. Acute and medium acute myxomas do not show late gadolinium enhancement, but there are some large ones, in particular when they become chronic, where you might see some at the base and the pedicle, you might see some enhancement. Sarcomas have a very heterogeneous enhancement anyways. We wouldn't use late gadolinium, we would use the early gadolinium perfusion. In sarcomas, very heterogeneous and no uptake on myxomas. So for the differentiation, we would use the early phase, the perfusion. Late gadolinium helps us to distinguish a fibrous component in tumors from no fibrous component.
So for instance, if there's a late gadolinium enhancement, it's probably not a sarcoma because they grow too fast.
Correct. And it's very aggressive tumor. It doesn't even have time to build anything, right?
but they would have early gadolinium enhancement because
Yes.
there's good flow through them.
Yes, that is correct.
Now, what about a PET scan? Dr. Lestucci talks about a PET scan. I have read literature about myxomas sometimes do light up on a PET scan. What are the problems with a PET scan with a myxoma? And
Well, there's a number of challenges. As you said, well, a negative uptake doesn't exclude anything. That's number one. Number two is they're mobile, they're moving. And so spatial resolution can be an issue in the heart. Then the myocardium is showing an uptake. So it's okay. I think PET is great when it comes to establishing the activity of a sarcoma and anything else, in particular when it goes outside of the heart. For differentiating myxoma, I'm not sure this is the primary target.
I think we with the PET to reduce a myocardial uptake at PET. You should give a ketogenic diet the day before, and the longer fasting period, at least 15 hours of fasting hours, and you abate the uptake. I know that PET is not may have gray zone, but in such a large mass, the PET the uptake is visible. Also, if it's mobile, it's not. It's a problem if it's a small mass, and we distinguished if the uptake is very high. It's probably a malignant tumor. Maybe also a lymphoma, also lymphomas. But if you have no uptake or very low uptake, it's probably malignant. So it's I think that no one technique is enough to make the diagnosis. But the pathologist makes the diagnosis.
That's
if you put several techniques together, you can balance the limits of one technique to the possibility of the other technique.
Would agree. Thank you. Absolutely correct.
Dr. Lestucci, you're an expert in echocardiography. You were born an echocardiographer, I understand. So you know, people ask me, especially the students that I teach. I get somebody who I think is a myxoma. It's something in the left atrium coming from an interatrial septum, highly mobile as this is. And they said, aren't you going to get all the other imaging you always talk about? When do you stop getting imaging on something that looks like a typical myxoma?
But I don't think that you can stop imaging. So I think that the best thing, as Cesar said, civis pacem para bellum. So if you want the peace, prepare to the war. So if you have not, if you have any doubt about the benignity or malignancy of this mass, approach it as if you are malignant. So prepare to make a wide reception and so on. In this particular case, this is a still frame, so I don't know if moving maybe is easier to see. But I've seen also cardiac lymphomas that are much like this one.
Yeah, I was going to ask you that question.
I had a case of cardiac myxofibrosarcoma who was operated as a myxoma, was completely indistinguishable from a myxoma, and actually was malignant. We had also a case of a patient who had at the third operation, second redo operation of a myxoma, was turned out to have a myxoma, a mass, including a part of myxoma and a part of malignant tumor. So this is really challenging. A mass so large, so the patient was symptomatic, the mass were large, so there was no other option than going to surgery. But going to surgery prepared to find something malignant, say, okay, if it's malignant, I have to be ready to cut larger and so on.
Yeah.
I think the echocardiography is not enough. Can give you some impression, but not the diagnosis.
I've seen I've seen a few lymphomas and a few sarcomas, obviously. And I find that if it's very solidly immobile, that is an indication that it's not probably a myxoma. If it's mobile, highly mobile, it's either a myxoma or a fibroelastoma. This could be a fibroelastoma. Obviously, we haven't seen it move. But we've had a number of patients who've had fibroelastoma who have gadolinium uptake and they move around. It looks like a myxoma. It even has the little lakes inside there. It looks like they have lakes inside there and they're fibroelastoma. But I found that if it's not mobile, that's why I really, really be careful about what I do next in terms of operating. Are the lymphomas, you say, sometimes highly mobile like a myxoma?
Yes, I have seen a sarcoma highly mobile like a myxoma. So I agree. If it's not mobile, it's more likely to be a sarcoma or a lymphoma. If it's highly mobile, maybe it's a myxoma, but maybe it's a myxofibrosarcoma. You cannot say before.
So some of those malignant tumors can be highly mobile.
But since the myxomas are much more frequent, you can, if you say, okay, it's a myxoma, you have more probabilities by an analysis. You have more probability to be right, but just because myxomas are much more frequent.
Right. But what I mean is, can you have a highly mobile lymphoma?
Yes, I've seen also this.
Yeah, you have, eh?
Yes.
I'm going to ask Juan a question. Juan is probably a way better surgeon than I am. Do you do a minimally invasive surgery? You do. I know you do.
I do. Yes.
Do you do this minimally invasively?
Oof. Probably not, RJ. I wouldn't be quite comfortable approaching this through a left mini thoracotomy, which would be the ideal approach to the left atrium. Particularly considering that you might have to do what Mike Reardon would call a partial auto transplant. This would probably require mobilizing the heart and detaching the aorta, detaching the SVC in order to be able to do a biatrial approach and remove the entire tumor as well as attachments to the septum. From this image, what I want to ask Usama is whether there was involvement of the roof of the atria. Was the tumor attached to the roof of the atria or not at all?
No, not at all. It was totally to the septum.
Okay. So
yeah, unfortunately, yeah.
In short, RJ, I would not be comfortable approaching this through a minimally invasive incision.
If it was one side, just one side, would you?
Yeah, if it's highly mobile and you can clearly see the attachment, I wouldn't see why not. My concern would be the handling of the tumor, being able to avoid seeding or disrupting the tumor, given how friable myxomas are in general. So if I have the adequate tools and a bag in order to remove it from the chest, I would.
And what about you, Juan? When do you go on to the next step other than just saying, yep, this looks like a myxoma? I mean, highly mobile, we all think about that. But Dr. Listucci said sometimes malignancies are highly mobile as well. When do you sort of stop and say, oh, maybe we better move on to a CT scan or an MR or something like that?
Our approach, RJ, is the same Patrick was suggesting. We usually go straight to an MRI with late gadolinium enhancement to try and characterize the tumors. that of course is if you have a patient that can tolerate being supine for a prolonged period of time while the MRI is being performed. From what Usama or Dr. Hamza is describing, this is a patient that had to be taken to the OR fairly quickly, and a diagnosis made intraoperatively and based on pathology.
Yeah, because the patient was so symptomatic. But do you do an MR on all your quote unquote mixomas, or just some of them? I must say I don't. Yeah.
No, I just some of them. If we suspect a malignancy, and we're not quite sure, you can never be 100% sure. But if the tumor is fixed, if we're concerned that maybe a malignant, there may be a malignant component to it, or if we have an unusual location of the tumor, we then proceed to an MRI preoperatively.
Okay, great. Patrick's made some comments there. I'm glad that he made those comments. If you want to say anything other than the comment.
Yeah, I just say, sometimes MRI is not readily available. And I mean, we're looking at an international conference. Not always would someone have MRI with this technology at hand. I mean, many of those tumors are incidentally found, and we use CT for all sorts of things. Meanwhile, for screening, for cancer, if patients have something else. So when someone comes across a low attenuating, pretty round, well-defined mass in the typical location, it is possible to suggest myxoma on CT as well. I would be careful in not saying that's definitive, but the appearance strongly might suggest myxoma. And then is the question, if you don't have MRI together with echo, would that be sufficient enough to characterize the mass? Possibly, yes.
And what about if it's a lymphoma or a sarcoma? What's the difference between?
Yeah, that's a very good question, RJ. The challenge often is it depends how the CT was being done.
Yes.
Most of the time, we use CT for many other purposes in malignancies. And then there's enough time for the contrast medium. We typically call it total venous perfusion phase, which means 50, 60 seconds after injection of contrast material, which is enough for lymphomas and sarcomas to take up in the early phase contrast. So they are typically bright. And in those circumstances, we don't overwhelm the heart with dense contrast material. So we have some differentiation here. The challenge comes when we use first pass imaging, for instance, in cardiac CT, where really the goal is to see the coronary arteries. This is first pass, and almost all tumors are dark. So then I would be very careful in making any further interpretation. The option is always to take a late phase imaging once you identify on the spot, but typically that's not being done.
I mean, that's important. That comes down to the history that you as a radiologist get. Most often you guys get a history, please do CT scan and that's it.
Yes.
But if we say we're worried about a tumor in the heart, you would protocol it differently.
Yes, that is correct. And CT is being done for staging, right? So the advantage is you can get some initial assessment plus the staging at the same time. I would, however, say if you have a dedicated question, as we discussed before, specifically myxoma versus everything else, I would go, if I have the choice, to MRI.
Yes, as you said, if you're lucky enough to have one in your institution. I think I'm just going to make a general comment before we let Usama carry on. It's very important if you're going to get into the cardiac tumor game to know your radiologist very, very well. And it's really, really important that you sit with your cardiologist to go over echoes and with your radiologist to plan what kind of imaging to do next. It's so important. So I just want to make this. Okay, Usama, I'll let you carry on. Sorry to stop you there. It's not that we didn't trust what you said. It's just a good talk. Okay, you can move on. I think it's somebody has their phone and their computer on at the same time. carry on, Usama, with your next slide. There we go.
Okay, sure. Well, we took the patient to the OR immediately because of her general condition. Actually, she was deteriorating once we had done the transthoracic and they gave us this unusual picture. We carried on the trunk to the OR immediately. Our approach for this surgery is right atriotomy. We found the right atrial mass attached to the fossa ovalis. I removed the right atrial mass shaving from the septum. Then I started to identify the attachment of the left atrial mass, started to open the septum, excise it circumferentially. I had to excise it generously because the attachment was broad than the right side. Actually, to deliver this large mass from the left atrium, I usually and safely go for left atriotomy to help delivering the mass instead of squeezing it, avoiding fragmentation or disattachment of anything of them. So actually, it's right atriotomy helped by left atriotomy with complete excision of the septum that repaired with autologous pericardial patch.
Actually, your behavior was optimal. So if even if this was not a myxoma, even if it was a sarcoma, you made a wide exclusion of the interatrial septum. So the risk of leaving some inside tumor was avoided. The problem with the surgery of supposed cardiac myxoma is if you could start the insertion and not around the insertion site. So this is at this point with these masses, it wasn't unnecessary to say before if it was a malignant or not. And what was to do was what you did actually. So cut wide, cut wide and not leave anything inside because
that's right.
Okay.
This is a myxoma that has a fibrotic exterior to it. There's your thing there. When you first cut in, did it look like a myxoma to you? Did you know what it was?
Yeah, actually, as you can see, especially the left picture, yes, it looked like myxoma to me.
It looks like a myxoma.
Yeah.
That picture looks completely different than the one on the previous page. Previous slide. Can you go? This was the right side. No, this is a left-sided mass. That one there, was that the right side?
That's right. This picture for the right only, for the right mass only.
And the one in the bucket, what was that? Was that the same?
It's the other one.
That's the other one. Can you leave it there, Patrick?
Yeah.
First of all, do you think that moved very well on the echo, eh? That moved very well in the echo. It was highly mobile. Oh, he's frozen. Patrick, can you tell us? We're looking at that. It looks like it's a fibrotic exterior and a tumor in the inside. What would you expect to find an MRI with that? Would you expect to find late gadolinium outside, and how would you expect?
Exactly. I was thinking the same thing if I should comment on it. So those are the components in myxomas which can actually take up some contrast on late phase. In fact, when you see it, there looks almost like a polypoid mushroom type of internal structure. And the fibrotic tissue is typically then attached at the bottom, almost like the pedicle in a polyp. So had we done an MRI, which was not available here in this case, I would suspect it would light up on LGE.
And do you think you would have made the proper diagnosis here?
You know, the fact that early perfusion, early gadolinium enhancement is practically non-existing I would assume, again, with all the uncertainties we're having, it would be a pretty firm diagnosis, giving those features.
Juan, do you have any comments about what it looks like?
Oh, not really, RJ. I agree with all that's been said. It's not as typical Mixoma as you would expect, though. Right? Not the multilobulated, friable, almost gelatinous mass that we're used to seeing. And on the next slide, you get the impression that it has that kind of fleshy.
Yeah, move to the next slide, please, Osama. Yeah.
That fleshy, I mean, it.
Can you show us the next slide? There you go.
Yeah, you see that I mean, it's hard without touching it, but it looks meatier than I would expect a typical Mixoma to look and feel.
You know, the when I said it, you know, we haven't seen the images, so there is a degree of speculation, but if you have a neoplasm, a tumor in the heart that has a significant portion without any reaction to the surrounding contrast material, that's very indicative. And the challenge always comes when we have two different entities at the same time, right? So it's not totally excluded that you have two histologies at the same time. Would be super rare, but we're not looking at a typical case anyways. So I would assume we would have described it as most probable Mixoma, and that would be very likely the diagnosis here.
In the time where you're questioning the diagnosis, I will send the person to our cardiologist to do a transvenous biopsy of this. And you can see in the previous page, there's a layer of fibrosis overlying the tumor. And this is one of those times where the transvenous biopsy, this was, you know, if we haven't seen the moving images, and the patient needed to go to the OR, but I'm talking about a different situation where a person has a tumor, you're questioning what it is, it may not be moving very much, you ask for a transvenous biopsy and it comes back as non-diagnostic. If you were to have not both sides, or even we'll talk about both sides, one side, what can you do for us, Patrick, from a percutaneous point of view? Can you go through the back like an old Sohn's technique and go through the heart, or what would you do for that if we were to ask?
You could, yeah, that's a very good question, RG. You could. I have to tell you, the atria are probably the most challenging areas for biopsy for access reasons. One could come from interior, but then we need to be careful that we, you know, space out the coronary arteries on either side well enough so we have access. We could, and we do it, let the lung collapse entirely, like in pneumothorax, we use carbon dioxide and then get access to the atria. It's possible. I would argue, though, atrial biopsies are probably the riskiest one, much more than further anterior, but depends on the location and the size of the tumor. I think it would have loved to explore it. One needs to see the images.
Yeah, so could you theoretically, I'm not going to push you on this because you're in my hospital, could you get an intracardiac mass biopsied?
Possible. Yeah,
Is
possible.
that right?
Easier through the left ventricle than through the right, because there's more vascular mass that helps seal any access route. That is possible. We know if we go through the ventricle mass that it doesn't really cause any harm. You know when pacemakers drill through, it doesn't cause any action. But again, we're entering really very dedicated biopsies that need a very thorough investigation and clinical question.
Yeah. Juan, do you have an interventional radiologist that will do percutaneous biopsies for you, or am I more lucky than you?
No, you're a lot luckier than I am, RJ. We're looking to send somebody to get trained over there, but our interventional cardiologist will do some. The problem is you need a particular kind of catheter and needle in order to get enough tissue. Some that we don't have access to in Colombia right now. So most of our needle biopsies or transvenous biopsies will come back indeterminate. So we tend to, you know, in large tumors that are you know facing outside of the heart or that protrude outside of the heart, either ventricle or atrium, we tend to do those under direct vision, and we will approach those thoracoscopically on occasion. But as we know, most of those are highly vascularized.
Yeah.
You mentioned the talk on given last year on that topic. It's a fascinating topic, and you know what we tend to see is a lot of these patients coming to us with complications, having had complications from percutaneous attempts to biopsy those masses. So that's why we've evolved to a thoracoscopic approach to those patients.
That's interesting. Yeah, we haven't had as many problems, but I still think it's worthwhile. I've had some good luck with lymphomas. 1 week I had 3 lymphomas, and two of them were biopsied. 3 of them were biopsied percutaneously, and we got the answer. But some of the times, as you say, it comes back indeterminate. But I think it's worthwhile to try, as long as it's not too dangerous. It sounds like you're having some issues that you've gone to a different approach, but you're lucky also to have a thoracoscopic approach, because we don't have that luxury. As I said, you're more advanced than we are here.
No, come on.
All right, Usama, do you have any more slides to show us? An interesting case to generate a lot of good discussion.
Well, just running of the pathology, it showed classical atrial myxoma. We don't have any more comments. It was classic myxoma.
Yeah, you can definitely see the myxoid tissue there, can't you?
Yeah. So patient went well and followed up for 2 years. We follow about 6 months. Do you have a protocol for follow-up of these cases, RJ, by the way?
So I tell people that they should have an echo for the first 5 years, because I had assumed that the recurrence rate is highest in the first 5 years. But for all of the research I did for this talk, I've realized that it can be a little bit longer than 5 years. But that's what I do. I tell them every year for the first 5 years. Juan, what do you do?
Yeah, usually we go for 2 years.
2 years, yeah.
If the patient is fortunate and coming, sometimes we lose.
Juan, what do you do?
I tend to have the same problem Usama has. In patients that I can follow, RJ, I tend to follow them yearly for as long as I can. If they have been referred to me by an outside cardiologist, I tend to or try to stay in touch with the cardiologist and follow them with yearly echoes to make sure that nothing is coming back. But the truth is, we usually are able to follow them for an average of 3 years, after which they consider themselves to be in too good shape to come back to the hospital.
Yeah, I think that's reasonable. And Chiara, what do you do in Italy? What do you do with these people?
For Mixoma, yearly echo for at least 5 years. For the strict follow-up for sarcomas, it's that it's due to the fact that in a short time they can change. The patient who I reported who had the relapse, local relapse after 18 months, had a normal MRI on normal CT scan, no signs of relapse on February 14th. I remember because it was February 14th, it's Valentine's Day, and he had signs of relapse on June 16th. So in 3 months, the local relapse was evident at CT scan.
Okay, well, that was a good first case. No more comments from the audience. Please feel free to ask any questions that you want to ask. because these are the experts and you can ask whatever you want. I tend to be a hog for the.
So I think that in the.
Go ahead.
So for the one a year is enough. Also because they don't grow, if they have a relapse, they don't grow so quickly as sarcomas do. If a sarcoma, you need a strict follow-up. For a myxoma or fibroblastoma, it's not so urgent, because even in case of relapse, the growth is lower.
You do a follow-up echo or routine follow-up echoes for people who have fibroelastomas after, say, the first 6 months?
Yes, we do. We do yearly echo, but I've never seen
after operation. I mean, after operation.
After operation.
Here, and have you picked up any new ones or no?
But I've not seen any relapse so far.
And what about in Egypt or Colombia? Do you guys do it for fibroelastoma as well?
Sorry, I didn't hear the question.
Oh, for fibroelastoma, do you have an echo follow-up period or anything like that for fibroelastoma?
Yeah. For all tumors, for cardiac tumors, we do. Yeah.
And one?
Fibroelastomas, I tend to follow for a couple of years only, RJ. No, not beyond that.
All right. Okay. Well, that was a great first session. The next session is going to be Dr. Umama Awan. You're next. You're going to give us a talk about a different kind of a tumor, multiple sections, but a little bit different. So let's see what it has. Oh, Robin, you're there. Robin, this first one was a benign tumor, so you didn't have much to say, but we'll get to these other ones, especially.
Yeah, hi, RJ. Thank you. It's
Oh, we saw it, Juan.
Okay, coming back. I was muted, and there you go. All right. So this, RJ, first of all, let me congratulate you on putting together this program. It's really a wonderful effort, and thank you so much for the invitation. This exchange of knowledge is absolutely critical for any condition, but more importantly for this type of pathologies, where really what we see is very piecemeal at other than very large institutions such as the one in China you just mentioned. So this patient is a 39-year-old female who came to me by the end of 2020. Previously healthy, she used to work out on a regular basis, and presented with a month history of worsening functional class. And she decided to visit a cardiologist or see a cardiologist in her hometown, which is a secondary city south of Bogota, because her husband actually noticed that she was not really in as good a shape as she had been before, and couldn't keep up with her daily tennis routine. And what the cardiologist found was a LV inflow and outflow obstruction causing severe mitral valve stenosis and aortic valve stenosis, which really was an LV outflow obstruction with this transthoracic echo on arrival. So with that echo, they called me up. She got on a plane and rushed to our hospital where we did this study.
Okay, Dr. Lestucci, what do you think about that? In Bogota, in south of Bogota, is she in a rural area? Or it sounds like if she's playing tennis, she's not in such a rural area.
Not so much as a small secondary city, RJ.
Yeah.
But with no large.
Oh, you're cutting up, Dr. Lestucci. Hopefully she'll get back online. Patrick, what would you think about that?
I'm not specifically trained to do echocardiography, so, but I would assume we might look at the same entity, or we might look at two different entities. We might look at something that is mobile.
Okay, can you say this is in a short time?
I shut up, no worries. Go ahead, please.
You were cutting in and out, Chiara.
Maybe
I'd really like to see what she says, because I was going to ask her, could this be rheumatic disease on the mitral valve? Acute rheumatic disease. Wow, look at that. That doesn't look like rheumatic disease, does it?
No, not really. Not really.
Rheumatic disease can cause thickening of the leaflets like that. Acute rheumatic fever can cause that, I think. But that's a big lump. That's what I was curious to see. I was going to try to test her to see what she said.
Let's see if we can get her back on the line. In the meantime, I'll continue to show you the images. But what was striking, and we'll go back as soon as Dr. D'Astusi comes back on, is that this patient had a transmitral gradient of 22 millimeters of mercury. It was to me, it was amazing that she was able to walk to the airport. And here you have another image showing the compromise of the posterior mitral leaflet and the posterior ventricular, the posterior LV wall, and an aortic valve gradient with a peak of 60 and a mean gradient of 40.
Wow.
So she really was very sick, didn't show it, but was really a dramatic presentation. And of course, they were extremely concerned when they looked at the echo, and when her cardiologist showed them the echo. Again, no previous history of anything. She was absolutely healthy, 2 young children, and she lived. The city where she lived was approximately 600 meters above sea level, and she traveled to Bogota, which is 2,700 meters above sea level, which is about 8,500 feet. And she was slightly dyspneic, but not dramatically so.
Out of the inflow of the mitral valve at a 20 millimeter gradient, and the outflow gradient, mean gradient of the aortic valve was, what did you say, 40?
40, yeah. So she had inflow and outflow obstruction of the left ventricle, which you can see here, with clearly what appear to be 2 different masses. One that what seemed to be attached at the apex of the left ventricle and protruding through the LV outflow tract, and occluding it at end of systole, as you can see there. And then there was a second one that was involving mostly the posterior mitral valve leaflet and extending into the posterior papillary muscle and posterior LV wall. We couldn't see anything outside the heart. She did not have a pericardial effusion and had no signs of tamponade.
I'm gonna bring Robin Jones into that question now. If and I don't know what the answer here is yet, because I don't know how the story is going to unfold. If he were to get you a biopsy and said that this was a sarcoma, transseptal biopsy, and they were able to biopsy this and said it was a sarcoma, say an intimal sarcoma or something like that, would you be willing to give somebody with these gradients this cardiac dysfunction by echo chemotherapy, neoadjuvant chemotherapy? In other words, when do you say no to neoadjuvant because the patient's too sick from a heart point of view?
So that's a great question, RJ, and I think my short answer to that would be know in this sort of situation, simply because of the drugs and the schedule that we use. And I'd be very concerned about giving combination chemotherapy preoperatively in this situation. Again, I'd sort of have a close discussion with the surgeon and with the radiologist regarding the situation, but my sort of instinctive answer would be no. Following on from that, as a general rule, even though the UK in terms of pre or post-operative chemotherapy for sarcomas is generally to not administer chemotherapy, for intimal sarcomas and cardiac sarcomas in general, we would usually administer preoperative chemotherapy.
How much do you expect the tumor to shrink with each session of chemotherapy? In other words, 3 weeks. How much would you expect with that portion on the mitral valve? Would you expect that to get better?
I think I wouldn't expect a dramatic response with one cycle if this proved to be an intimal sarcoma. And again, that would factor into the decision-making process. Having said that, I think intimal sarcomas, even though in the past the sort of dogma that they don't respond to chemotherapy, a retrospective multi-institutional study that we did showed that they did have, or they do have a relatively reasonable response rate to chemotherapy. So basically, for patients with localized disease, the response rate was 38%. So that's not, not bad, but I wouldn't expect a dramatic initial response as you'd probably see with a lymphoma or some other type of tumor. And I think that would factor into the sort of decision-making process regarding neoadjuvant therapy, because I suppose if we had a very high chance of a dramatic initial response, I'd be more prepared to consider preoperative treatment.
If this were a lymphoma and the patient were in heart failure, as this patient sounds like she is mild heart failure, at least she's symptomatic from the obstructions, would you expect the lymphoma to melt away? Not totally, obviously, but cause a significant improvement in one dose, in one course?
Yes, I'd suppose there's a
You would?
yeah.
Wow.
But for sarcomas, I wouldn't expect that. I wouldn't expect that sort of initial dramatic response. Having said that, sarcomas always sort of amaze me and always do things that you don't expect. So probably now somebody's going to say, well, we treated with it was an intimal sarcoma and we treated with neoadjuvant chemotherapy and there's a dramatic initial response. So I suppose my point regarding that comment is that it's the unpredictability, I suppose, of the timing of the response and obtaining an actual response that makes it challenging with sarcomas, if that makes sense. But I'd welcome thoughts from other members of the panel as well. I always like to debate these things. So,
are there other oncologists listening that want to open the debate up a little bit, the discussion? I'm going to ask Patrick. This looks like it's from the posterior mitral annulus right at the heart. Will an MRI be able to tell us how much invasion there is of the AV groove?
Probably yes. Probably yes. MRI is excellent in snapshotting and reduction in motion if the patient is cooperative and can actually undergo the study? I think we probably would. Yeah, I would suggest if there's question regarding the invasion and the depth of invasion, I would assume that MRI might be the next reasonable step.
Yeah. Okay, Juan, we'll let you get back to it. It's a very interesting case so far.
So we took all this into consideration, of course, and we did talk to our oncologist who totally agreed with what Robin just said. And given this, you know, the gravity of the situation and the gradients that we were seeing, and clearly the risk of progression of either one of the two obstructions, we opted to take this patient to the OR emergently that same evening. Cannulated the distal ascending aorta and did a distal bicaval cannulation, planning to do an auto transplant if necessary. So we initially approached this through a left atriotomy that we extended to the roof of the left atrium without dividing or you know, cutting the superior vena cava, and found her to have extensive tumor infiltration of the posterior mitral valve leaflet and annulus towards the posterior medial commissure mostly. And this extended into the posterior papillary muscle and posterior wall through the LV trabeculae. We proceeded to excise the mitral valve and do a subendocardial excision of the mass as far as we could, extend it into the fat without, of course, injuring the circumflex artery, which you can see in one of the images there. But needless to say, we weren't able to get a full and free margins. The second mass was a large solid mass with a pedicle that attached it to the LV apex. We were able, once we removed the left atrial and mitral tumor, we were able to approach this through the mitral valve annulus, and we're able to resect that completely with its pedicle. And this is what we got. So you can see there on the left is the left ventricular apical mass with its point of attachment at the bottom there. The left atrial mass that extended into the posterior mitral valve leaflet, and the multiple sections of that mass that was involving the posterior LV wall, which of course we weren't able to resect, unblock. That part of the tumor was quite friable, as you can see here.
Well, Juan, did you get a coronary angiogram?
We did not. We did not get a coronary angiogram preoperatively, RJ. We probably should have. But
did you regret it afterwards, or were you okay with it? When it's
No,
so close to the AV groove, you wonder if it's a left dominant versus right dominant system. I guess you'll know if you can't come off bypass to do some bypasses there. But
yeah, we stayed away from the circumflex, and the mass didn't seem to be extruding outside of the ventricle or into the AV groove, so we were able to stay away from it. We probably should have gotten a coronary angiogram, but again, this was her mode of presentation was so dramatic and her symptoms such that I was concerned she would not make it through the night.
Yeah, no, I mean, obviously this patient had a very, very bad tumor. The other thing about it is that that stuff near the LVOT there, it looked like it was getting ready to break off. It's quite interesting. When you looked at this, I was expecting it to be more friable. I was expecting the posterior papillary muscle and posterior wall mass. That's what I was expecting the LV tumor to look like near the AV, near the near the aortic valve, but it obviously it didn't. It looks totally different.
Yeah, what you can see here in the middle is this big mass here was the one that was compromising the AV groove and extending towards the left atrium. Then right here you can see the posterior mitral valve leaflet, and within this mass here is the posterior papillary muscle, which was excised completely in order to be able to get down to the base of the papillary muscle and to the LV posterior wall in order to be able to remove as much of the tumor as possible. Of course, we saw this and at that point not as a curative procedure, but more of a debulking procedure in order to be able to save the patient's life, and then proceed to treat it with chemotherapy,
Right.
and look for alternatives in the future.
Why did you not go through the ventricle? Was it too much, or just a little bit not what you would expect to do?
No, it seemed like we were, as we resected the endocardium and some of the trabeculae together with the posterior papillary muscle, it seemed we had a fairly clear margin, although we of course did not go as deep as you would have wanted to go. She had a small ventricle too, so the extent of the tumor would have left us with a restrictive cavity probably.
I see. Yeah. From that CT scan or the MRI, the echo that you showed us, it looked as though the AV groove was really, really involved. I'm surprised that you were able to get that much of valve out. It looked like it came through the annulus, through the AV. There.
Yeah, you can.
Yeah, and even the previous one. Look at that tumor there, the posterior leaflet. It looks as though it goes through the AV node. The anterior leaflet looks a little bit thickened too, I guess. But
it's this of course is a posterior, the posterior, the
leaflet there.
The posterior medial commissure right here, RJ. So that was fused, and you can right start there to see the circumflex artery back here.
Yeah.
You see?
Yeah.
So we went down, went through the left atrium, resected the endocardium here, saw the fat, the periarterial fat, and came down into the ventricle. I mean, she was young enough, had enough endocardium on the ventricle and the atrial side that we were able to replace that valve with a mechanical valve, and I placed a mechanical valve into her, looking for an optimal hemodynamic profile, and thinking that she was probably going to need anticoagulation postoperatively anyway, because of all the raw surfaces. The pathology on that mass was a high-grade synovial sarcoma, highly undifferentiated. So she was treated with several courses of chemotherapy by.
Ask Robin what he would give. What's your next step, Robin?
Yeah, so for a young patient with a high-grade synovial sarcoma, we would give postoperative combination chemotherapy.
And when would you start, Robin?
In this setting, if she'd made a good postoperative recovery, probably within a few weeks of the operation, basically.
Like a couple of weeks.
Yeah, very promptly. Again, depending on how well she recovered from the operation, but given the aggressive nature of this, I think, and given, as Juan pointed out, the operation was done as an emergency, essentially. I would be keen to start treatment very promptly.
And would it matter? He told us, Juan, you said you think you had residual tumor left behind at the annulus level or inside the heart?
Inside the heart, in the posterior LV wall was my main concern, RJ. She was treated exactly as Robin described, and on her follow-up echo, she actually decided to visit Mike Reardon's team at Methodist and MD Anderson, where they did a transesophageal echo that showed, at the 6-month follow-up, a small mass in the left on the left atrial wall at the interatrial septum, and that was confirmed by an MRI, and we did a PET scan as well that didn't enhance. So there was always the question as to whether this was a small laminar thrombus, as we didn't see any growth of it, and the lack of enhancement made us doubt about a recurrence of the tumor. But it was a remote area. It was a remote recurrence, if a recurrence at all. In other words, it was compromising the interatrial septum, where we had not found any tumor during the original operation. So she went to MD Anderson, underwent a few courses of chemotherapy with no regression, actually a progression in the size of the tumor, and Mike ended up operating. Oh, go ahead. I'm sorry. It's a shame that Mike is not here because it would have been.
He's supposed to be here. He must be in the operating room or something, because he's supposed to. I know. So you say that there was a mass that came a few months later after she finished chemo, or during the chemo, or right from the very beginning?
After finishing chemo, we did a follow-up MRI and found that small mass that was either a thrombus or a recurrence of the tumor, but it was located at the interatrial septum, where she didn't have any tumor previously.
And you said that the MRI didn't say much, didn't give you much information.
Didn't give us much information, Robin. I'd like to hear from Robin.
I was going to ask him.
What his
and from Patrick as well. What kind of modalities we can use? Is a PET scan worthwhile here? Or Robin, both of you guys can pipe in on that.
Well, Patrick is the expert, and I've been very impressed with. I will have that. I'll just say
there's an ask. You go to ask the radiologist and say, "Are you crazy?" So why don't you see what you're going to ask him for and see what Patrick says in response? I think this is great.
It's very difficult to image these anatomical areas, and particularly after surgery. And we tend to use a combination of modalities, basically. But this is really, really challenging, and it can be very difficult when we're giving postoperative chemotherapy to know exactly what's going on in that area. So as I say, we use a combination of techniques depending on the surgery that's been performed and the tumor type, etc. But I'm really, I'd like to sort of talk to Patrick and Juan about the best way forward with this, because as RJ said, sometimes the radiologists go, "What are you doing? Why are you ordering these investigations?" So I'm really interested to see what you have to say.
Yeah, it's really a diagnostic dilemma in the sense that any technique we have, particularly when we look at MRI, will pose a challenge upon us, because we will have inflammatory changes, we will have some residual tumor, we will have some infiltration, we will have some scars from the previous surgery, and all the tools we use will be compromised by this effect. So post-operatively is a huge dilemma. It's such an aggressive tumor. I would agree with you. We probably would do both initially and see if there's any tumor we can detect, maybe in a cardiac CT, see if there's any outside, invading into the pericardium, maybe anything into the lung, to clear that margin. And the rest we probably would do an MRI, see what we can do if we have any clue of residual neoplasm or further, recurrence. It's going to be challenging.
These little lumps that show up after you do a cardiac resection, especially of the atrium, we don't know if it's a thickened fold or something like that.
Yes.
There's such a hard thing to deal with.
Yes.
How do you deal with those, Robin?
Yeah, good question. In the UK, we often basically just use a sequence of scans, and unless the patient is symptomatic, or if there's an obvious problem that's evolving. But often we'd have a very careful policy of just regular imaging and monitoring the situation. But again, it'd be good to hear what everybody else has to say. But often we just, if the patient's asymptomatic and there's no sort of dramatic change, then that's what we do. I mean, do you have any thoughts on Patrick and Juan and Chiara as well?
You're raising a very good point, which is serial imaging, and quite often the temporal evolution of findings is the best indicator as to what is going on. Just one snapshot alone might not give us the answer.
Right.
So unless the patient is very symptomatic. Sorry, Juan. Sorry.
No, go ahead, Robin. I was just gonna say that I totally agree, and that's what we did. So we did serial MRIs without seeing any growth. We of course assumed, given the pathology and the surgery that was performed, we had to assume that this was a recurrence of the tumor, and gave her further course of chemotherapy, with which we did not see any further growth of the mass, but it remained stable. It didn't regress either.
Did you see early growth as well?
Beg your pardon?
Was there early growth?
No.
No. And what interval did you use for your second CT after you found the first one? 3 months or 1 month or what?
Approximately 3 months, RJ. It was, yeah,
and no change with no therapy after 3 months.
No change. So she decided at that point is when they wanted to get a second opinion, and I sent her to see Mike Reardon and his team at Methodist and MD Anderson.
Robin, if there was no mass there, what kind of a prognosis would a person like this have? With a synovial sarcoma, pretty extensive synovial sarcoma with an R1 resection or an R2 resection, with the early response to chemotherapy?
I would say, unfortunately, given the high-grade, undifferentiated nature of this tumor, that the prognosis is very poor. And I often prepare people, for the worst-case scenario, so that if things turn out better than planned, they're really happy. But high-grade synovial sarcoma in this location is clearly a poor prognosis tumor, unfortunately.
And would you expect this person to die of metastatic disease?
Yes, yeah. Again, local control can obviously be a problem, but clearly there's a high chance of metastases.
And Chiara, would you consider this patient for radiotherapy? We know he went to Mike Reardon. Mike Reardon is probably going to resect it because we know Mike Reardon. But the thing is that if the patient has a poor prognosis, probably from metastatic disease, I mean, it was on the left side, and it was popping in and out of her outflow tract. Would you consider doing this radiotherapy on this atrium or even the whole heart?
Unfortunately, I lost the connection.
Okay.
So I don't know the
what about
final diagnosis.
Okay, that's okay.
I saw just of the salary, the specimen, we was a fire. It was a sarcoma, two different tumors.
Synovial sarcoma. Synovial sarcoma. Federico.
Synovial sarcoma.
Federico,
Okay.
would you irradiate? Sorry, go ahead.
Yes. Okay. And the margin were clean.
He thinks of possibly an R2 resection. They treated with chemotherapy. It got better.
Yeah.
And then a few months after all the chemotherapy is finished, some mass came in the atrium distant to his resection margin, distant to his resection, in other words, in the intraatrial septum.
Okay.
And then it didn't change with time, but they gave chemotherapy anyway. And so now the question is, what would you do? Would you consider radiotherapy?
If surgery is not considered a possibility,
Then yes. So you would send for surgery.
Could try to with radiotherapy.
Okay.
Maybe because it's but it's osteosarcoma. I don't know if
synovial sarcoma.
It's radiosensitive because not synovial sarcoma.
Synovial.
So it can be synovial. You should ask to the radiotherapist if it's likely to be radiosensitive. It could be treated. Also, anyway, it's the atrium, and an attempt can be done. It depends on the risk of surgery. I see there is Dr. Novaria.
Yes.
It's online. Can ask him if would.
So remember, this patient had a potential positive resection margin in the ventricle, now has a lesion in the atrium. So what would you consider for radiotherapy? Dr. Lestoussis thinks that we should send for surgery, and that's what he had. And what do you think? Would you irradiate this? And if so, what part of the heart would you irradiate?
Good evening, everybody. I feel very honored to be here with you today. And so in synovial sarcoma is an high-grade sarcoma, and I consider chemo because it is has a high metastatic potential. But if there is a potential residual margin, microscopic positive margin at surgery, I consider radiation.
And what would you irradiate? In this case, potential positive resection margin in the ventricle and now a new mass in the atrium.
I consider a neoadjuvant therapy, if possible. I don't hear
on the mass, on the atrial mass, not on the margin, the possible infiltrated margin in the ventricle, or both.
I don't understand. The mass.
We had a resection with possible positive margin in the ventricle, and a new mass relapsed after chemotherapy in the atrium.
I consider radiation.
Yes, but on the atrium.
On the atrium, yeah.
But not the ventricle.
The mass is on the atrium. The gross tumor. Yes, I consider radiation in the atrium.
Okay. Juan, why don't you continue to let us know what happened?
So she underwent further chemotherapy, no radiation at MD Anderson, and unfortunately, the day before she was scheduled to go to surgery for resection, she had an intracranial bleed. She had a right hemiplegia, and what's amazing about this woman is her spirit, because she actually recovered from it and was sent to a rehab facility where she recovered she was able to talk and walk and started to walk with assistance, so much so that Mike was finally able to take her to the OR last week, resecting a pedicle specimen in the that was attached to the interatrial septum. The resection margins were negative, and you can see the mass here, suspectfully similar to the one Usama showed us a few minutes ago. And again, it's unfortunate that Mike is caught up in the OR because you know, we were waiting for the pathology report to see if it was indeed another synovial sarcoma or if it was a second primary. And she is recovering well. She is continuing her physical rehab, and from a cardiac standpoint, appears to be free from disease. Now, her workup to identify extra cardiac disease or metastatic disease has always been negative, Robin. She's never metastasized anywhere so far.
That's great news, Juan. Really, really good news. Yeah,
it's been 15 months now. So it's I mean, unfortunate but fortunate in a way.
That thing grew a lot, didn't it?
It did, and very, very quickly, RJ.
And was it the same chemo you gave her initially?
It was the same chemo, yes.
So she's failed that chemo. That would be considered failure of that chemo, right, Robin? If you grew this on that chemo, it's a failure of that chemo.
Yes, in a way, but again, I suppose at the there are challenges with the interpretation of imaging, particularly in the post-operative setting. So I fully take your point, RJ, but I suppose there are always sort of caveats, but it's great that she's free of metastatic disease. Really, really good news. The bleed. So why did she have the bleed in her brain, Juan? What was the reason for that?
She was of course an anticoagulation for her mechanical valve in the mitral position, Robin. I'm not sure. It seemed to be a spontaneous bleed.
Okay.
I'm not sure if it was related to anticoagulation or the combination of anticoagulation and
the chemotherapy.
And the chemotherapy, yeah.
Yeah, yeah.
What do you use for metastatic disease? Do you look for it with a PET scan?
Yes, that's what we usually do for metastatic disease, particularly as Juan pointed out, you know, that there's a risk of, and I think you pointed out earlier on in your presentation, RJ, the risk of disease spreading to the brain. So for intimal sarcomas, other cardiac sarcomas would use a PET CT.
How often would you do that?
So post-treatment, our policy would be to do a scan every 3 months.
For how long?
For the first 2 years, and then 6 months after that, and then annual thereafter.
Patrick, do you know what they do here?
Well, we use PET extensively for this indication. I have to admit, I don't know if the frequency is every 3 months. I wouldn't know this. That's very frequent, but probably required, given the dynamic and the biology of this neoplasm.
Yeah, for a high-grade tumor like this, we would. I fully take your point, Patrick, regarding a fairly intensive schedule, but we would do scans every 3
months. Yeah.
And isolated lesions to the brain, Robin, do you go after that, or do you irradiate those?
I suppose again that's sort of context dependent, depending on the exact position, depending on disease status elsewhere, and depending on the tumor type as well. But we would generally try and be fairly aggressive for an isolated lesion. Yes, i.e., you know, we would consider a surgical approach.
And Juan, what are you going to use for surveillance? Do you guys have a PET scanner in your hospital?
Yeah, we do, RJ, and we did one on her as part of the imaging sequence previously to try and see if there was uptake from that original small lesion, and there wasn't. So what we do is what what we just heard, and tend to follow them with either MRI or MRI and PET, if we can follow them at our place. Otherwise, we try to bring them back as often as possible, to image them from their referring institutions.
If I understand correctly, that looked like a big egg attached to the intratracheal septum. Is that what that was? It looked like that, right? I mean, you didn't do the operation, but that was my impression. Was that what actually it was? It looked like the whole surrounding thing was a tumor, right? Attached to the.
So this here is the intratracheal septum.
Yeah.
And the tumor was protruding,
yeah, that's what it looks like.
into the atrium, and actually making the mitral valve prosthesis dysfunctional. So Mike operated with Tom McGillivray, and between the two of them, they removed the tumor, which was, according to Mike's description, fairly easy. It was just attached, pedicled and attached to the intratracheal septum, which they removed and replaced with a patch of photofixed pericardium. And they decided, due to her intracranial bleed and difficulties in her management because of the anticoagulation required by the mechanical prosthesis, they replaced the mechanical prosthesis and changed it for a tissue valve.
Yeah, that's good. All right, well, that was another great case and great discussions around that. It's time for another little break so people can get their work done, and we'll meet again in a half an hour, okay? I think that was great. And for the audience, please feel free to ask questions. So we'll come back in about a half an hour.
Great case, Juan. Great case.
Great case. Congratulations on the case. Okay, welcome back, everybody. Hope you had a nice break. It'll be our last break. We have two other sessions, two other tumors to discuss, and then we'll give a little closing remarks, and we're done for the year. Next is Dr. Andrew Newcomb. He's been a good friend of mine for a long time. When I knew him, he had hair. He still has hair, but he's got a short haircut. It looks pretty short there, Andrew.
Yeah.
Andrew, I'm just joking. Andrew's been a friend of mine for what, 15 years or something like that.
Good while now.
He's a cardiac surgeon and one of the tumor specialists in Australia. He's going to lead one of the leading tumor specialists in Australia, if not the leading tumor specialist in Australia, leading tumor cardiac surgeons in Australia. And he's our Interact lead for all of Australia. He's going to bring Australia together. And he's going to speak to us today about a tumor that he had. And Andrew, what I'm going to do is I'm going to have you present. And from time to time, we'll stop and we'll have a conversation about it. We have multiple people here. Andrew, for those who don't know, lives in Australia. I just said that. And it's what, 5 o'clock in the morning there? 4:45?
No, it's just about 10 to 7.
Oh.
So
you're probably at work. Okay, so why don't you start and then we'll continue the case.
Okay, thanks. Can you see my screen there?
Yes.
Excellent. So this is a case that I did back in 2018 now. It's funny how time flies past, but this is the case of a nearly, at that stage, 60-year-old man who had had a bit of a tough time when I met him. He'd had liposarcoma and had that previously resected in 2003 and 2014 from left leg and right arm. And he came into our hospital in September, having had a recurrence in his right pelvis. And so I should have actually taken pictures of this too. He had quite a large, about this size, lesion in his inside the pelvic rim. And so they did a hemipelvectomy with a whole lot of other things. They took out his pelvis, irradiated it, and put it back into his, put him all back together. So it was a massive operation. He was actually doing reasonably well from that, but then had a wound dehiscence on the 6th of October. So about 9 days after he'd had this initial procedure, and they took him back to the operating room and fixed it and took him back to the ICU after that. And it was at that stage that somebody noticed some ECG changes, some anterior wall, so V1, V2, V3, ECG changes that hadn't been there when he was in the ICU, even on the week or so prior for his original operation. And so that's when he went on to then have some testing. I put this in here only because he'd had multiple PET scans. And like a lot of these cases, and probably what you've been looking at today, the PET scan really wasn't very informative in terms of identifying this cardiac lesion. This is in the RV here, and there's really nothing. It's certainly no brighter than the liver, spleen, or anything else there. So this is the echo that they performed, or one of the echo. They actually did a few echoes in the time that that he was between this diagnosis. So the first was on about the 10th of October, going on to the 29th, and then I operated on him on the 3rd of November. And you can see this this lesion inside the right ventricle. This is the tricuspid valve, and everybody started panicking. So then he had a range of imaging, not so much just to look at the heart, but also because of the low PET avidity, to look everywhere else and make sure there were no other lesions. And so this is a CT scan. Again, you can see the lesion in here. I wasn't able to save any moving files from these because they're a bit old, so they're all stills. This is his MRI. This is I had to look through all of these, and eventually I had decided I thought it was going to be attached here because it seemed to just be moving against the septum and against everywhere else, and I thought it was going to be attached out at the apex, which turned out to be the case. So then
Can I stop you there?
Yeah, for sure.
I'm going to ask, I'll start with Patrick about liposarcomas and the best imaging modalities for liposarcomas.
Yeah, so we have two images here, and I think they allow, at least for narrowing down the differential diagnosis. Let me begin with the CT, where we see a well-demarcated, fairly round, probably rather soft mass in the apex of the right ventricle. The attenuation values seem to be rather consistent with below 0, because we do have some tissue that is also on the image, which would be the liver, blood pool, esophagus, and it seems to be darker. There's another mass which I see here below the diaphragm. I don't know what that is, if this is from previous surgery, or it seems to be very similar. I saw also on the PET something, but I wasn't really sure if that's representative of an entity below the diaphragm. In any event, just based on the attenuation values, the shape, location, form, I would assume there's a significant amount of fatty tissue in that lesion. And then we go over to the MRI here, and that is a sequence that is in phase. So we typically would do an out of post phase imaging as well, because then we can see a signal drop if this is fat. But the signal intensity here is very consistent with a predominantly fatty neoplasm, or I should say lesion in the right ventricle here. And I think I would, in the first instance, would assume it is a largely macroscopically fat-containing neoplasm.
If he has a liposarcoma, they've just resected, he's had 2 previous liposarcomas, do we need an MRI? It's lovely to have an MRI, but do we really need it, or can we stick with a CT scan for a lipomatous tumor?
I would again, it's hard to say on one image, but I would feel very confident just alone on the CT image that I'm seeing here, very confident in saying it's an almost entirely fatty tissue tumor. The question then always is there a solid component somewhere? Is there a pedicle? Where is it attached? One would like to see a bit more imaging. It seems to be an iteratively reconstructed image, which is good quality. So maybe other slices would show the boundaries a little bit better, but I would be confident in saying it's very likely, given the history, a liposarcoma in the right ventricle.
And is there a difference in the Heinzfeld units with the liposarcoma, a malignant tumor versus a lipoma, or a...
I wish it would be. No, unfortunately not. The hallmark of sarcomas is, and that's the biggest challenge in imaging, is identifying non-lipomatous tissue in those tumors. I mean, the fewer solid components we have in a tissue, the less malignant they are in general, anywhere in the body. So here, essential component would be to identify some areas which are not fatty tissue. I do believe the MRI shows a few, strings of non-fatty tissue, which is concerning. A true lipoma would be just bare fat. Fat tends to be pure fat, like lipomas tend to be a little bit darker in attenuation on CT than liposarcomas, also because there's a bit of an edema, etc. But that's a tough call. We rely on the demonstration of fibrous tissue, other tissue, vessels, some sort of contrast enhancement. And if that's the case, the risk of liposarcoma goes high on the list.
I see. So you're looking for heterogeneity, really?
That is correct.
If it was very bland, you would consider it to be a lipoma or something like that, lipomatous tumor, a benign tumor potentially.
Yes. Yes.
And I know that what he did was he took this out because it looks like it is on the pedicle when he showed us the echo.
Yeah.
It wasn't. This is a pretty easy tumor for you to biopsy percutaneously, or what?
We could. Liposarcomas, just in general, and this is a very good question, is they're probably the most challenging targets to biopsy, because what you get is fat.
Right.
And then it really is a significant burden on the pathologist to have, all sections through the whole specimen. And then there's this tissue challenge, which is significant. But, once we would go for biopsy, should we go that route, I would love to have an MRI first, or at least a late enhancement gadolinium, or post-contrast a little bit later, to identify the location of the best biopsy. And if that's the case, we would always go for the area that is non-fatty or less fatty in the tumor.
And in terms of a target, that's a good target because it's surrounded by myocardium, and it's a big target.
Yeah.
the motion of the heart doesn't really bother you very much, does it?
Yeah, I mean, this makes cardiac biopsies a bit more challenging. Of course, it bothers because you can imagine on any imaging modality, whenever you take an image, the heart is in a different position. So what we would do is we would have always an ECG synchronization method available so that we obtain images preferably at the same cycle. It requires some synchronization of the active taking of the biopsy with the ECG signal. Technically challenging, but possible.
And do you ever use ultrasound or echo to do these biopsies, or always CT?
Well, I haven't used echo in this scenario, and that's an organizational divide that we have, likely in most institutions where echo is hosted within cardiology and the rest of the imaging and radiology.
Dr. Listucci, would you get a CT scan based on that echo test that he showed? He showed you a pretty nice echo. It shows a lot of movement.
I don't think that the echo is much diagnostic. So you see a mass. I think that I will ask for CT scan and MRI. There is nothing in echo that can aid in the diagnosis, I think. Maybe try, since it's on the right side, just to see if it's actually a metastasis or a second tumor. So have a biopsy. I will try to have a biopsy.
I must say that I disagree with you. Andrew, could you go back to the echo? The echo tells us a huge amount of information. And the echo shows, if you look at this echo, that is totally freely mobile inside the heart. I always get an echo on all my cardiac tumor patients because the MRI can show some movement. The CT scan doesn't show any movement. The MRI is beautiful at showing planes, but the echo, it shows you all the information you need for this tumor, I think.
Yeah,
Yeah, I think
not about the etiology, but not about, I mean, I can tell if, what is this?
Oh, you can't say what it is, but
I will try, since it's on the right side, it's easy to obtain a biopsy. I will go to a biopsy.
Yeah. Juan, do you get an echo on all your patients that you do a tumor on to see this sort of information?
No, the echo is good to see, to know if the mass is mobile or so on. So which is the risk, how high is the risk of embolization, for instance? Because this kind of mass is a high risk of embolization, for instance. So this is something we should try to remove as soon as possible. If it's possible to have a biopsy, it would be better, or go to surgery.
Okay, now
the idea is, I don't know, but this doesn't seem angiosarcoma.
No, he had a previous liposarcoma.
Yes, previous liposarcoma. So
3 times.
It probably a metastasis for liposarcoma.
Right.
The question is to be sure and to decide if try chemotherapy before trying to remove the mass, but knowing that this is a highly mobile mass and that the risk of a pulmonary embolism is high. If it were on the left side, I would say remove. If on the right side, the risk of pulmonary embolism is anyway high.
Robin, are you there?
Yes.
So it sounds like a duck, moves like a duck, quacks like a duck. Would you want a piece of that before you give him any chemotherapy? If this is a chemotherapy sensitive tumor, I have no clue.
Yeah, these types of liposarcomas, in my opinion, don't tend to be that sensitive to chemotherapy. So I would be inclined to not administer preoperative chemotherapy here. So And following on from the comments regarding imaging, I think for a lot of these liposarcomas, CT is really good. Certainly for the retroperitoneal, CT is our preferred option. But again, welcome other people's comments about this. But the bottom line is I would be inclined not to give chemotherapy. I'm interested to hear what Andrew thinks about that.
And the other question I had for you is that cardiac tumor that metastasizes to the periphery is very bad. I guess any metastasis is bad. Is a peripheral tumor that metastasizes to the heart any different than a metastasis to a lung or to another part of the body?
I suppose it's bad, but very often, we've got a lot of patients in our sort of clinic on follow-up that do develop metastatic disease, and we treat each individual metastasis when it develops. Some of these low-grade sarcomas, people can live for a long time, even with metastases in bad anatomic locations.
And if this man had multiple lesions, say one in his heart, one in his lung, and one in his arm, would you ask Andrew to remove this?
I'd probably want to have an idea of the tempo of the disease before embarking on quite major surgery. So what we would generally do in the UK is probably do an interval scan, a short interval scan, just to gauge the tempo of the process and to see whether disease develops elsewhere, if that makes sense. Because clearly, if further lesions develop, intervening surgically may not be the best way forward.
And what's the short interval mean? 1 month or 3 months?
So I'll tease you a little bit. 6 weeks, maybe.
That's good. So something
just
like
as a compromise, yeah.
Yeah. So something like that.
But of course, I'd speak to Patrick first before ordering scans willy-nilly like that. I'd just explain the rationale to the radiologist.
Yeah, one of the interesting features is they said that this was not evident on his CT scan prior to going ahead with his previous resection. But when I looked at that CT scan, it was without contrast. And really looking through it closely, there was a suggestion of a dark mass within the ventricle, but again, it was non-contrast. So it was hard to say if it was there or wasn't there. I think it was there. And clearly looking at the size of this, it's not going to pop up in 6 weeks, is it?
Yeah, you're raising a good point as far as using CT without contrast. It makes things certainly not easier. Although I would say fatty tissue is one of the few tissues that can be identified without contrast. But it's always easy to say simply because the heart is moving, you have artifacts, and maybe the focus of attention wasn't really on the right ventricle, as it usually is not still. The beauty, what I would suggest, and I am coming back to Robin's point here, the beauty of you need CT for the rest of the staging anyways for the other tumors. And then there's always the opportunity to use the same injection, the same setup, do a cardiac scan first, just move on and do the rest of the staging all in one session. That's probably the most efficient and most cost-effective way.
There's a question probably to Robin. If the patient did have histology, would that help you with respect to prognosis? Does histology, we've already partially answered this, but what would you say to that?
I think given the fact that this is the third recurrence in a way, Andrew, or the second recurrence, but third operation, I'd say it's entirely consistent with recurrent liposarcoma. But it's always good if we were going to consider preoperative treatment to have histology. But I'd say in this case that it seems consistent with liposarcoma, recurrent liposarcoma.
Okay, great. Andrew, carry on.
Okay. So then the guy was presented again at the sarcoma multidisciplinary meeting, and they felt that the most appropriate and expeditious approach was to operate on this tumor. Again, because of that initial feeling that maybe it wasn't present previously, and it was a fairly fast-growing lesion within his right ventricle. But so they presented him and felt there was no indication at that stage for pre-operative radiation or chemotherapy, and so we operated on him on the 2nd or 3rd of November it was that year. So he was still really recovering from this hemipelvectomy. He'd had a bowel obstruction that was really only just settling down, and I sort of kept a few dates available for him in case he needed to wait a bit longer. But so this was 5 weeks after the hemipelvectomy. So it really wasn't a long interval between the two major operations. So I opened the right, so we've opened a stenotomy for those who aren't surgeons. He's got bicaval cannulation, so a cannula in the superior and inferior vena cava. And the reason for that is to allow us to open up the right side of the heart without entraining air into the bypass circuit. We have intermittent cold blood cardioplegia, and I would usually use antegrade and retrograde, and I can't see the retrograde cannula here, but I think that that's probably what I did. The cross clamp is applied. The heart was opened along the line of the right ventricle, and I've also opened the right atrium because initially to see if we could resect it through that access, but that was clearly not going to be the case given the size of all of this. So we've opened along the line of the ventricle. This is the tumor coming out here. There is on the next slide, this appearance here, we could see on some of the imaging, and I was sort of interested to see why, but this structure that you can just see through there is some of the subvalvar apparatus of the tricuspid valve. And so that's where one of the cords for the tricuspid valve was then passing. And so this tumor had grown around the subvalvar apparatus, and it was definitely attached onto the anterior portion of the apex of the right ventricle. So we resected the tumor. We got into the cavity and around the tumor and resected the portion of the ventricle to which it was attached. I did try to reimplant this cord for the tricuspid valve, but found that it just wasn't. The tricuspid valve isn't a valve that the cardiac surgeons operate on a great deal in a reconstructive way. And so this was sort of somewhat out of my comfort zone. And I think I ended up removing this and sending that for pathology as well, and then putting in an artificial cord and probably plicating the leaflets a little bit to affect normal sort of function in that tricuspid valve. So that's the end result of my tricuspid valve repair. And then we're faced with reconstructing this reasonably large and ugly hole in the ventricle. And I had taken a fair amount of the ventricular wall out at the apex. So I elected to use what we call bovine pericardium, which is a treated product, glutaraldehyde treated pericardial product that is very strong and quite able to repair different portions of the heart. Interestingly, RJ, my time at Toronto General helped me be very sort of comfortable with this product, and this is something I use quite a lot of. So the ventriculotomy was closed, and then the patch here on the left is incorporated into the apical repair down there. And so that was the repair. If we wanted to have any questions or have some commentary there, RJ.
Did you get a coronary angiogram before you started? Did you get a coronary angiogram on all your tumor patients? Is what's why I'm really asking.
I think in this case, we did not. I was looking for it earlier. No, we normally would if it were more elective, but I think in this case, as I said, we didn't. Sorry,
you were elected to repair the valve. I would just have changed it, but that's just, you know,
Yeah.
tomato, really.
Yeah.
You try to.
I don't think it would have made a difference. So I was trying to find out, as I said, this was back in November 2018. I was trying to find out if the patient was still alive. And I haven't heard back from the two doctors who would normally be looking after him.
Yeah. How much of the heart did you take as a margin in terms of come right up to it, or did you take a little bit farther?
I tend not to, when these are in the ventricle, I tend not to take a huge margin for various reasons, mainly because you don't want to be leaving a patient without any functioning myocardium in the various chamber. So my margin was really close. I've got the histology here on another computer. So the pathologist hasn't sort of mentioned.
Were you able to see it from the epicardium, or was it the metastasis into the myocardium?
No, it was just within the myocardium, and it had attached itself there. It wasn't really able to be taken out. It's not like it's just grown into the trabeculations. It was definitely attached to the myocardium in through here, but it didn't come through the epicardium, and histologically it didn't come through the epicardium either. I think within 3 millimeters of the apical margin.
Yeah, that's good. You know, the thing I've noticed with these tumors is when they metastasize to the heart, I have a nice picture that it's I used it in an article that we published about cardiac tumors with Mike Reardon. It was at the time it was a melanoma. They tend to metastasize to the heart, and they tend to expand so that the actual myocardium that you resect isn't that much in the end. It seems as though it's a lot, but it's not very much. So your loss of ventricular wall, I give a lecture about this sometimes, loss of ventricular wall sometimes is not as much as you think, because it metastasizes and it sort of spreads out the tissues between it. You can see, for not just for Andrew, he knows this stuff, but for the students in the group, this man, you'd expect to have a myocardial resection, and you expect the patient to be, I don't know how he did, but you expect him to have poor cardiac function afterwards. But by removing such a big mass from the ventricle, you restore ventricular volume. So the stroke volume will actually go up after the procedure than it did before, because you've taken something out of the ventricle. And the myocardium is non-contractile in that area. And so when you remove that, you remove non-contractile muscle. So the cardiac performance should actually be good, and you would expect this patient to really not have any problems coming off bypass. I don't know if it's true or not, Andrew, but that's the general concept about removing cardiac tumors.
Yeah, so he came off bypass reasonably well, RJ, as you anticipate. I think we ran him on a bit of low-dose milrinone and some norepinephrine for a few hours, which is more as a routine than anything else. I'd usually have the intraoperative echo in my notes, but I don't have that today. So he actually did reasonably well. He was able to be discharged to rehab about 9 days after this procedure, and came back to see me 6 or 8 weeks later, and was actually doing better than I thought he would have done. He was quite good at that stage, and I think was then going off to have some adjuvant treatment thereafter because of the pelvic and then this tumor almost concurrently. So that's
Fred, can I ask?
That's really all I have for this patient, I'm afraid, RJ.
Well, I think it's a good case. Federico, are these radio sensitive?
I'm sorry. Yes, the myxoid liposarcomas is particular radiosensitive disease. but also from a Strass trial in retroperitoneal sarcoma, the best histologies which benefit from radiation is low-grade liposarcoma.
So this
in particular,
myxoid.
myxoid liposarcoma is particularly radiosensitive.
Right.
Well, that's good. Anybody have any more comments? I think it's a very, very good case. Congratulations, Andrew. That was a big, big tumor that you took out. And
Yeah,
well,
yeah,
it's a scary
it
tumor.
was a big one.
Yeah, that's good. All right.
All right.
No, nobody has any more comments? Maybe we'll move on to the next session then. Dr.
Thanks for
Navaria
your
is
time,
here.
everybody.
Say that again.
I'm just saying thanks for your time and thanks for listening.
Oh, you're welcome.
I'll stop sharing, I think. Oh no, I've already stopped
Really
sharing.
nice case, and you were clever also because it's not an easy surgery, I think.
No, not easy, especially because it's not something that you have to think about very often either. So it's it is an interesting sort of thought process preparing yourself for an operation like this, isn't it?
And poor patient, because it's really it's, after such a long history.
Yeah, big, huge interventricular sarcomas or big, huge interventricular tumors, especially ones that metastasize and involve the muscle of the myocardium, are very, very scary for surgeons to take on. But there are a few principles, as I suggested, that make it not as scary as it can, as long as you remember those. Doesn't mean it's easy, but it can be done. But you need specialized hands, specialized centers. That's what we're talking about.
My apologies, I was called away for a second. Forgive me, I missed the last part. So what was the histology in the end?
It was a myxoid liposarcoma.
Oh, so it was metastases.
Yes, yeah, sorry, metastatic myxoid liposarcoma.
Yeah. And I suppose the anatomic position of the metastasis would be consistent with a myxoid liposarcoma, which can metastasize to unusual places. Myxoid liposarcomas, in comparison to, I suppose, to retroperitoneal liposarcomas, can respond to chemotherapy, whereas the well and the dedifferentiated, the low-grade, well-differentiated liposarcomas don't tend to respond to chemotherapy.
Great.
Interesting case.
Yeah. It's interesting that the low-grade ones do respond to radiotherapy. That's very interesting.
Yeah, as Federico said, that was in a way, Federico, it was a subgroup of the Strass trial, wasn't it? And in retrospect, the design of the trial could have been different if we had more information about the different types of retroperitoneal sarcomas when the trial was designed.
Yes, of course. But from Strass trial, if we used the data of Strass trial, we have seen in a multivariate analysis that the major benefit in liposarcoma histology is as a response to radiation is in the low grade, and while high grade liposarcoma are no benefit from radiation because an high metastatic potential.
Yes, indeed, indeed.
All right, Federico, do you want to start with your case? Would you want to start sharing?
Yes, of course. Can you see my presentation?
Yes, you just have to enlarge the presentation to full screen.
Because I have a problem to scroll my slide.
Matt, do you have his talk? We can see whether we have it locally.
Do you want me to share your talk from my end?
Do you want us to show their talk from here?
Yes, please. Yes.
You can just say next, next, next.
Okay.
Okay, give me 1 second.
Thank you very much.
I've given you remote control, so if you click on the screen now, you should be able to advance the slide yourself.
Thank you very much. So I just said before, I'm very honored to be here with you, and thank you to Dr. Cusumano for introducing me and my presentation. So the topic of my presentation is heart inoperable mass treated with radiotherapy. So I'm going to talk about 2 clinical cases of unresectable cardiac mass treated with the radiotherapy at our institute. Next slide, please. So the first one is a 54 years old female with good general condition, only hypertension as a pathology in pharmacological therapy. Her medical history started in December 2016 with retroperitoneal mass detected by CT scan due to abdominal pain, and she underwent resection of retroperitoneal mass in other hospital, and histological diagnosis was leiomyosarcoma grade 2. She underwent in another hospital Neoadjuvant chemo with the 6th cycle of gemcitabine and dacarbazine, and the next restaging CT was NED. Next slide. She relapsed in November 2017 in the right inferior abdominal wall with soft tissue nodules, which was removed. Then CT scan and PET-CT performing in June 2018 show a new relapse, always in soft tissue, which was in other institute treated with SBRT, 54 grain 6 fraction in one and 48 grain in 6 fraction in the other. Then she relapsed again with plurifocal recurrence disease in the lungs and in subcutaneous nodules, and she started second-line chemo with doxorubicin and dacarbazine with partial response. In this setting, patient was managed in other hospital. In January 2020, she underwent SBRT on progressive pulmonary nodule and surgical resection of subcutaneous nodule. Next slide. Interestingly, as restaging CT on February 2020, there was evidence of progressive disease in 3 pulmonary nodules. In the was appeared a nodule in the left kidney, but important appears nodule in left ventricular site, and a cardiac MRI performed on March 2020 show this pericardial exfusion with a round mass in left ventricular cavity, 24-17 for 50 millimeter with a necrotic area. But important, patient started to be symptomatic for ventricular frequent ventricular arrhythmia, and amiodarone therapies was started. Then patient was referred to our institute. Next slide. We manage a patient with our colleagues of Oncologic Veneto Institute of Padua, and patient was managed with at Croaviano at our institute for radiotherapy and cardiology with Chiara Lestuzzi and me and my colleague in radiotherapy, and in Padua for medical oncology. We share case with our colleagues of Padua, and due to progressive disease at in lungs, cardiac, and kidney, we decide to start chemo with trabectedin. But we consider, because patient was symptomatic, we consider therapy, a local therapy on cardiac lesion with radiation. Patient started trabectedin, and the second cycle of trabectedin, we start volumetric modulated arc therapy with image-guided radiotherapy on cardiac mass, 44 gray in 22 fraction, and simultaneous integrated boost to gross tumor of 55 gray. As Dr. Lestuzzi has said before, radiotherapy, cardiac radiotherapy is a challenge due to the critical site, but also for the lung motion, cardiac motion, and lesion motion. So we have integrated for radiotherapy planning. In radiotherapy planning, we have integrated the echocardiography to study and consider lesion motion with basal cardiac MRI and cardiac CT, as well as respiratory motion by means of simulation CT with respiratory gating. Next slide. We obtain a PET CT of patient that we have fused with a tax simulation, and also with tax simulation with respiratory gating, and with the cardiac MRI and cardiac CT to better define the target volume. We defined our target area. Next slide. We have defined the target area PTV1 in blue, this one, and PTV2, the simultaneous integrated boost, using the movement of echocardiography. In this slide, we can see the PTV and the cardiac structure, and fuse with the simulation CT. Next slide.
May I ask a question? May I ask a question? Can you go back to that last slide?
The mass?
No, this one here. This one here. Are the red things in the soft tissue? Do you think those are metastases, or just what do you think those are?
This is metastasis of
the soft tissue.
Arthur, you mean in the other ones, in the bones and soft tissue?
Yeah, the bone and soft tissue.
This is not a PET. Just the yellow one,
it's not a PET. That's not a PET.
The red one. What are the red one?
The red one is a cardiac metastasis in a CT PET fused with our CT simulation.
So what I'm asking is that are those things, do you think in the bones she has multiple mets in her bones?
No, no.
Soft tissue?
No. She has only 3 nodules in the lungs, 1 nodule in the heart, and 1 nodule in the left kidney. So we decide, because she has metastatic disease, she has to start chemo. but because she was symptomatic to the heart, because she have frequent ventricular arrhythmia, we decided to local treatment, and we decided to use the radiation for heart lesion. And so to better define the volume, we fused the PET CT with our TAC simulations, with our CT simulation.
And did you give this before the chemotherapy?
Yeah, I don't understand.
Did you give it before the chemotherapy? Did you give
concomitant with chemo?
Yeah, well, here's the problem.
At the same time?
Same time. Because you gave the chemotherapy, sorry, you gave the radiation because of arrhythmias.
Yeah.
Would you expect the arrhythmias to go away with chemotherapy, or why did you use radiation? Just because to get it faster?
We use the combination with trabectedin because trabectedin is active in the metastatic lesion in the lungs and in the heart and in the left kidney, but also trabectedin has a radiosensitizing effect. Yes. So our goal was treated her with using the radiosensitive effect of trabectedin that cover also metastatic disease. This was our discussion with Dr. Lestuzzi and Padua medical oncologist colleagues. Next slide. This is another example of fusion of CT stimulation CT with the respiratory gating and CT PET. Next slide. This in the same planning we have fused also basal cardiac CT. Next slide. And as I said before, to define the expansion of our target, because a cardiac lesion move during radiotherapy, we use the integration with echocardiography that Dr. Lestuzzi made, and the total movement of lesion is 14 millimeters. Next slide. This is our radiotherapy planning. We can see in the first figure the optimal coverage of target at the isodose of 95% of the prescriptive dose. The second figure, you can see the isodose of 50%. So we can see the optimal spare of surrounding cardiac structure, left ventricular, right ventricular, right and the left atrium, and spine. And in the last figure, you can see the histogram dose volume with the optimal coverage of the target. Next slide. During the radiochemotherapy treatment, we perform a daily electrocardiography and Holter in the first week, always negative for arrhythmia. So, with Dr. Lestuzzi, we decided to perform weekly Holter and electrocardiography with the medical examination blood test. Next slide. After the side effect during radiochemo, the principal side effect was nausea grade 2, grade 3, but controlled with antiemetic therapy, anemia grade 1, and asthenia grade 1. So treatment was well tolerated. In June 2020, after radiochemotherapy, cardiac MRIs show the stability of the metastasis in left ventricular cavity. there was a good hemodynamic compensation with the left ventricular ejection fraction 65%, but there were no more episodes of arrhythmia, and so we decided to stop amiodarone. Next slide. This is a CT, angio-CT, cardiac CT performed in July 2020 and in February 2021 when patient continuing trabectedin. Next slide. Currently, from October 2020 and September 2021, she had progressive disease in distant side, but always in a few side. So we can consider a slow disease, a very slow disease. And she underwent SBRT, chemo, and other surgery. Dr. Lestuzzi visited the patient in January 2022, and she has progressive disease in distant site, small fibrotic area in left ventricular wall, but no episode of arrhythmia, and she is free from amiodarone. Next slide. The second case is a 66-year-old male, former smoker.
Perhaps we can stop and ask for comments about the first case so we don't forget the first case.
Okay.
Okay, so it looks as though, can you go back to your slide? The tumor there looks like it went away, but on CT scan, did it go away or no?
Sorry, the CT scan?
Did the tumor regress in size? Same size?
During treatment, the last CT scan detected a small shrinkage of a tumor, but at the echocardiography of Dr. Lestuzzi documented a fibrosis of nodule.
And
correct?
Actually,
Yeah.
okay, actually, I saw during the treatment of the radiotherapy, the echogenicity of the mass changed. So, and this is, we have seen this before in other tumors. So the mass maybe doesn't change so much in size, but it changes in echogenicity and evolve to fibrosis. I think that she didn't have a CT scan with cardiac synchronization, allowing exact analysis of the cardiac of the ventricular metastasis, because at echo it disappeared, and actually it's just a hyperechogenic part into the myocardial wall and the left ventricular wall, and so it appears to be fibrotic, but in this case, I just looked with echo because the CT scan was performed mostly for evaluating the lung lesions. So maybe if you have a CT scan not synchronized to the ECG, the mass may seem larger than what actually is. Because in echo, I have no doubt that it's gone.
The reason I asked that for is because sometimes the person will have an obstructing tumor, and you showed in your talk how the tumor essentially melted away completely, and that's a complete response. And when you have a response, do you ever see it? For instance, the last tumor we saw in the heart was a big, almost filling the whole right ventricle. If you were to irradiate that, would you expect it to go half away, a quarter away, 3/4 away, or all the way? I mean, complete response is all the way, but you say that sometimes you don't get much loss of the actual volume of the tumor, but you get a difference in the quality of the tumor. Is that correct?
Yes. Yes. It's difficult, but anyway, I think that as in the case we have published with right ventricular metastasis for mantle-sarcoma, also in that case we saw a worsening of left ventricular arrhythmias as soon as the tumor started to grow up. And we saw an increase in ventricular arrhythmias when the size of the tumor was still the same, but the uptake at the PET was increased. So maybe in these tumors, there is not only a mass effect, but also some activity, something produced by the tumor that is induced arrhythmias. So in this particular case, after removing the amiodarone, the lady is still free from arrhythmias. And also when we started trabectedin, her arrhythmias were still worsening. This was one of the reasons why we decided to go with radiotherapy on that lesion, because the risk of arrhythmias.
If she had any more tumors in her heart with the metastatic disease that she has, obviously you're not going to operate. But if she had a tumor on, say, the right ventricle distant from that tumor, would you irradiate the rest of the heart, or is that enough radiation for her whole heart? Based on your gradient, based on your X-ray gradients, radiation gradients.
But
do you understand what I'm saying? You gave this lady radiation to the free wall or to the apex of her left ventricle, correct?
Yeah.
Yes.
And so would you give a radiation to other parts of her heart too, or is that finished?
Yes.
Yeah.
Yes, yes.
The gradients fall off very rapidly, do they?
Yes.
Yeah. Okay. And then the final question I have is, go ahead, you want to answer?
Yeah, and what was the goal of planning the radiation was to spare the interventricular septum. This was my, I expected to have some adverse effect on the free wall, but the important thing was to avoid radiation of the septum. In fact, in the plan, the interventricular septum was always spared. Actually, the ejection fraction is normal now, but the global strain is altered in this patient. So this is not a normal heart. There is something that is gone, but it's like
cancer in it.
all the myocardial infarction, not a transmural myocardial infarction.
And can you tell us again how you use the echo? I mean, you show the motion of the heart. You don't gate the radiation to the heart, do you? It's not gated radiation.
No.
How do you use the echo again? I didn't quite understand how you use that.
We try to obtain, I suggest I show the moving, and they try to have the tumor be within the radiation field throughout the whole movement. Putting
I see. So you tell me it moves this much.
To avoid that a part of tumor goes out of the radiation field. So in this particular case, to keep the radiation field a few millimeters from the interventricular septum, and try to see through the cardiac cycle how long the mass stay in the radiation field.
Right.
It's not a simple task.
No.
In radiotherapy planning, we define the target always with Chiara, with the integrated the data of echocardiography for expansion, for give the expansion of volume.
And how long does the beam stay on when you turn on a beam per day?
How long is the radiotherapy delivered?
Yes, per day, each day.
Each day is a patient 22 fraction, and every day the therapy is about 14 minutes.
That long?
Yes, 15 minutes.
Yeah. Okay.
Because every day we perform an image guide radiotherapy for setup patient, and totally are 15 minutes. In tomotherapy is more long, also 20-25 minutes.
Wow. And in this patient, you used chemo, you used the radial sensitizing agent, which also acted as an agent specifically for the metastatic disease. If you didn't have metastatic disease, do you normally use radial sensitizing medications?
Generally, we use, in this case, the combination with trabectedin.
In this case, but what about in a case where they don't have other metastatic disease? Do you always try to use a radial sensitizing drug?
No.
Just coincidence here.
But there is not much literature about the use of radiosensitizing agents.
Yeah, that's why I asked the question.
We use the trabectedin because we have data in soft tissue sarcoma from TRUST trial. TRUST trial is a trial of a combination of trabectedin and radiation in soft tissue sarcoma of extremity and trunk, superficial trunk, but also the cohort B explore the combination in lung metastases. So in this case, the combination, according to the patient, was to control metastatic disease. In particular, the radiosensitizer effect is for cardiac lesion, but we decided to take patient cover of metastatic disease during radiotherapy treatment, because in during radiotherapy treatment, patient disease could spread.
Yes, actually, we have, when Dr. Navaria was not working yet, many years ago, we had a case of angiosarcoma infiltrating the right heart, which had poor response to chemotherapy, and was stable, as a stable disease, not reactive. So we tried radiotherapy, but during the month of radiotherapy, we stopped the chemotherapy, and he developed brain metastasis and died 1 month later. So the problem is, if you have a metastatic disease, not to stop the chemotherapy for the metastasis in the months you need for radiotherapy, if it's not a contraindication, because sometimes maybe chemotherapy may be contraindication. So and there is nothing in the literature stating what is better. This is one of the reasons why I'm very happy of the project of Interact, because we need to put together all this experience, because we made a personal plan time after time in each patient, and each patient was different from the others.
Yeah.
Another thing, we choose trabectedin in this case because we know that trabectedin is active in L sarcoma, lipo, and leiomyo. So she just underwent to dacarbazine and doxorubicin. So the third line, because the trabectedin in this case is a third line therapy, is third line chemo, was safe with concomitant radiation. So this is another this is the principal thing, because we have chosen trabectedin.
On the other hand, if the first choice of chemotherapy was anthracyclines, as is in many sarcomas, I wouldn't use anthracyclines together with radiation therapy on the other hand, because we know that the two together are much more cardiotoxic. So you have to balance the risk of metastasis, the risk of adverse effects, and to choose according to which is most appropriate chemotherapy for that particular tumor. And sarcomas are really a world of tumors. There is no standard therapy.
Okay, thank you. Carry on.
So case 2, the second case is a 66-year-old man in good general condition, former smoker until 2000. His medical history started in January 2018 with the diagnosis of non-small cell lung cancer, CT2-CN2. He started chemo with the platinum plus pemetrexed for 3 cycles from March to May 2018, but for progressive disease in May 2018, he stopped chemo and started atezolizumab. And in June 2018, he underwent mediastinal radiation to a symptomatic lesion. Next slide. In October 2018, a PET-CT showed a partial response, in particular a regression of uptake in nodule lungs, but a new uptake in hepatic site, adrenal, bone, and a small uptake area in the left ventricular wall near the apex. But at the echocardiogram performed on December 2018, there were no abnormal kinetics corresponding to PET uptake. On February 2019, he complained dizziness when standing up and palpitation, and was admitted in different hospitals with dizziness and ventricular arrhythmia. At echocardiography, detected atypical masses in the left ventricle, and with differential diagnosis between thrombus or metastasis. And the CT scan show a large mass in the left ventricular with infiltration of the left ventricular wall, mediastinal metastasis near the pulmonary artery, liver, and adrenal metastasis. Cardiac MRI confirmed the left ventricular mass, suggestive of neoplastic disease. Next slide. At CT scan, we can see the mass in left ventricular wall. Next slide. Also, MRI, cardiac MRI, show the mass in ventricular, the left ventricular wall. Next slide. Next slide. This is an MRI that we use to perform radiotherapy planning. Next slide. But patient was referred to our institute in cardiac surgery, and it was operated on April 2018. But at surgery, the mass was nearly double compared to the beginning, and the histological diagnosis revealed a high-grade spindle cell sarcoma. Next slide. So patient was referred at our institute. In our team sarcoma, because a patient at the beginning of his diagnosis was managed at our colleagues who treated non-small cell lung cancer. This is Dr. Lestruzzi echocardiography that show progressive disease, a regrowth of tumor after 1 month. Next slide.
Can I ask a question? And I'd like to ask Robin Jones what he would do now.
Pardon me?
I want to see if what would Robin Jones have done after the first tumor? Would you have sent him to the OR? What would you have done?
Yeah, I think I really like the approach that
Small cell sarcoma, a small cell, of his lung. Now he has something in his heart.
I think we have a very similar approach. Going back to the can you hear me?
Yes.
I really liked your approach to the previous case using trabectedin and radiation together. And I think that's something that we don't do often in the UK. And I think that you illustrated the case really well there, and the benefit of using that multidisciplinary approach. So that's really sort of struck me, and I think it's something that we should consider more often. So I really like the way that you did that, and we probably would have approached that slightly differently. I'd say in this case, we would probably have treated in a similar way, basically.
And what about now? What would you do now that he has this recurrence so quickly?
If there's a rapid recurrence, we'd usually consider alternative systemic therapy in a way just to gauge the tempo of the disease, and then consolidate with local therapy. But again, I think the context can be challenging, but in general, that would be our principle, to try and consolidate with systemic therapy with another local approach.
Yeah, actually, since I've followed the patient, actually I was against surgery, because the problem was that the patient was already on immunotherapy for his lung cancer. And the mass, in my opinion, was unresectable. In fact, the cardiac surgeon did just the debulking. Just the debulking, and when unfortunately, the patient was not in our hospital, was in a different hospital, and they decided to operate, thinking that a debulking was something useful. And then I would have pressed to have a biopsy in this case, in this particular case, because the clinical history was not consistent with a lung metastasis. It was very strange because the lung lesions were growing slowly. This patient had an echo in December and was made by myself. Probably I made a mistake. I missed a very small mass, but the mass grew so quickly in 2 months while he was still under immunotherapy for his lung tumor. And this was strange because the other metastases were not growing so fast. So we didn't think actually to a second tumor was strange, but anyway, there was something strange in this patient. And try the bulking. I think that the bulking was is always without any sense. So I think I would have done. I personally would have suggested a biopsy, maybe a mini invasive biopsy if it's not was not possible, and to think with a biopsy with a histologic diagnosis. Is this why in the other case of the metastasis of liposarcoma, I said I will look for a for a biopsy if possible, because you never can say.
Yeah, that's a really good point, Chiara. That's a really, really good point. And I've had patients with metastatic disease previously, where, as you say, the clinical, the scenario doesn't quite sit, it doesn't make sense. And I've gone back and done a biopsy, and something completely surprising has been found. So I fully take your point.
When you found, did you get this patient at this time, Chiara, or when you first did the operation? In other words, were you planning to give him some systemic therapy, but this grew so fast?
I saw him the first time when the first PET was observed in December. And I saw him at the beginning of January, and I didn't see anything strange in the heart. So I looked carefully to the cardiac apex, and I didn't see anything. And now I apologize and I blame myself because I had to ask for MRI. Now thinking I made a big mistake. I had to ask also for MRI because there was an uptake near the apex, and it was suspect, and I was happy for the patient to don't find anything. When the mass grew up and he had dizziness and syncope, he went in a different hospital, and they didn't ask me my opinion. They followed the patient and they decided to send the patient to the cardiac surgeon. Actually, I presented this case before surgery at the cardiac tumor board, and when I said they are decided to send the patient to the cardiac surgeon, I remember Dr. Riordan jumping on the seat and saying, "Why?"
Yeah, I said the same thing. I remember.
and this was the mistake of it was a heart team composed by cardiologists and a surgeon who never, without any experience in malignant tumors. Maybe if were another cardiac surgeon with some experience, would be. So I saw the patient later after the surgery.
And you were planning, in addition to radiotherapy, to give some systemic therapy as
and,
well?
and we planned the radiotherapy this way. I heard of the patients by some colleagues, but not unofficially, and they said, my first suggestion was to have a biopsy or anyway to make a radiotherapy.
Yeah.
Because it was a huge mass, not resectable. Why try debulking? This is in a rapidly growing mass.
You can consider debulking or a biopsy, an open biopsy.
Yeah, because the problem with this mass that it was not the first finding.
Yeah.
We knew that the mass was very small at the beginning of January and was very large at the beginning of March.
Yeah.
So in 2 months, and this is why I said, okay, it's a rapidly growing mass. Maybe it's a metastasis. Okay, go ahead with radiotherapy. And they also lost a lot of time doing the preparation for surgery. They lost, so it was the typical case of driven by cardiologists and cardiac surgeons without experience in cardiac tumors. Another team would have done something different.
Chiara, can I ask you just one question? How was the collaboration done with medical imaging in this particular case? Was it done a CT scan? I don't think you have shown this. Was it done with contrast, without? Was there a formal report? Just understanding how this collaboration would have potentially prevented from us from, or you from you know, a delayed response.
Was a problem, because I had an unofficial news about this patient by some colleagues, but the top decided not to share the case with me.
Okay.
This is what happens sometimes. It's a hard thing. I will explain you in private.
No need.
It was really something disappointing for me, because I know we are in a small region. We see, and it's always disappointing when you give a suggestion and the suggestion is not followed because it's not.
No, I hear you. The point I'm trying to make from the imaging point of view is, and I think that is of value for those who want to know how to image those cases, is we do have a pressure for imaging without contrast material, and it comes from the fact that there are some rumors it could damage and kidney function, etc. The reality is, I mean, this is an extreme case and it's a rare case, but for those who set up imaging protocols, it is a true fact that if we compromise on the technicality of how to image patients, we run an increased risk of catching those important and sometimes unexpected findings. And that's an important message I would like to bring across. If a cancer patient is to be staged, we should actually do the best we can, because those cases will otherwise slip through.
Yeah, in fact, I think I believe in collaboration. So I don't say this patient must be undergo, as when Dr. Cusimano asked me, will you make radiation therapy on the relapsing tumor in the atrium? I said, okay, if there is no surgical possibility, I will think to. I think that is like a puzzle. Everybody must put his little piece and put the puzzle together. And I have so if I ask to one radiologist to have something, a few days ago I asked a radiologist to have a CT scan for a particular problem, and he did is best. I had a patient with myocardial metastasis close to the descending anterior descending artery and coronary artery, and I asked a CT scan with, to see how much the metastasis was compressing the coronary artery, and he did for me. So this is a good collaboration between physicians. The problem is the cooperation between institutions.
Yes.
And this is the big problem. If one institution says, no, we are the best, we don't want lessons from others, this is this is what the patient doesn't need. The patient needs the cooperation with humility also from everybody.
Yes, the problem in this patient was that he started the oncological therapy in our institute, but for symptomatic heart disease was managed in other institute. And then when after cardiac surgery operate patient and the histological diagnosis was sarcoma, he come back to our institute. And with Chiara and our colleagues of multidisciplinary tumor sarcoma tumor board, we decided to treat the recurrent lesion with definitive radiotherapy with conventional fractionated. And as I previously said, we consider the cardiac motion, echocardio for cardiac and lesion motion, integrate with cardiac MRI and cardiac CT, the PET, but also the CT with respiratory gating for respiratory motion. Next slide. This, Chiara, if you want to comment.
Yes, this is just one slide. It's not the best one, but we use also in this particular case a 3D echo to show the movement of the mass to better understand, even if normal echocardiogram may be enough. This patient, unfortunately, had also both a poor cardiac echocardiographic window and a poor vision of the tumor, because you see the tumor is a low echogenicity. If you see on the left, it's hard to say the mass, which was really large, but it's maybe confused with normal echoes. The 3D images were helpful in better visualization of the mass. Okay, this was just one of the things are put together in the planning.
Next slide. For this patient, we decide to treat with not with volumetric arc therapy, but with the tomotherapy. In this treatment, Dr. Cusimano, the treatment is about 30 minutes. 30 minutes long, and we decide for conventional fractionation of 45 gray in 25 fraction with a simultaneous integrated boost of 55 gray. We can see a two-dimensional reconstruction of target. In the second figure, you can see, we can see the PTV in red, the PTV, the gross tumor volume and PTV 55 gray, and in the blue line the large PTV 45 gray in 25-day fraction daily. Next slide. This is a radiotherapy plan with the ISO dose of 95% of prescriptive dose of 54 gray. Also in this slide, we can see the spare of surrounding cardiac structure. Next slide. And this is ISO dose of 50% of the dose prescribed, so 22 gray in blue. Next slide. At the restaging patient, we have monitored patient always during treatment with the alter weekly echocardiography and weekly medical examination and blood test. At the echocardiography after radiotherapy show an action fraction of 65%. The CT PET performed in July showed no uptake of a cardiac mass, with minimal uptake of ventricular wall. Next slide. We can see the response, metabolic response of a lesion after radiation at the PET-CT. Next slide. At the restaging, patient restarted atezolizumab, and at restaging in October, echocardiography show no change in mass size, and the PET-CT show a small uptake in the area of heart of surgery and radiotherapy. And the echocardiography of February 2020 reveal a hardly visible mass. Next slide. Patient had progressive lung disease to the bone, brain, and lungs with atezolizumab, and he underwent palliative radiation and died in January 2021 for progressive lung disease with regression of cardiac disease. Next slide. Thank you for your attention.
I really enjoyed that discussion. I really did a lot. I think that's, you know, if we get this Interact going, and I hope that we do, and we get enough patients around the world in a short amount of time, I think it'd be wonderful. You oncologists know better than I do, and the radiation oncologists know better than I do. It might be a good thing to do a randomized trial of radiotherapy versus surgery, even for the primary tumor, radiation versus chemo versus surgery. It'd be quite interesting to see that. Anyway, does anybody have any questions? I've asked a lot of questions, and I'm sorry if I bore people. Anybody have any questions from the audience?
Those are fantastic cases.
Yeah, they're great.
All of them. The last one was really challenging.
Yeah, you know, I
really
tried to choose the cases so that we'd have a wide variation of cases to have learning points at every step. And I think all of the speakers who presented cases, I think, filled that to the brim.
Indeed, yeah.
All right, well, that's great. It's time to end the meeting. It seems that we just started, but it's been many hours that we've been going here. And I thought personally that it was a great meeting. I'm a little bit biased because I've gotten all the speakers and done all the topics that I'd like to have, but I think that we started with a great overview, I thought. We thought it aid an overview of cardiac tumors, what's known and unknown, and show that we really know a lot less than we know, but there's a lot of, that's good in some ways because it gives us a lot of targets to aim for in terms of knowledge. We heard about the challenges, both in a global scale and what we need to do to get an international registry going. And we heard of some of the challenges, some of them financial, some of them not so financial, about getting whole continents together and countries together and things like that. I think it's really good. We learned a lot about radiotherapy. I learned a lot about radiotherapy. Perhaps one year we can have a cardiac tumor conference solely on radiotherapy. Next year, I'd like to have the whole conference on chemotherapy, if you guys think it's appropriate to do that. But I think it's reasonable for us to talk about different therapies about this. So I learned a whole lot. There's a lot of, there's not that much in the literature that I found really about radiotherapy. So I think it's good. I agree with Robin Jones that we had phenomenal cases that really brought out a lot of teaching points. And I'm really happy, Robin, that you in a very high level area took something away from this conference that may change the way you think about things. And that's the whole concept of the international collaboration and it's not only international collaboration amongst colleagues, but it's multidisciplinary international collaboration that's going to get us where we want to go. And I think that's been my goal for the whole conferences, all 7 conferences. I've had multiple specialties, and I'm glad that people like Patrick Wogala, who really is an international expert on all this sort of thing, available with us. And thank you very much, Patrick, for staying for the whole conference. You should get an award for that, as should Robin and everybody else who stayed. So I think that it's been a very fruitful and a very educational meeting, and I hope you have as well.
Rajay, let me make one comment, because one of the drawbacks of online conferences, despite all the beauty of international all at the same time, would be impossible to do otherwise, is the lack of an applause from the audience. And I think you do deserve a big applause for organizing, bringing us together. I can speak of my colleagues. We all learn from you. We learn from this collaboration. And I cannot re-emphasize enough how important these conferences are and that you started this. So thank you very much on behalf of all of the whole audience. So to speak.
Thank you very much. I'm really happy to see how many people stayed right to the end. It really makes me very happy. All right. Well, until then, thank you very much. Don't forget that you can apply for accreditation. Here in Canada, we have to get a certain amount of accreditation, and this is a small amount, but it's still worthwhile to get something more than the knowledge we take away. And if you have anybody who didn't see it or you didn't see part of it, you can always send them back to the website, and they can look at the YouTube or the Facebook feed for the rest of the year. And then subsequent to that, all of these sessions will be on the Toronto Cardiac Tumor database, Toronto Cardiac Tumor website as an open resource for people to go to learn about things. So thank you very, very much, everybody, for coming. Thank you very much.
Thank you.